Good morning, everybody. We're going to get started. My name is Kristen Rogers. I'm one of your moderators this morning with Barrett Crowther, who's sitting in the front row from the University of Colorado. I want to make sure that everybody has taken the time to sign in to your iPads, because we will have a number of audience response questions throughout the presentations this morning. So just make sure you're signed in and ready to respond. I'd like to introduce our first speaker this morning. We have Leo Riella from Brigham and Women's. He will be presenting an overview of the immune response to transplants and immunosuppressive targets.
Thank you, Christine. Good morning, everyone. Second day of our boot camp. This is one of my favorite talks to give because it goes back to the essence of transplantation and talking about what are the exactly immune response components that drive rejection process and how we developed all our drugs in terms to control the immune response. So we're going to try to cover three main objectives, and we're going to go, with some very basic concepts all the way to some clinical concepts, and you get more kind of in-depth discussion on the following talks along the day. So we have some immunology boot camps that will talk more specifically about T-cell development, differentiation, B cells, and as well as antibody. So how does the immune system recognize a transplanted organ? What are the main components of the immune response against the allograft, and what are the immune mechanisms involved in graft injury? So those are the three main objectives. So if you get an organ transplant here, a kidney transplant, what is exactly that the immune system is recognizing as foreign and is activating and leading to an immune response? So among all the polymorphic molecules that we have, the one that's most different between individuals is the human leukocyte antigen. So those are, those receptors present in all cells, the class 1, or in antigen-presenting cells in class 2, and they are responsible for presenting new peptides to the T cells and B cells. And, why is this, relevant to transplant? Because if you put on an array all proteins available in the human body, these are the ones that are going to be most different and therefore the greater potential of driving an immune response. We know that, in the clinical arena, if you look at HLA mismatches and look at very, simple A, B, and DR mismatches, which are only the three of the six HLA possible. So the better the mismatch, looking at deceased donors, the better the long-term outcome. But if you look at one-year outcomes, the outcomes are quite similar. So you can see that on the top here, the zero mismatch has the best outcome of all, and the 6-6 mismatch have kind of the worst. And it really gets magnified as you look in the long term. So HLA mismatch, although not essential for organ transplantation, it's for sure an important factor when you're doing, for example, donor selection, if you have a couple of different living donors. So that plays a major role. There's also an expansion in terms of understanding some of the known HLA antigens. So this past year, there's been two impactful papers published, one in the New England Journal of Medicine, the other one in the Lancet, both looking at kidney transplantation and looking at potential other polymorphic antigens that are not HLA antigens, but can also drive an antibody response. And so the one here identified LIMS1 locus, and this was done by initial genetic screening of patients, identifying patients that may have deletions, and afterwards looking at their outcomes. And then there's also a paper coming from Europe that also look at some of these, non-HLA incompatibilities using genome in a prospective cohort. All of them then validated with some microarrays, so assays to try to measure the specificity of these non-HLA antibodies. But you hear more about antibodies later on, but just to put the frame that HLA antibodies are the most important, or HLA matching is the most important one in terms of compatibility, but you have all these non-HLAs that may play a role, and this is why if you have siblings that are HLA match, they still require immune suppression, all right? So it's different than siblings that are, twins and identical, which they usually don't. So stepping back just to the immune system, I have a very simplistic view of how do you understand the components of the immune system. You have on one side what I call the surveillance arm of the immune system. So this is the part of the immune system that's able to recognize any threat and send a signal. all right? It's not specific, but it definitely, raise awareness of the system. And then you have on the other side what we call the SWAT team, which is the components of the immune response. They're able to recognize a specific danger, generate the appropriate response, and exterminate it. Okay, so it's much more the more specific arm. So what are the correlates of that? So the innate immune side, that's our surveillance part of the immune system, has NK cells, have dendritic cells, neutrophils, macrophages, and then you have the adaptive immunity, our SWAT team, which is the T and B cells. They have the antigen specificity. So this is one of our first questions. Is it appearing something? Questions on your, all right. So how does innate immunity may trigger or potentiate rejection? By increasing expression of co-stimulatory molecules on antigen-presenting cells, by recognizing known self in the allograft, by producing inflammatory cytokines that attract the immune cells to the graft, by efficiently presenting allo-HLA peptides to T cells, or a combination of, A, C, and D, or A, B, C, and D. Perfect. So you guys got all answers correct. I think the one that, maybe 10 years ago would be questionable would be about the recognizing known self. But it does seem that, the innate immune has the capacity of recognizing known self as well. So this is important concept. So let's go over this for a minute. So innate immunity is responsible for this non-specific response to injury. So the main importance of that is that it potentiates the rejection process, but usually it's not as powerful to be able to reject an organ by itself. What are the potential innate immune activation processes that may happen in transplantation? So number one, early after transplant, we have the ischemia reperfusion injury. So this is a major source of innate immune activation. And late after transplantation, you can have tissue damage, say from ischemia. If somebody's hypotensive, you can have infections. All these may activate the whole innate immune system, and that also may predispose to infection, to rejection. So how does it happen if you look at the molecular basis? So when you have injury to tissue, they're going to be release of what we call damage-associated molecular patterns. So these are molecules that usually are hidden in the cell and are not released on the extracellular fluid. And when this gets released, then there are receptors that are present on those antigen-presenting cells and other innate immune cells that have what we call pattern recognition receptors. Very broad receptors that can recognize multiple different molecules, but the classic one is a toll-like receptor, and this is an example of one of these molecules that get released with injury. It activates a toll-like receptor, and the down-signaling pathway is production of cytokines, upregulation of MHC, and co-stimulatory molecules. So you're kind of prepping up those dendritic cells for response. Is innate immune injury important for the outcomes of transplantation? And the answer is yes. So if you look at different cold ischemic times and look at graft survival, we know that the longer the ischemic time, the lower the survival rate of those grafts. So not only they can cause injury, but they can also potentiate rejections. So those are the two main reasons why this is important and a way to control it. And the rejection rate this is an older study, but shows it can almost double the amount of rejection rates depending if you have delayed graft function or not. This has changed a little bit since we started using thymoglobulin because it has a much more powerful T cell effect, but for sure it's still the case. What about adaptive immunity? Those are all T and B cells, our SWAT team. So T cells are essential for the autoimmune response. So we know this from animal models that if you do transplants in mice and then you remove the T cells completely, you don't reject the graft. You may have a small immunological response early on, but truly you need those T cells to kind of drive the rejection process in the long run. So T cells have three signals that are required to be fully activated. So it requires an antigen-specific signal. It requires a co-stimulatory signal to say, okay, this is the right signal, this is an important response to occur, and then requires what we call signal 3, which is going to amplify the number of T cells, proliferate them more, and get them ready for the fight. So what about signal one or specificity? So this is one of the most important concepts of adaptive immunity. So T cells have to recognize an antigen bound to an MHC molecule. So that's different than antibody that can recognize an antigen without the MHC molecule. So this is a crucial step in the activation. However, in transplantation, there are a few different matters in which this can occur. So we call this the recognition of the T cell with the MHC receptor, the allorecognition in transplant. And you can have the direct allorecognition, which means that you have donor antigen presenting cells. They're kind of migrating after transplant and stimulating directly the T cells. So that's unprocessed donor MHC on the graph APC. You can have recipients APCs. They're basically going to uptake MHC or the HLA molecule from the donor, process it, and then present a little piece of that to the T cell and activate the immune response. That's called the indirect. And you have a newer type of allorecognition, which we call semi-direct. And this is derived from the concept that cells in general, and immune cells in particular, they can release what we call exosomes, which are small vesicles that can contain, a number of different receptors on the surface, including HLA or MHC molecules. And this, instead of being processed by the recipient APC, they get uptaken by the membrane and just expressed wholly on the membrane. So this is semi-direct because you don't have the antigen processing, but you show actually the whole donor MHC on the T cells. And we know that this is important. So this is an example of a video that shows, oops, I think I'll get your help to click on the video because I don't have a mouse here. Hello? Can you click on the video? Yeah. So this is just to show, some of these exosomes which, we tend not to see. I think it's not working. All right, that's fine. So in theory, yeah. So these are all the exosomes that are released kind of around the cells. So this is a major source of communication between immune cells. And this is something I think that we are exploring more and more and trying to understand. There are a number of groups working on exosomes to be able to diagnose rejection. This is something that came out of our lab. Basically you process the urine to get all the exosomes in the bottom, and then you look at some specific markers on that. So this is an example of a CD3 on an exosome. And by looking at the amount of exosomes with CD3, you can predict or diagnose rejection. So these are some of the tools, based on some new concepts of exosomes that can be used in the clinic. But if you put allorecognition in perspective, you're going to see there early after transplantation, you have dominance of the direct and semi-direct allorecognition. As a lot of these donor antigen presenting cells get destroyed or disappear, you have an increase of the indirect allorecognition. So those are the recipients' APCs processing HLA molecules. I think, a big question, in transplantation in general had been, okay, so we have many different innate immune cells, many different antigen presenting cells. Are there cells that are more important for this early activation of the T cell? And we were looking specifically in the skin, because skin of all transplants is the most immunogenic transplant. There's a lot of innate immune cells there. And what we discovered on this paper was that if there's one specific dendritic cell, the CD103 in humans is the CD41, that seems to be particularly immunogenic early on. So if you use a mouse that doesn't have these dendritic cells and you do the transplant, you have a significant reduction of the rejection rate in a fully MHC mismatch model. So it tells you that it's not all innate immune cells are the same in terms of capability of activating the T cells. And by identifying some of these specific subsets that may be more potent, we can potentially develop new therapeutic targets. And this was something that came out of our lab just this past year, which was, okay, so if we know that ischemia injury is bad and we know some of the cells that may play a role in that activation, can you modulate those cells? And what we use, we screen a number of different molecules, but just to cut to the chase, if you look on the right side here, these are antigen-presenting cells that have MHC on the surface. So if we incubate with this molecule, which is derived from the Mycobacterium tuberculosis, you see that all that MHC from the surface go to the cytoplasm. So that dendritic cell, instead of having all their weapons like in the surface and ready to fight, it kind of gets, involuted inside. And this is mediated through a specific enzyme called March1 that regulates the transport of receptors from the cytoplasma to the membrane and vice versa. So by doing that, we show that this March1 was crucial. So why is this relevant? So imagine yesterday we were talking about treating the organ, and we do the perfusion machine, which is great, but we haven't had any effective way of trying to control the innate immune prior to transplantation. So the idea here was to treat the organ prior to transplant and then be able to prolong rejection, delay rejection. And this was exactly the case. So just by treating the skin with this solution and downregulating the dendritic cells, you could prolong the survival of the allograft. It doesn't completely abrogates the alloimmune response, but it reduces to such an amount that maybe you don't require as much induction therapy, and as well as minimizes some of that early injury. And I think this is an interesting concept because it kind of moves from just preventing the rejection, treating the recipient, to treating the organ prior to transplantation. And the big thing is that you have much less toxicity to the recipient, and I think this is one of the important contexts. All right, so from the antigen-specific signal, the allorecognition, we'll move into the co-stimulatory, which is a signal 2 that's required for T cells to get activated. And I use an example, always when a new postdoc come to Boston and he's come alone and trying to find a date, and they ask, okay, so how do I find a date in Boston? And you may say, oh, you can walk downtown, Newbury Street, and see if you bump into someone, or you may go to like a bar where there's going to be music, there's going to be, the environment's going to be right, and there's going to be other people that are also going to be interested in meeting you. So the context of an interaction is really, really important. So imagine that you have all these T cells, in their circulation, through your lymphoid organs in the blood, but they have to have a place where they have a chance to meet their counterpart, okay? So every T cell has a very specific fingerprint. And you want that T cell to recognize the counterpart, the APC, with the MHC and the peptide that it's able to recognize. And this is going to happen in the secondary lymphoid organs. This is where the dating happens, where you're going to potentially have the greater amount of interactions between the APCs and the T cells and potentially find their counterpart. And not only that, doing that secondary lymphoid organs is where those antigen-presenting cells are going to have those co-stimulatory signals and other potential molecules that are going to be important to basically, make sure that that antigen-specific signal will lead to a response, which will, activate cytokines, lead to proliferation, and prolong graft survival. So this is a concept that has been taken into the development of a drug, which is belatacept. So the concept there was, if you have an antigen-specific signal, but you don't have co-stimulation, you don't get T-cell activation. So they developed CTLA-4 Ig, modified a little bit to work in humans, and that blocks the B7 ligands, and therefore you don't have that co-stimulatory signal, and T cells don't get activated. This is important, in particular for naive T cells when you're getting early on. So from the context of T and APC interactions, you have the magnitude of the response. So that is what some of the cytokines and all that is going to lead to this proliferation of the T cells and expansion, quick expansion. And there are also going to be other players that are going to play a role in trying to control that, which may include regulatory T cells and some other cells that may evolve into memory or maybe die out after they exert their function. So there's an amplifying effect and also the creation of a number of different subset of cells that will try to keep the system in check. So, and the big thing about T cells is that if you look back in some immunology books 20, 30 years ago, it was simple. You had two types of, for example, CD4 T cells, Th1 and Th2. Now, you push forward 25 years, there are probably more than 15 different types of CD4 cells. These are some of the ones mostly characterized. And we know that there's some differences, that in transplantation, there's a dominance between a Th1 response mediating the T cell mediated rejection and a TFH or follicular helper cells mediating B cells. And if you don't have any rejection, if things are stable, you have a predominance of Th2 and regulatory T cells. And some cells that may play a role in different organs or may play an additional role in different organs Th17 in lung and skin transplantation seem to be important, and some of these other cells which we don't know much. But why do we have all these different T helper cells? It's all about how your immune system is going to be able to defend yourself against potential threats. So every T cell has a very particular role, in the context in terms of having different sizes of weapons and different types of weapons to fight whatever is being the potential threat. So how do we see this in terms of rejection? So if you have a T-cell mediated rejection, we know that this is a Th1 mediated injury, and that's dominant by those CD4 cells that go into the graft, start secreting cytokines such as interferon gamma, recruiting macrophages, and that's causing injury locally. And the way I think of it is almost like a grenade, all right? So the cell has to be kind of around the area where it's kind of leading to the injury, and it's throwing all these cytokines and superoxides and so forth that's going to cause injury around that. So this is a CD4-mediated response. There's also a CD8-mediated response on that T-cell-mediated rejection that depends on CD8s infiltrating the graft and then secreting perforin and granzyme B that kind of starts breaking things apart, in particular the basement membrane, and attacking the tubules. And these tubules then become large and gorge, and you're going to hear more about that in some of the breakout sessions. But that's a cytotoxicity mediated by CD8 cells, and it requires a direct contact of that CD8 cells with the target cells. And basically the cytokines that get secreted, such as granzyme B and perforin, they start opening holes into that membrane of the target cells, and it's almost like a knife type thing, but it requires the T cell to be really next to that target cell. And this is, putting combined, the CD4 and CD8 T cell response dominate the cellular rejection process, and here I'm showing the kidney, but that's true for other organs as well. This is a histopathologic drawing showing, the tubule here and showing some of these T cells invading the tubule, mostly CD4 cells. There are CD8s around. This is a slide from Michael Mango showing that infiltration of CD4, CD8s, and macrophages in the T-cell mediated rejection, and we have a session just talking about some of the characteristics of T-cell rejection later on. And I think this is one of the most beautiful, microscopic pictures, which is an electron microscopy showing the tubules and showing a T-cell invading the tubule and causing this cell to be apoptotic. The nuclei is getting distorted, the mitochondria is getting destructed, and so forth. So a nice example of, some of the drawings that you just saw. And then on the other side, you have the B-cell activation and differentiation, which drives primarily the development of antibody-producing cells, such as plasma cells, and that antibody is going to cause injury. And the way I think about it is a weapon, so this is kind of a long-range, like distant weapon, so those B cells and plasma cells, they can be in the secondary lymphoid organs, they can be in the bone marrow, and they're going to be secreting these antibodies. They're kind of a guided missiles, because they go directly to where the potential target is, and they don't have to be in the tissue itself to cause injury, but distantly, and for sure they activate things locally in order to lead to the injury. And the concept is that you require either complement or FC-mediated processes in order to cause that antibody-mediated rejection. There's some antibody that can directly activate endothelial cells, but the complement activation and the FC-mediated cytotoxicity are the two main components in which antibody-mediated rejection may occur. And then on histopathology, this looking at kidney, you see that the injury is primarily located in the endothelium. So capillaries get engorged. There's a lot of inflammatory cells there. You can do C4D staining to determine that there's complement activation with that. And then you have the donor-specific antibodies on the circulation. So what do we currently use as immune suppressive drugs, based on all the concepts that I just showed you? So a lot of the drugs that have been developed has been focusing primarily on the T cells. And the way the field had evolved was that we tried to target the T cell at different levels, okay? So we just went through the signal 1, signal 2, and signal 3. And as we now compare the drugs that we have currently available, so calcineurin inhibitors is kind of blocking signal 1. You have belatacept, for example, blocking signal 2 up here. And then you have some of the anti-proliferative agents, such as mycophenolate, azathioprine, that's kind of blocking the signal 3, the proliferation cycle. And then you have steroids that act a little bit down signaling through all that, and more on the gene expression and the production of cytokines. So the goal of having drugs acting at different levels is that you can minimize the amount of drug and maximize the efficacy. Because otherwise you have to use really high doses to be able to block those single pathways. And when you combine, you're able to reduce that. So, but, think of an immune system as, a really dynamic system in your body. And it's influenced by many, many different things. So if you have infections, and you're going to have a session on infections, if you are eating wrong, depending on the food that you eat, all these things and environmental exposures, all these things can modulate and affect the immune system. I won't have time to go through this. There's a session in the afternoon that Marisa Allegri is going to talk about environmental things that may affect the immune system. But I'll show you just one graph that's extremely interesting. We put 21 kids into a camp, and we provided a diet that was organic, without gluten, without dairy, and low salt. So it was a couple of different interventions. The kids did eat, but it was hard in the first few days. And these are all the kids that were on the study. And I'll show you just one slide about results, which was measuring the immune system from when they started the study and then at the end of 4 weeks. And they could only eat the food that we provided. We didn't change any of their medications. And if you look at Th17 cells, one of these kind of pro-inflammatory cells related to a lot of these autoimmune diseases, this is the reduction that we saw just with the dietary intervention. Okay, so it tells us that diet can be much more powerful than we have predicted. And I think we got to think about when we talk about our patients, not about only if they're taking their medications or not, but thinking about the diet is also a way of modulating the immune response. So what I showed you in the past 25 minutes was that HLA antigens are the predominant triggers of autoimmune response. They're the most powerful and polymorphic of all. There's for sure importance of knowing HLA, but they're a little bit less intense in terms of driving the immune response. Second, that innate immunity enhances adaptive immunity. So we'll talk more about how infections, instead of ischemia reperfusion, but infections later after transplantation may lower the threshold for a T cell to then go in and attack the transplanted organ. We discuss, what's the mechanisms involved in T cell mediated rejection. So that's predominantly a T cell and macrophage driven process, while the antibody mediated rejection is driven by alloantibodies, mostly targeting HLA molecules that either causes injury through complement activation or through Fc mediated cytotoxicity. And finally, there are a number of environmental factors that we're just starting to better understand that may modulate the immune system either directly or indirectly through the microbiota. And this is something that I think the field is still in its infancy in trying to understand all these concepts and put together to what we already know. And I'll stop here. Feel free to email me with questions, and I hope you guys enjoy the next 2 days. Thank you.
So I just wanted to highlight one of the questions. How does diet affect the microbiome, and is that what's
so you have to come to Marisa's talk. Marisa's not here yet, but there are multiple things that are kind of arising into this. The best studies that started assessing that was from Sonnenberg from Stanford, where he started comparing isolated tribes in Africa, in Brazil, that had a much unprocessed diet than what we Westerns kind of eat on a regular basis, and we don't know exactly if what in the food that makes a difference. If it is the greater content of fiber, if it is the lack of some of these conservatives that are put in the diet and so forth. But what we do know is that when you change your diet, you change your microbiota. And we saw in our study when we did 4 weeks of all these organic diet and so forth, we saw a change, a significant change in that pattern. But there are other things that influence that microbiota. So if you had a vaginal delivery versus C-section, that from the beginning gives you difference. If you get milk from your mother versus cow milk when you're a baby, that changes your microbiota. microbiota. The antibiotic use that you have after transplant or after any infection kind of changes. So there's so many things that seem to affect, and we don't know, even though people talk about a lot of microbiota, it's such a complex field that we don't know, oh, okay, this is a good bacteria, this is bad. There's so many bacteria in our body that so far most of the studies are associations. They look at someone with chronic disease and they say, okay, this is a microbiota that's not as good for you because it promotes your immune system versus others that don't. But going to the nitty-gritty of the microbiota, there's certain bacteria that produce factors that can promote either inflammation or, on the other hand, promote immune regulation.
Wonderful. Thank you.
Thank you. Thank you.
Next, I'd like to introduce Dr. Alex Wiseman at University of Colorado. He's going to be highlighting key trials that have influenced our current immunosuppression strategies. Thanks.
All right, so this is going to be a compendium of trials and papers that if you put them into your mental library, this is going to form the framework of what you need to know about immunosuppression and how we're trying to manipulate immunosuppression, how we're trying to get better at immunosuppression. So without further ado, I do have some financial relationships and grant support, and there is one off-label discussion of alemtuzumab as an induction agent. So again, where are we now and how did we get here? So we have KDIGO guidelines that have essentially defined what the recommendations are for appropriate immunosuppression, both induction as well as in maintenance. And what I really want to point out is the fact that this was published in 2009 and has not been updated, and so that's a problem. So if we can't update our own literature from 2009 to 2019, either things haven't changed much or we're lazy and have not written up enough of things. And I think that it's not the latter. I think it's that we keep trying to evolve and try to improve, and the rest of the discussions today are going to be revolving around the fact that we reached this point in 2009 and haven't really gotten much further. So we recommend that IL-2 receptor antagonist be the first-line induction agent. That's 1B data. We recommend a lymphocyte depleting agent rather than IL-2 receptor antagonist be used for patients with high immunologic risk. Are we following this recommendation? No. You see that 75% of our patients are receiving depleting antibody therapy. So we're already deviating from our recommendations, and why is that? We'll talk a little bit about that. So maintenance-wise, we, in 2009, stated that calcineurin inhibitors should be used with an antiproliferative agent with or without corticosteroids, and that tacrolimus should be the first-line CNI, 2A data, mycophenolate be the first-line antiproliferative agent, and if mTORs are to be used, they shouldn't be started until after wounds are healed and graft function is established. So let's look at exactly what that recommendation looks like. Well, we're following that one pretty well. Tacrolimus MMF-based therapy or mycophenolate-based therapy forms over 90% of kidney transplant utilization rates currently. With steroids, it's about 70%. Without steroids, it's about 30%. And you see that the turquoise line is all the other immunosuppressive therapies. So I just want to take a quick poll. How many of your centers are steroid-free centers for any organ system? So raise please high. So if this looks less than 30%. You're a steroid-containing center. You use steroids. So this is an evolution as well, which has occurred. But the literature basically, we'll describe exactly how it came to be that there's a cohort of you out there that are steroid-free and a cohort that are not. So let's first talk about induction. Where did we get with this induction agents, and why are we using what we're using? So way back when, IL-2 receptor antagonists were approved. And why were they approved? To reduce acute rejection rates. This was a 1999 study that led to FDA approval of basiliximab, using it in combination with cyclosporin and steroids. The acute rejection rate you see on the left-hand side, the right-hand side of the screen, you basically see acute rejection of 35% versus 49%. Clearly an advantage to using IL-2 receptor antagonists, except now we're not dealing with cyclosporin and steroids, and we're not dealing with acute rejection rates like this. So this is a 30% reduction in acute rejection rates. However, now you know that we're dealing with rejection rates of the 10, 12%. There's still a difference when you use IL-2 receptor antagonists. It will reduce your acute rejection rate by about 15% typically, but 15% of a small number is very hard to see clinical value. So oftentimes you'll see things written about, do we need IL-2 receptor antagonists? Is there a role of IL-2 receptor antagonists in clinical medicine now? So those are things that are still out there, but I do say that there is some benefit, although it becomes more and more marginal, and the cost effectiveness of treating 100 patients to reduce 2 acute rejection episodes becomes the question. What about regarding the depleting antibody therapy? How did we move all the way to using this in everybody, well, for at least 75% of our patient population? So there's really 2 studies that drove this process, and the 2 studies are first the study that's published in, again, 2006, rabbit antithyrocyclobuline versus basiliximab. This is in presumably higher risk patients that had a PRA greater than 20, retransplant, or a high risk for DGF. This is mostly a study of high risk for DGF and utilization to prevent acute rejection. You can see that circled in the box, in the red box, is a difference in acute rejection comparing rabbit ATG versus IL-2 receptor antagonist, and that is statistically significant, and that was meaningful. There is no difference in terms of graft survival, no difference in terms of patient survival, and there was actually no difference. In fact, it maybe even looked safer to use a rabbit ATG in terms of CMV infection risks within this study. So this is number 1. Number 2 was the study that is a former IL-2 receptor antagonist that was available, daclizumab versus thymoglobulin in, again, high immunologic risk patients. And this is a study that instead of using it in mostly high risk for DGF or African American indications, this was patients who had retransplants at a much higher rate. So about 80% of the patients had had a retransplant and had high PRAs greater than, while it said greater than 30, most of these patients had PRAs greater than 80. Again, no donor-specific antibodies monitoring at this point in time. Acute rejection, though, looks about the same as the study prior. So instead of about a 10% absolute reduction in percentile terms of rejection risks, and so thymoglobulin was effective again in preventing acute rejection in high-risk transplant recipients. So these studies were 2006 and 2009, and we use it 75% of the time of our patient population. FDA approval did not occur for thymoglobulin until 2017 because these 2 studies were not blinded, they were not placebo-controlled, they were not done in an FDA kind of standard way, and it took years of essentially looking at the data and revisiting the data and looking at clinical efficacy within our clinical practice to actually gain FDA approval, which only occurred in 2017. The process from which it actually achieved FDA approval is recently published in the American Journal of Transplant just earlier this year, so you can refer to your data in this. And it really looked at the quadruple endpoint of rejection, graft survival, patient survival, loss to follow-up, and none of those factors were different with the exception of acute rejection. But when you bundled them all together for the FDA, it looked statistically significant enough to get approval. So that is going to be our induction state of the current state. And now I'd like to kind of move on to other aspects of maintenance therapies. We'll talk about calcineurin inhibition and CNI avoidance for a few minutes. So our classic study that led to those KDIGO recommendations in 2009 really were formulated based upon the Symphony trial that enrolled over 1,600 patients, probably one of our best studies in transplantation from an immunosuppression standpoint, looking at medium to high dose cyclosporin versus low dose cyclosporin versus no dose calcineurin inhibitors with sirolimus versus tacrolimus with a presumed goal of 3 to 7 nanograms per mil. So it's talking a little bit about dose and levels achieved. We'll look a little bit at that, but obviously, how did we come to tacrolimus MMF-based therapies? Well, this trial essentially showed that there was a significant difference in acute rejection rate compared to cyclosporin, either at the standard or low dose. You can see acute rejection rates of 12% versus the 25% with cyclosporin. Sirolimus or CNI free immunosuppression with an mTOR inhibitor at levels of 4 to 8 were clearly inferior with a very high acute rejection rate that translated into poorer GFR and poorer graft survival. So this was one of the one of the pieces of data that you should keep in the back of your mind in terms of CNI-free immunosuppression. What happens when you don't use CNI and you use mTORs? We'll talk about other means as well. So taking the Symphony trial to the 3-year point, I just want to make this comment about dose exposure. So we talk about trough level monitoring and this goal of low dose CNI 3 to 7. Well, believe it or not, that was not what was achievable or actionable in this trial. And so basically the mean tacrolimus trough level was pegged really at that higher level at 6.5 for most of the study. Cyclosporin arms were also pegged pretty high for the low dose at 100. The sirolimus arm was pegged pretty high at those levels. This is conservative behavior of the investigators to go for the highest level achievable that was acceptable for the trial. So again, when we talk about 3 to 7, there's no data out there to say that 3 to 7 is the right dose. In fact, if you were to look at the mean and standard deviation, we should probably be using Symphony data and say 5 to 8 is truly the range of tacrolimus trough levels. And again, graft survival and GFR consistently were better for tacrolimus-based therapies. So we do have a couple other agents that were FDA approved that were CNI agents, and those 2 agents are long-acting tacrolimus-based formulations. One is trade name Astigraph, and the other one trade name is Envarsus, also known as tacrolimus extended release and LCP TAC. There was some dose finding differences between these. As, you can see that the pharmacokinetics essentially looks pretty similar for the TAC extended release versus the BID tacrolimus formulations. That's the yellow and the green, but the blue area under the curve and pharmacokinetics, you basically see that there is a lower peak and a longer exposure with more AUC, a higher AUC with the LCP TAC or Envarsus. So again, with dose findings studies, you basically need to dose reduce LCP TAC by about 25-30% to achieve the same levels of exposure compared to the others. When we look at the FDA indicated trials for both of these agents, the first is a trial that was again published in 2014 looking at Astigraph, or the extended release tacrolimus formulation. This again is looking at patient and graft survival, comparing BID TAC to QD TAC to cyclosporin, and you basically see no difference in graft and patient survival to 3 years. This study was meant to be looked at and was looked at 1 year and did not get FDA approval for 1 year because there happened to be a significant problem with the BID TAC arm. So if you look closely at the blue line here, you actually see that Prograf had a remarkably low graft and patient survival that was probably the lowest that we've seen in any randomized controlled trial. So taking the data out to 3 years was important to not only show equivalency, but not to look at the potential inferiority of tacrolimus that was essentially different than any other trial that had been published previously. Looking at the Envarsus approval data, so basically the triple endpoints of graft patient and acute rejection survival, all the same, BID versus LCP TAC, those are the upper lines, and you can see the dose exposure. This is again dose finding, and there was a learning curve where we were overdosing patients and having very high exposure. The blue line is actually the Envarsus exposure in the first couple weeks after transplant. So there was perhaps some noise, and that could have prevented acute rejection if you're dosing your patients and having trough levels that are almost double the BID TAC exposure. So that's where we stand from a CNI perspective. Let's talk about corticosteroid withdrawal really quick. We basically have a major study and a few other minor studies, but the major study is, again, probably our one that you put into the mental library, which is a prospective, randomized, double-blind, placebo-controlled, multi-center trial. So this is, and it lasted 5 years. So no trial has accomplished this in transplants thus far, and I doubt that this was ever going to be accomplished again in terms of a placebo-controlled trial. Basically enrolled patients that had immediate graft function, so no DGF, and they were randomized to 7 days of a quick, rapid steroid taper versus extending a standard taper that included steroids out to 5 milligrams by 6 months and maintaining at 5 milligrams. So those outcomes essentially showed 5-year follow-up Similar GFR across the quartile, so same quartile analysis for patients that had GFRs less than 20, less than 40, less than 60, less than 80. And again, this primary endpoint of patient graft and rejection rate looked very similar when bundled. When you actually look at the rejection separately, you see that there is some static in the information here. So you basically see corticosteroid withdrawal with a higher acute rejection rate. That's the red line. And that acute rejection rate was about 18% throughout the study versus your maintenance steroids of about 11%. Patients were allowed to be, by center preference, put on one induction versus another. And you can see that the one induction versus another made a difference. The IL-2 receptor antagonist utilizers saw acute rejection of 24% in steroid withdrawal versus 14% using thymoglobulin. And then again, very similar to Symphony data in terms of acute rejection rates, IL-2 receptor antagonist versus thymo of acute rejection rates of 10.3 and 11.9%. So pretty comparable in the setting of steroids. So what is the value of withdrawing steroids? So a number of you raised your hands. You said you're withdrawing steroids. Your centers are believers. What is the value here? So looking at all the other additional outcomes, one could say that there was no difference in infections, CMV-BK, no difference in hypertension, no difference in incidence of diabetes, although there was higher use of insulin in the steroid arm. No difference in cholesterol, no difference in cardiovascular risk scores, no difference in cataract formation. There are two differences one difference that was noted was in bone disease. So avascular necrosis and fracture risk, 11.3% versus 5.2% in those that had steroids is higher, statistically significant. How our patients view this and why they want to be off of steroids is shown at the bottom, which is weight gain. It turns out that if you look at weight gain over time, there is a little bit higher weight gain, the little white diamonds in the 6 to 12 months, but you see that there's an overlap and there's no more white diamond there from 24, 36, 48, and 60 months. So basically, weight gain occurs. Weight gain is no different from one arm than the other. 5 milligrams of prednisone after the first year does not lead to increase in weight compared to elimination of steroids. So there has been another study, so for those that so I guess I did not ask this question. How many of you are using alemtuzumab or Campath as an induction agent in your transplant center? So keep your hands up for a minute. How many of you are steroid-free centers? Interesting. So some actually reduce their hands, because most of the alemtuzumab use has been really in the setting of steroid-free immunosuppression, mostly based upon this study. So those that are using it, by the way, you're grandfathered into using it, and your programs have access to it. This is not access that's provided to every center at just anyone's whim and fancy, because it's been repurposed for multiple sclerosis and is no longer really promoted or utilized for transplantation, except for those that maybe had access to it at the outset and were not required to change their protocols. So the alemtuzumab story is one looking at steroid withdrawal patients, comparing alemtuzumab to basiliximab, alemtuzumab to thymoglobulin in the setting of steroid withdrawal and TAC MMF-based therapies. You can see that basically the top line shows that alemtuzumab had less rejection than conventional induction therapies, but the difference really was in the low-risk patient population in which IL-2 receptor antagonists had higher acute rejection rates. It was essentially equivalent across the board in terms of the comparison to thymoglobulin and Campath. So again, it seems that if you look at higher risk patient profiles, or you look at changing your immunosuppression profiles, if you're using any kind of modification of a theme, IL-2 receptor antagonists provide you a little bit less protection or less coverage in terms of preventing acute rejection. So these lead to kind of the contradictory thoughts of steroid withdrawal. There's an editorial written by a couple colleagues. One was Niraj Desai, and this is Dan Brennan as well. And they say, well, so what is the rationale to not do it? Why not have steroid withdrawal? We've seen similar GFR, similar outcomes. Yes, there's a little bit of acute rejection, but it doesn't seem to matter at 5 years. 5-year outcomes basically were comparable. yes, acute rejection a little higher, no difference in all these other factors. But the other question is, well, why do it then? Well, why not take people off of steroids versus why keep them on? So the argument to keep people on steroids lays within that acute rejection data. So if you look at those patients that had acute rejection, they tended to have more fibrosis on their biopsies than those that had rejection off of steroids. That's a subtle sign, and it's a subtle indicator, and I would have to say that at 5 years, one could not really make that determination. I know that if you were at the ATC this past year, one of the featured abstracts was from one of our colleagues, John Gill, as well as Steve Whittle, who ran the 5-year study, looking at 10-year outcomes, looking at registry data, and essentially found the same kind of information. So there was not like this dramatic drop-off of GFR, a drop-off of graft survival. So for whatever it's worth, we do have some supporting evidence that maybe tips the scales to saying it is just as safe as the promoters would have said it was. So a lot of people say, well, if we don't eliminate steroids in the first week, you can't eliminate it ever. Where did that come from? There is one study that basically says, well, perhaps you cannot eliminate steroids later, and this is about as strong as the data gets, so don't shoot me for poor data. But basically, this is a double-blind, randomized controlled trial of late prednisone withdrawal at 3 months, and this is in the setting of cyclosporin and MMF-based therapies. And you can see that these people were randomized to taking a sugar pill versus 10 milligrams of prednisone starting at 3 months. And the acute rejection rates, particularly in African Americans, was substantial. So that's the blue lines there. But also in non-African Americans was significantly higher than that's the burgundy line. So there is this signal that maybe prednisone does something, even at low doses, even at 10 milligrams at 3 months. Can I tell you what happens at 1 year in somebody who's entirely stable? No. Are we ever going to have a trial that looks at patients 1 year after transplant and randomized to 0 versus 5 milligrams of prednisone? Probably not. I think this is going to be too much of a long-term effect and too many long-term questions that would be answered in otherwise stable patients. So this is what we're left with. So finally, we're going to move into the CNI withdrawal and anti-metabolite story here. So there are two flavors. Again, we tried. We started in 2009, and we have moved through the era of the 2000s as the era of trying to eliminate calcineurin inhibitors. CNI withdrawal was initially attempted with mTOR inhibition. I showed you the Symphony data, but sirolimus was actually used as a way to reduce exposure to CNIs as well as eliminate. This is how FDA approval occurred. You basically see that patients were on cyclosporin, sirolimus, prednisone versus cyclosporin withdrawal at 3 months with sirolimus, prednisone alone. Very, very high exposure sirolimus, higher acute rejection rates during that withdrawal period. You can see on the left-hand side or the right-hand side the acute rejection differential in patients who were withdrawn from cyclosporin. But when you look at the 3-year data, the GFRs in those patients that remained on therapy was significantly better. And even in the intention to treat arm, it was significantly better. So this essentially led to FDA approval and a whole other era of attempting to use mTOR inhibitors instead of CNIs. So this led to the Spare the Nephron trial. Spare the Nephron trial now used instead of cyclosporin and eliminating, used modern immunosuppression, right? So basically CNI MMF steroids versus mTOR MMF steroids. And here the data were not nearly as positive. You saw, I mean, there were some problems with rejection in that prior study. In this study, the difference in GFR was modest, if anything. The adverse events were higher. It's a utilization issue that led to a kind of a reticence of adopting this as a primary therapy. There's another study, instead of using sirolimus, but using everolimus as the CNI conversion to, and this is a CNI, again, eliminating cyclosporin, keeping patients on everolimus, MPA steroids versus cyclosporin, MPA steroids. You can look at the 5-year data, which is this is long-term extension study. And you can see that the GFR is a little bit better in the everolimus arm, statistically better. The biopsy-proven acute rejection was higher, but the real problem lies in the liner notes. It's the higher rates of proteinuria, the higher rates of stomatitis, hyperlipidemia, higher discontinuation rates in particular, just the tolerability effects to gain this advantage for GFR. So it's just been a tough slog in terms of making this the go-to therapy. Even so, from the outset, de novo, that was the Symphony experience. This is the conversion experience. Finally, what about later on? So some patients who are failing, and you say, well, let's salvage their grafts and maybe take them off calcineurin inhibitors as their GFRs get really low. That actually was a question that was asked and answered by the CONVERT trial that took patients from 6 to 120 months after transplant, an average of about 3 years after transplant, and said, okay, if you have a GFR of 20 to 40 or 40 to 60, we'll look at you differently, but we'll randomize you to either mTOR versus remaining on CNI. The late phase, the 20 to 40 GFR, never got out of the gates. They were very low enrollment because of a very high adverse event propensity. Pneumonitis, infection risks, as well as proteinuria issues were predominant. Even in the stratum that had higher GFR, so the GFR greater than 40, there was really no benefit to transmitting or to transferring to sirolimus. You can see that the GFR at 12 and 24 months were essentially the same between sirolimus conversion and continuation, but again, that adverse event signal of proteinuria really showed up very early, actually, at month 6, and continuing and progressed to 2 years, showing an increase in median proteinuria over time. So again, really not that it can't be done, but it is always done with some baggage to carry along that needed to be monitored. So with that experience, we had to move away from mTOR inhibitors, and now we had a new opportunity to look at CNI-free immunosuppression, and that's with the use of co-stimulation, or belatacept, essentially. So in this study, there's the benefit trial design. There's a lower intensity and a moderate intensity exposure. The less intensive is what ultimately got FDA approved, and basically showed some of the details of this study showed higher acute rejection rates. So again, the common theme is you don't use calcineurin inhibitors, you have higher acute rejection rates, and that's the same with belatacept-based therapies. And again, the converse story is you don't have calcineurin inhibitors, you have better GFR over time. And this 7-year data was published in the New England Journal in 2016, showing a very strong differential in terms of GFR between those on belatacept and not. There were some other nice features that looked promising, i.e. the death and graft loss data actually looked better for belatacept at 7 years. The de novo DSA formation was higher with cyclosporin-based therapies than belatacept, but I just mentioned to you what the control arm was. Cyclosporin. So what really needed to happen, and what the field was really interested in, is not only this acute rejection rate, but how would it compare against tacrolimus-based therapies. And and I'm not sure if Andrew's going to go into this in his talk, but the clinical application of the benefit and benefit EXT trials has essentially shown a very high acute rejection rate that makes centers more reticent to adopt it as primary therapies. The DSA data is quite provocative and quite interesting, but we have to get over the hump in terms of acute rejection. So what about this transition concept? So we talked about transition from CNI to mTOR. What about transition from CNI to belatacept? There's a phase 2 trial that was published, and now 3-year data are available. It randomized patients to switching to belatacept at 6 to 36 months after transplant. Again, higher GFRs. This did not, there was a little bit of a safety signal in terms of acute rejection. You can see the 1-year and 3-year rejection numbers. This is a phase 2 trial. It's not yet FDA approved for this indication. This is how most people are using belatacept. It's how our center is using belatacept, but it is not an FDA-indicated method right now. This is like rescue therapy for those who are not tolerating CNIs, essentially. The GFR differences at 1 year did maintain, although these are modest differences. These are not the benefit-style improvements in GFR. And there is a safety signal in terms of acute rejection. So there's a phase 3 trial that has been modeled exactly after this. It has been completed. I think hopefully by next year we will have results and we can be sharing those at ATC or Fellows next year. So then last but not least, what about that third agent? So we talked about steroids on the back end, we talked about CNIs on the front end. What about the antimetabolite? What can we say about utilization? Is there one better than the other? So without showing randomized controlled trials, because there is a specific reason why I'm not, there's a meta-analysis comparing MMF versus azathioprine of 19 randomized controlled trials. And within this meta-analysis, it did show acute rejection rates lower with MMF, 38% reduction. And you cannot read it, you will not be able to read it, but it's using cyclosporin, tacrolimus, other basic baseline CNI therapies, and a reduction in hazard for graft loss. Basically, I think you focus on the language down below. Trial quality was poor. Only 2 trials reported adequate allocation concealment, only 7 used ITT analysis. And ultimately, the quote that I have at the bottom is, the finding of improved graft survival in particular among patients with MMF is controversial and evidence is weak. There's no evidence that it improves patient survival. So when you're talking about transitioning patients from MMF to azathioprine, I think in a stable patient, you can start to feel comfortable about the fact that, once you get through the most risky point of transplant, that perhaps transitioning from one agent to another, while not proven, it's basically the data is weak to say that it's better, worse, or indifferent, and that could be an option. What about transitioning or comparing MMF or MPA to mTOR inhibitors? So again, last but not least, this is a publication from last year. One of the largest studies I think that's ever been done, about 2,000 patients that were enrolled ultimately. This is the primary data that led to a much larger study, but same study design. Basically, everolimus, 3 to 8 nanograms per milliliter with a lower exposure of tacrolimus. You can see after 6 months, looking at levels of 2 to 5, compared to MPA tacrolimus-based therapies, 5 to 8 nanograms per mil. This is the last slide. This is the interesting endpoint, which is a primary endpoint of % of patients who had GFR less than 50, CNI toxicity perhaps, or some hemodynamic factor, or prevention of acute rejection. So you can see the forest plot, you can see the line of equality, you can see the line of equality going down one, you can see most of those lines crossing that line of equality, but most of those lines tending to favor MPA-based therapies. And again, this is a point to say that it seems to be something that you can transition to, you can use it as an option. It has some modest signals to say that it's not, I don't want to have too many double negatives, not non-inferior, or it's essentially not equivalent. I don't want to say equivalent, but there's definitely some signals that MPA may be more efficacious. But bottom line is there was less CMV in the everolimus arm, so that makes it potentially one indication for utilization. So with that in mind, I think I just want to close with the following statements, which are that our induction agents right now, we do have a modest reduction of acute rejection with non-depleting IL-2 receptor antagonists. It's more pronounced with depleting therapies. Really, there's no evidence of graft survival benefits. Maintenance therapies, we are now becoming more similar than more different. We are not personalized, we are standardized, we are protocol driven, and that's because we have not been able to get over the hump of any other efficacy or advantages of new strategies. And so really what we hope in the future is to have immune monitoring tools that allow us to deviate from our standard protocols, but it's very hard to get us off of what we know, and until further notice, until we have better drugs or better ways of monitoring, we're kind of in the 2009 KDIGO recommendations. Thank you very much.
Thank you, Alex. Do we have time for maybe one question?
Sure.
Somebody had a provocative statement that I want to have you address.
Okay.
So with 95% allograft survival achieved at 1 year, would it be fair to say that our success has become our failure in our efforts for further innovation for acute rejection reduction?
100% true, like not 95% true, but 100%
Yeah.
true. So we basically are so good at what we do that to make it better, it makes it very expensive to do trials. It makes it very expensive and difficult to show statistical significance. So we are trying, basically it gets down to the point of what the patients are experiencing, and I think that becomes a much more important thing. What side effects are they tolerating or not tolerating? What what individual effects that they are having can be manipulated with other therapies, and when is it safe for us to transition. So I think that, again, we are not going to get off of our TAC MMF-based addiction until we have a way to monitor for safety profiles or for efficacy of therapies, so that when we give belatacept, we're not worried about a 40% acute rejection rate.
Awesome. And then one more question on steroid withdrawal.
Yeah.
Somebody asked if there was any data on DSA development in steroid withdrawal.
That's a great question, and within that data set there was
Yeah.
not, unfortunately, and I've not seen anything in terms of DSA prevention or promotion with steroid withdrawal or not. That's a really unanswered question.
One more question. Can you just provide a little bit of the context in the BENEFIT trial? Somebody had asked why BENEFIT was performed with cyclosporin and basiliximab.
So that gets into when FDA approval happened for TAC MMF-based therapies. So we basically were using TAC MMF as a combination therapy, but FDA did not recognize that as a combination therapy because TAC was approved with azathioprine and MMF was approved with cyclosporin, basically. So these were all kind of historical data points that led to poor opportunities to study against clinical practice standard of care.
Awesome. Thank
Yeah,
you.
Thank you.
I'd like to introduce our next speaker. We're actually going to have a combination of 3 speakers to talk about key clinical trials in heart, lung, and liver. And I believe this is Mary Jane Farr,
Yes.
who
Hi.
will be
Good
starting
morning
with
again.
heart, right?
Hi. So I've just got 5 or so minutes of some newer things happening in heart transplantation, but just to follow up on some of the things that you talked about. So I work in a transplant center where it's about nearly 42 years old, and we actually have a number of long-term survivors greater than 25 years and a handful greater than 30. And I would say that the survivors, although it's a selection bias, are all on prednisone and low dose triple immunosuppressive therapy, and we never change those things, and the patients say, don't touch my medications. Some of the other things that you highlighted about CNI sparing therapies and some of the clinical trials or even anecdotal or single center things, we see the exact same thing. Increased rejection rates with modest improvement in renal function. So whatever you said about happening in the kidney, both the rejection and the GFR, we see the GFR effect and we see the rejection effect. So it parallels, and heart always follows kidney by a handful of years. So okay, so on to my slides. Okay, so important endpoints in heart transplantation: freedom from all rejection, freedom from antibody-mediated rejection, certainly freedom from development of de novo donor-specific antibodies, which portends a worse prognosis. And all of this comes down to amelioration or prevention of coronary artery vasculopathy. Once that occurs, the trajectory of survival is markedly diminished. And prevention of graft dysfunction, either systolic dysfunction or worse than that, restrictive physiology, where you end up with pulmonary hypertension and renal failure. And then finally, prevention or delay in renal dysfunction or failure in the setting of long-term CNI use. So I'm just going to highlight maybe 4 drugs. There's lots of different trials that you can choose, but for the purpose of this audience, drugs. So one induction trial was the use of rituximab. So in heart transplantation, about 50% of the United States uses some sort of induction therapy, thymoglobulin or IL-2 receptor antagonist therapy, but many centers don't, and there's actually not really good data in the heart literature to support use of induction. I'm from a center that we used to use induction, and we stopped using induction, and we may be turning back to induction. But so this clinical trial was a clinical trial in heart transplantation, CTOT-11, in patients that did not have prior donor-specific antibodies. They were randomized to 3 drug regimens postoperatively, or the addition of either placebo or rituximab. And the hypothesis was that B-cell depletion at time of heart transplantation would attenuate the development of coronary artery vasculopathy, and there's data in the literature to support the B-cell effects of CAV. And there was one nice study that was Brigham and Columbia, and I think it was Mass General as well. We're looking at explants of hearts. If you looked at the vasculopathy, there was a major B-cell component to the vasculopathy, and so that was part of the hypothesis. And so we know that rituximab is a monoclonal antibody against CD20 B cells. And so there was 163 patients who were in this trial, and they were randomized to either rituximab 1,000 milligrams or placebo in just two different infusion time points. And the primary endpoint was, well, a number of different things, but the primary was looking at coronary vasculopathy as assessed by intravascular ultrasound, percent atheroma volume, or intimal medial thickness. And the secondary endpoints were what you would expect, episodes of rejection and development of donor-specific antibodies. And just to note, to remind people, this is the way we assess coronary vasculopathy. This is not the ISHLT guidelines, which is just angiography, but this is an invasive look using IVUS. And the percent atheroma volume is really just that volume of plaque that develops that ultimately leads to obliteration of the coronary arteries. And so the major surprise of this trial, and people would maybe argue it was somewhat underpowered, was that there was an accelerated accelerated cardiac allograft vasculopathy with rituximab and a markedly increase in percent atheroma volume, and everyone was really surprised by this finding. So that's the first thing. The next trial that is ongoing now, the All-In trial, this is a randomized multicenter clinical trial using tocilizumab, IL-6 receptor antagonist therapy, also as induction. We have used this off-label in heart transplantation as a desensitization therapy, and it is, of course, used more widely in the kidney transplant community. So the study design is, as I said, it's a 1-to-1 randomization using IL-6 receptor antagonist therapy. At 2 days after transplantation, these are patients who do not have donor-specific antibodies to their donor, who have not suffered primary graft failure and otherwise meet basic inclusion-exclusion criteria. And the infusions are 6 infusions, and the primary endpoints are really graft failure, death, detection of donor-specific antibodies, rejection, and then there is an attempt at looking at intravascular ultrasound as well, although not all centers are going to be able to do that. Excuse me, the secondary endpoint is death or retransplant. No, actually, it is the primary. So this is ongoing. I think we've had pretty good enrollment so far. It's a pretty easy drug to tolerate. Leukopenia is probably the major side effect. So I think this is a very interesting trial, and we know that IL-6 can be, is invoked in innate immune responses and in T-cell activation. So, it's a drug that will potentially hit both sides of the immune response. The third trial that I want to talk to you about is really just a single-center trial out of Cedars-Sinai called the DUET trial, and this is use of eculizumab, a complement cascade inhibitor, in the setting of highly sensitized patients. So the problem with highly sensitized patients is, of course, that they wait long for transplant, and many are unable to be transplanted without intense immune modulation, either pre in a desensitization strategy or peri, and certainly long-term post-transplantation. So eculizumab is a humanized monoclonal antibody that binds to and prevents activation of C5 and the complement cascade, and it is invoked both in specific immune responses, antibody-mediated rejection, and also invoked in inflammatory responses. And this drug has also been used off-label for both indications. Even for primary graft failure and heart transplantation, there's been the occasional off-label use of eculizumab with, at least anecdotal experience of a good response. Okay, so there's a picture of eculizumab and where it blocks the cascade, and some would argue that's a not enough or early enough blockade of the complement cascade. So the preliminary data, so for this set of patient population at Cedars-Sinai, they were all highly sensitized patients, and they went through some form of desensitization strategies. So here are some of them. For patients who were transplanted, none of them had a CDC positive cross-match. Going into transplant, I would presume that all of them had a positive flow cross-match. In heart transplantation, a CDC is typically enough, and for many patients, we'll do a retrospective flow to get a sense of an immune profile. So in this particular case, they were all negative CDC. And then there was use of eculizumab post-transplantation. And so the 1-year survival, the overall, the actuarial survival is more than accepted in most transplant centers. Freedom from antibody-mediated rejection was at about 77%, which is not bad, probably expected. Patients with donor-specific antibodies at 1 month is pretty high, and the infection rates were pretty high too, but it is a reasonable therapy, and this trial is ongoing, and I think it'll be finally closed in December, and there'll be some results in early 2020, but other centers are starting to use eculizumab post-transplantation and using the Cedars-Sinai protocol. There are a number of infusions, and we recently just did this in our center. Okay, so 2 more trials I want to talk about. One is called the Tic-Tac trial. This is long-term follow-up. So the hypothesis of this trial was that we are over-immunosuppressing our patients. And so there's a lot of center variability in heart transplantation. There are some centers that do steroid withdrawal in 8 weeks. There are some, like my center, that withdraws within 1 year. And so there's a lot of variability. And then is it 3 drugs? Is it 2 drugs? And there are many centers that will use 1 drug. So Tic-Tac was tacrolimus in combination with at least 1 other drug, MMF in this case, or tacrolimus alone. So actually 2 centers, this was Mount Sinai and Newark Beth Israel. 2 centers, 145 patients. There's 10 years of follow-up. The initial data was very good that there were some major acute cellular rejection in the first year, but some of the early data that showed that this was a reasonable strategy. So 10 years of follow-up. The long-term survival probably favors the combination therapy, TAC MMF versus TAC alone, 68 to 80% 1-year survival. But you would argue that 68% 10-year survival is actually excellent. So that's the first thing. The second thing is 10-year freedom from coronary artery vasculopathy. Also favors the combination, but there was no IVUS data here, and that's okay, again, because the ISHLT definition of vasculopathy is just angiography. And then, so I would say, I think still people are a little bit on the fence on whether tacrolimus alone is a reasonable strategy. I think from the time that this trial started to now, we have a lot more information and education on the heart side in the last 5 years about, while standardizing, also using personalized strategies to create an immunosuppressive regimen that avoids rejection in AMR and de novo donor-specific antibodies, and also avoids malignancies and some of the long-term consequences. So the final trial I want to talk to you about is the SCHEDULE trial, and this is looking at everolimus. This is the Scandinavian heart transplant everolimus de novo study with early calcineurin inhibitor avoidance. And the hypothesis is that initiation of PSI therapy using everolimus and early cyclosporin drug attenuation or withdrawal attenuates coronary vasculopathy. So the primary endpoint here was IVUS assessment by either percent atheroma volume or intimal medial thickness, which is just a diameter. So 115 heart transplant patients were randomized to initiation of everolimus and CNI withdrawal within 3 months post-transplant, which is very early to use PSI. We typically don't even think to do such a thing until after 6 months, and standard of care is pretty much a year is when we think about transition based on angiography. So the results of this trial shows that there was a significant decrease in vasculopathy in the everolimus group, but there was a significant increase in acute cellular rejection and no difference in graft function or mortality. And this is just a slide to demonstrate the decrease in percent. This was an intimal medial thickness, and it was clear to be able to say that this was in the setting of donors that didn't come with some burden of coronary disease. And finally, some of the other endpoints that, while you could see in multivariable analysis that treatment with everolimus decreases your risk of vasculopathy. Other risk factors for vasculopathy were obviously donor age. Actually, male recipient, you might have predicted female if you invoke some sort of higher incidence of rejection scenario. And then, of course, diabetes. Actually, the diabetes doesn't make any sense, does it? You would imagine there'd be more vasculopathy. One of the major problems, as you've alluded to, Alex, is it's very, very difficult to uptitrate everolimus. the levels that we're looking for is somewhere between 4 and 8, and that's extremely hard to do in my experience, and I try to do this a lot in a high-volume center that we are initially faced with a lot of leukopenia, followed by worsening proteinuria, especially in the diabetic population, aphthous ulcers, dyslipidemias, which is a major problem. So we start a patient on everolimus and their LDL goes up, triglycerides go up, you maximize their statins, then you're turning to PCSK9 inhibitors. So you're sort of layering one expensive drug on another expensive drug. So it's not so easy to use these drugs. So in conclusions for this short presentation, that more clinical trials in heart transplant are needed. Like I said, we always seem to lag behind the kidney literature. Research community, belatacept, it's making its way into heart transplant clinical trials. More standardization of practices is necessary to be able to better assess outcomes across centers. There remains very little data on induction therapy. There's lack of standardization, as usual, in MFI to better understand the immune profiles of one patient population over another. And then sort of what I didn't talk about, and there's not time, we can talk about it in small group sessions, are some of these other ways in which we can monitor individual patients sort of beyond the biopsy scenario, especially when biopsies after a certain period of time really probably increases the risk and doesn't provide benefit to better tailor what immunosuppressive strategies are best for individual patients. Okay, thank you.
Next, I'd like to introduce Jeff Edelman, who will be talking about the lung transplant clinical trials.
Hi, good morning. Thanks. I've moved up to the second spot. I'm one person away from break. I'm going to use my 5 minutes to give you 3 clinical trials, so 3 and 5. And the first trial is looking at kidney injury after lung transplant. We tend to keep our patients on 3 drug regimens long-term, usually a calcineurin inhibitor, which is typically tacrolimus, cell cycle inhibitor, which in most centers is mycophenolate, and corticosteroids. That said, we still have high rates of chronic lung allograft dysfunction. It remains the leading cause of death after transplant. And we also have high rates of chronic kidney disease. When patients get further out, say at about 8 years, the incidence of chronic kidney disease is quite high, with up to, I think it's 8% of patients needing either dialysis or going on to transplant. So although we clearly have regimens that insult the kidneys, we'd like to protect them as well. And so the first trial I'm going to present is a randomized trial that was done in Europe, looking at the addition of everolimus to standard triple therapy with reduced calcineurin inhibitor exposure. So 4 drugs incorporating everolimus in lung transplant gets the acronym for EverLung, which I will submit to you is the best acronym of the day. This study enrolled adults who were 3 to 18 months after lung transplant. They had mild to moderate renal dysfunction. Their eGFR was in the range of 50 to 90. This is a randomized trial. We don't have quite the numbers in kidney transplant, so a randomized trial enrolling 130 patients in lung transplant is huge. All patients were on 3 drug regimen. Half of them were randomized to continue that regimen. Half of them were randomized to have a reduction in their calcineurin inhibitor with addition of everolimus. And so in the quadruple drug regimen, the tacrolimus target was 3 to 5 nanograms per milliliter. Cyclosporin was 25 to 75. And the patients in both of those arms actually ended up having drug levels that were right really at the top end. In the triple drug regimen, the tacrolimus target was greater than 5. The mean level was actually closer to 10. cyclosporin, a small number of patients, the mean level was pretty close to 100. And then other than cell cycle inhibitors, prednisone were the same. Everolimus target trough level was 3 to 5 nanograms per milliliter. And so they looked at, this is showing you EGFR trends over the 12 months after enrollment. The white is the triple drug regimen. I'm sorry, the white is quadruple drug regimen. The gray here is the triple drug regimen. And you can see baseline, and then with the change, the EGFR kind of jumps up in the 4-drug regimen patients and sort of stays higher throughout, whereas in the triple drug therapy, it kind of trends down gradually over that 12-month period. And so the mean EGFR in the 4-drug group at 12 months remains statistically significantly higher than in the 3-drug regimen. And at 12 months, there was no difference in other adverse outcomes, including rejection, infection. There was, however, it's a non-blinded trial, and so in the study drug group, drug was discontinued, could be discontinued for adverse effects, and there was about a 25% discontinuation rate in that group. But still, at least early on, we need to see long-term data as far as what happens with these patients with reference to CLAD, but this at least is some evidence that if you have patients who are early out and are running into problems with renal dysfunction, that this may be a reasonable strategy to consider. One of our other problems in lung transplant is the approach to diagnosing acute rejection. For us, acute rejection diagnosis requires histology. The way we get our histology is transbronchial biopsies. And transbronchial biopsies aren't without risk. There's about a 2 to 4% incidence of pneumothorax. And they're also not, they're invasive. Patients don't like procedures. But also even with, at transplant centers, there's a high rate of inadequate sampling, up to about 25% of getting not enough tissue to make a diagnosis. And so the holy grail probably for all of us transplanters, no matter what organ, would be to have some non-invasive way to diagnose rejection or get some other signal that we need to alter our immune suppression. And so this was a study done largely at UCLA looking at gene expression profiling in BAL fluid to try to correlate that with allograft rejection. And so it was retrospective. They had a biobank of BAL cell pellets collected from either surveillance or clinically indicated bronchoscopies. They sorted those patients out based on events at the time of or after bronchoscopy, including A-grade acute cellular rejection, lymphocytic bronchiolitis, infection, or patients who had no rejection or infection. And so looking at gene expression profiling, they identified, this is the amount of upregulation. So these are genes that were upregulated by at least twofold, reaching statistical significance. So in this kind of upper right quadrant, they identified 72 genes that were upregulated at least twofold to a statistically significant level. These genes cohorted into about 4 different pathways: T-cell receptor signaling, cytokine signaling, cell adhesion, and cytotoxicity. They then looked at these genes, these families, and they kind of went through and they wanted to come up with a relatively simple test that they could use to identify or predict rejection. And so they targeted four candidate genes, one from each category. And using this 4 kind of candidate gene profile, they were able to come up with an expression pattern that was about 60% sensitive for rejection, 82% specific, and 76% accurate when compared with transbronchial biopsies with acute rejection. The sensitivity was higher depending on what grade of rejection, and so it was about 60% for A1 or A2, about 80% for A3, and if you looked at patients who had what we call spirometrically significant acute rejection, so they had a decline in PFTs, which was a small number of patients, it was 100% sensitive. They then looked not only at the sensitivity for acute rejection, but the correlation with developing of CLAD. CLAD is chronic lung allograft dysfunction. It's defined by either development of airflow obstruction, bronchiolitis obliterans, or development of restriction, what we now call restrictive allograft syndrome, subsequent to biopsies. Graph A here is the patients who had or didn't have acute cellular rejection diagnosed by biopsy, and looking at CLAD-free survival over time. You can see if you had acute cellular rejection by biopsy, there was some decrease in CLAD-free survival. And what was striking to me in this paper was that just looking at the gene expression profile, looking at these 4 candidate genes, patients who had a profile that predicted acute cellular rejection had a much lower CLAD-free survival. The relative risk of CLAD in this group was 2.4. And so it would seem, in looking at this, that maybe this profile is better at predicting development of CLAD. I think this group is probably, all of these patients, if they had rejection by biopsy, you can imagine that they were treated, and if they didn't, they were in this arm. This arm is enriched, I think, by patients who have untreated rejection. And so I think I can't see that this profile would replace biopsies at this time, but I certainly think that if you were using this, and again, this is still in a small sort of a retrospective study, if you were using this, the way you might use it would be to say, well, I don't have rejection on biopsy, but I do have this suspicious profile. Maybe these are patients that I should treat anyway. But I think it is good to know that we are moving, or we have some other perhaps potential non-invasive ways to get at rejection. So the last study I want to talk about was already mentioned earlier, and this is heart and lung transplant from hepatitis C infected donors going into uninfected recipients. This is a single-center study. They looked at donors with hepatitis C viremia, actually donors who were nucleic acid test positive, with recipients who were uninfected. And this study included 8 heart and 36 lung transplant recipients. One of the things that I think is striking about this study is that they enrolled patients over about 17 months. And in 17 months at a single center, to have this number of patients is really quite striking. If you think about the fact that the top 20 lung transplants in the country, the range of transplants per year is probably about 50 to 130. If you're a single center and you're adding 36 donors to that pool, that's huge. The patients who received, the 44 patients who received transplants from hepatitis C donors received 4 weeks of treatment basically up front, started on the day after transplant using sofosbuvir and velpatasvir, excuse me if I mispronounce those, that's not my language. So they had a composite outcome of a sustained viral response at 12 weeks after transplant and graft survival at 6 months. And the trial was stopped after 35 patients had reached the endpoints, and the outcomes they reported that early on, 95% of these recipients actually did have detectable virus at the onset after transplant, but 100% had cleared the virus by week 2, and in all of those patients, the virus remained undetectable for the duration, not only out to 12 weeks, but for the duration of the study period. And they had 100% graft survival at 12 weeks. So I really do think that this does offer a tremendous potential to increase our donor pool in organ transplant. And this is really nice evidence that at least, you know, for that 6-month period, I think we still have to see long-term outcomes, but this is quite compelling that this would be safe. So thank you.
I'd like to introduce our final speaker of this trio, Josh Levitsky, who will be talking about the liver transplant trials.
Okay, so I'm not going to go through a lot, just like real specific trials, but just try to give you a little bit of an overview of where we are at with liver transplant immunosuppression, kind of bringing us up to present. I kind of agree with Alex. We haven't had a lot of clinical trials in the last 10 years. Really what it comes down to with liver, which I think is different than other organ transplants, is that we are continually trying to have less immunosuppression, but I think when you push that too far, rejection can occur. So it's sort of a balancing game between the complications of immunosuppression and avoiding rejection, just like all. But definitely liver transplant recipients can tolerate less immunosuppression. And so that's been sort of the goal with a lot of the studies that have had some success. And but the main message going forward is that we have a couple new therapies on the horizon, but we're really trying to utilize what we have now in a better way. And I think the biomarker story we'll talk about a little bit later there's an afternoon session here that Alex and I are going to do where we'll talk a little bit about biomarkers, and I'll focus on the liver transplant aspect of that. So this is some data, a little bit old. It's an SRTR report. It's pretty similar as to how it is now, that induction therapy has actually been increasing in liver transplantation. If you look at the reason for this, it's mainly for renal sparing immunosuppression. But if you look at IL-2 receptor antagonists have steadily increased as used in induction. Up to 30% of centers are using some induction therapy. And calcineurin inhibitors are by far, tacrolimus is the mainstay. Antimetabolites have also increased. Most centers are using antimetabolite therapy on a lot of their patients, particularly renal dysfunction. We have liver kidney patients. We have autoimmune patients. So but I think mostly for renal dysfunction to be able to lower the CNI levels early after transplant. mTOR inhibitors have taken a little bit of a tick up with the approval of everolimus. In liver transplant, it's mainly used after 4 weeks or so in combination with tacrolimus, and primarily to reduce the tacrolimus levels down to spare renal function. And steroids are generally, most centers are using some steroids, but not typically long-term, except in autoimmune patients. So, of course, I think the main focus really has been to try to avoid this, which is calcineurin inhibitor-induced renal injury. And just like lung and small intestine, the liver transplant recipients have high rates of CKD afterwards. And part of this is going in with CKD. It's how patients get transplanted. They have to have some renal dysfunction. That's part of the MELD score. And there's some recovery in most patients, but a lot of times there's some ongoing injury that leads to kind of combining with the CNI can make it worse. And so I kind of point you to, we published a series in AJT a couple of years ago called Protecting the Kidney in Liver Transplant Candidates and Recipients. And there's 2 papers. The one on post-liver transplant, we have some tables in there that kind of summarize the trials of protecting the kidney, which is, if you look at, I kind of break it down into early, which is within a month of transplant or after transplant, then delayed 1 to 12 months, and then long-term. If you look at the early trials, the best data have been with patients who go into transplant with renal dysfunction, of putting them on an IL-2 receptor antagonist, delaying CNI therapy for even up to 5 days in some cases, and when you started targeting lower levels of CNI trough levels. And this tends to, with the IL-2 receptor antagonist coverage, again, if you don't have somebody with high immunological risk, I think this can work very well to improve renal function, and there are some data that this is long-lasting. Some of the data are mixed, but if you do that approach where you have a really early aggressive strategy, you can improve GFR without the penalty of increased rejection. The delayed approaches really have focused on kind of the same. There was actually a liver spare the nephron study several years ago that tried to get completely rid of CNI therapy between 1 and 3 months after liver transplant, sort of a similar. And they had improvement in GFR, but there was, not surprisingly, a fair amount of side effects with, this was with sirolimus, fair amount of side effects with sirolimus, and there was an increased rate of rejection. And so what the everolimus studies had kind of learned from that experience, did not get rid of CNI, or tried to get rid of CNI. There was more rejection. But if you lower the CNI therapy to really just bare bones, but just keep a little bit on board in the context of everolimus, the seminal trials have shown really significant improvement in GFR long-term, and actually even a lower risk of rejection. This actually, though, does come at the cost of the side effects of everolimus. It's mTOR inhibitors, the same array of side effects that you see in others, at about 20% discontinuation rate. So you have to kind of choose wisely the right patient. Also, the wound healing. It's generally it's not advisable to do this before until 4 weeks, at least after transplant. The late conversion studies have been really, unfortunately, fraught with negative results. It sort of kind of makes sense. It's a little bit too late after a year to be trying to minimize CNI therapy or even get rid of it. There is some potential benefit to use mycophenolate. May have some nephroprotective effects. It's a reasonable option. But generally, late after transplant, you're really not going to improve GFR a whole lot by trying to get rid of the CNI therapy, and really just kind of minimization. And of course, we have a lot of interest in liver transplant tolerance, trying to remove immunosuppression at a later time. That's an active area of research. I'm not going to talk about that, but happy to answer any questions about that. But it's certainly an active area that I think the liver transplant population can indeed have strategies to completely eliminate immunosuppression compared to other organ transplants. So this is sort of summary of the renal sparing, which I've kind of focused on. It really delay and reduction of CNI exposure, minimizes acute kidney injury, but again, it typically requires antibody induction. And this early CNI reduction in combination, particularly mTOR inhibitors, may stabilize improved renal function without much penalty. There's some evidence of MMF and reduction in CNI may help. And of course, we're not talking about combined liver kidney transplant, particularly in this, but we know that there can be protection of the renal allograft in combined liver kidney transplantation. So again, this is sort of the summary of what we generally do. Most centers are using tacrolimus as their CNI, about 25% using induction, more than 50% using mycophenolate, 90% using corticosteroids and tapering by 3 to 6 months, some increased use of mTOR inhibitors for renal sparing. And I think the anti-CD40 is the drug that is now going into a phase 2 trial in liver transplantation. I think it's pretty exciting. There was a an effort for belatacept in liver transplant, and it was successful for about a year after, but there was a late increased risk of death in the patients who got belatacept, and that basically put the kibosh on that drug for liver transplant. But anti-CD40 may be something that's really promising to get rid of CNI therapy early and hopefully have the similar rejection rates. And the advantage here is, which is really nice, is over time to be able to use this subcutaneously in patients rather than having them come in for infusions. I think that's my last slide. Thanks.
Thank you, Josh. We're going to skip questions just in the sake of time, and we're going to take a 10-minute break. We're going to resume at 10 o'clock, and we are going to skip the second break so that we can make up time and be ready for lunch. So if you need to get out, this is your time.
seats, I'll introduce our next speaker, Dr. Andrew Adams from Emory. He's going to be talking about new immunosuppression agents, what's promising and what's failed.
All right, thanks. So I have the mandate to talk about some of the newer agents and then give a little bit of flavor of our personal experience with trying to take a new agent and use it. As Alex kind of alluded to in his talk, trials don't always resemble clinical practice. So, and then talk about some of the new agents that are coming forward and maybe where they're going to apply, and Josh kind of alluded to one of those in liver as well. So I do have some research funding from a couple of companies as well as the NIH. And just to illustrate, you've seen these well-worn slides, but the problems in transplantation and why do we actually need to develop new reagents. And I won't go through these pretty quickly in the interest of time, but certainly there's more and more people who need a transplant. Our 10-year outcomes are what really start to make us think that we have to develop different reagents, different drugs, or different ways of delivering those drugs to improve long-term outcomes. And this is from a nice review, and Dr. Mannon's here someplace, and I'll show kind of a slide of that. But these are some of the unmet needs when you start to think about why should we develop new reagents in transplantation. And as Alex touched on, some of these are to minimize comorbidities in the long run, to improve long-term graft function, et cetera, but also to improve quality of life, and to treat some of these conditions that are a little bit more difficult to control. Antibody-mediated rejection, as we know, both early and late in certain populations, and then to minimize some of those unwanted effects of immunosuppression like infection, malignancies, et cetera. So this was, I just recommend for your reading if you're interested in development of new immunosuppression, but kind of a viewpoint paper that was written by Mark Stiegel and Roz Mannon as well as others. And it just to highlight one figure from their paper about why this is necessary. If you look on in the black lines there on the left-hand side, shows kidney transplant population overall, survival of living and deceased donor kidney transplant recipients, the waitlist mortality in those that have a failed transplant. What's their 5-year survival? And you can see it hovers somewhere in the 50 to 70% range. And if you compare that to, for example, melanoma, colon cancer, kidney cancer, or breast cancer, it's not very far off. And so although we think we're doing a really good job in transplantation, there's certainly a lot of room for improvement. So the challenges in transplant, we don't have enough organs. I'll highlight just one kind of shameless plug for a potential solution for that in xenotransplant, and then the transplants don't last long enough. So just to highlight that the evolution of immunosuppression has really driven the successes that we see in transplantation today. So over time, over the last 50 plus years, you see the development of different immunosuppressant reagents. And we've gotten to the point today where, as Alex alluded to, we're kind of somewhat in a condition where we're, because of our own success, we have difficulties in developing new reagents where we have patient and graft survival, at least in kidney. In some other organs, that may not be true. When you start to think about lung and bowel and even heart, the success rates aren't quite as high. But the drive to develop new reagents is coupled with some of the constraints we have by the successes that we enjoy. So what's current immunosuppression? As Alex kind of highlighted well, it's using some type of CNI, mostly tacrolimus, some form of induction, the majority thymoglobulin, mycophenolate, and steroids. And that's what it ends up being in the day in the life of a transplant recipient, right? I think these are Alan Kirk's hands when he was at Emory. And these are the long-term problems that we see related with that, where death of a functioning graft, et cetera. That kind of went through fast. But we have cardiovascular, infectious malignancy, et cetera. It's really modulation of immunosuppression that can impact some of these. And so when you go down to a molecular, a cellular level, and look at what we're blocking in order to prevent rejection, we're blocking the interaction between, mostly we're talking about activation of T cells, which then can lead to the activation of B cells, the innate immune system that Leo covered so well earlier today. Thinking about what molecules do we need to target to be able to prevent rejection without some of the side effects that are associated with that. And so here, just thinking about that, the immunosuppression that we use today, it limits rejection, but we also see these other side effects where cells also use those pathways, for example, in normal neuronal pathways. So you see neurotoxicity, drives cardiovascular disease, the development of diabetes, and even the development of nephrotoxicity in the short term with higher doses of CNIs, or in the long term as you develop fibrosis, et cetera. So what we really need is kind of specific immunosuppression that's targeting the cells that are responsible for rejection and not having the side effects associated with standard immunosuppression right now. So it can be, we can talk about which cell to kind of target, but T cells mostly specifically. So just quickly, see how well you were listening when Leo went through things. What is co-stimulation blockade? I'm going to focus a few slides on this. So I don't know if it'll come up or not, but by raise of hands, I have no idea. Depleting macrophages to inhibit rejection, antibody or fusion proteins designed to block activation signals, or infusing Tregs to block T-cell mediated rejection, or none of the above. You know you put your email in when you did this, so people will know if you got it wrong. Okay. Did it not come up on the iPads? Oh, okay, there we go. So most people were, good job, Leo, wherever you went. For those people who had 4, I hope you were just trying to joke. All right. So co-stimulation blockade, focusing on these co-stimulatory signals that block T-cell activation. These are fusion proteins or antibodies, and they are ways to kind of maybe target more specifically immune system and avoid some of the side effects associated with standard immunosuppression that we use nowadays. And there are many of these molecules. One of the well-worn pathways is the CD28B7 pathway, CD8086. And the idea or concept behind this, is Leo kind of explained, is the T cell recognizes this antigen, but it needs additional signals to become activated. And when you have an antibody or a fusion protein, you can block that and inhibit the T cell, and sometimes in a way that it persists over time. So the first kind of co-stimulatory reagent that was developed was one that was developed from a molecule, in this case, a molecule that's a co-inhibitory molecule that's kind of the brake for the immune system, but that also competes with a co-stimulatory molecule, CD28, and this was CTLA-4 Ig. And so it was shown in mouse models by our group and many others to prevent transplant rejection. And this was over 20 years ago, and there was a lot of excitement within the field that, hey, we maybe have developed or found a way to specifically block the immune response without some of these side effects. And so then went on to be tested in non-human primate of kidney transplant, and unfortunately didn't work as well. So some therapies that work in mice don't work in monkeys or in people. And so this didn't limit its development. It became now a drug that's used for, say, rheumatoid arthritis, and can be used in kidney transplant as well in certain circumstances. We've shown that, and others have shown that in the absence, or when you can't get belatacept, for example, you can use abatacept as a replacement. But it isn't as effective, and that's kind of a recurring theme. And so these molecules, the co-stimulatory molecules, grew in number. And so you see a family here, more families in the TNF receptor superfamily. Not that you need to know these, but what you need to know is there are many of them, right? They're proliferating, and they've been used now not just in autoimmunity and in transplant and other conditions, but in cancer as well, to be able to try and turn on or turn off the immune system depending on what the condition is. And so one other kind of key concept is when you combine these therapies, there's a lot of redundancy. There's many of these. And so when you start to block more than one pathway, you can have better results, better intended results. And that's true when you turn on the immune system, for example, in cancer, combination therapies of co-inhibitory blockade, or when you try to turn off the immune system, for example, in transplant. And here, just a study that was shown in mouse from several decades ago that showed that the combination of blocking 2 pathways is better than 1. And then those results were translated into a preclinical model in non-human primates, where here Alan Kirk and Stuart Konecki, who are at the forefront of some of this research, showed that in a kidney transplant model in monkeys, that the combination of CTLA-4 Ig, a molecule to block CD28 and CD86 and CD40, could dramatically prolong survival in a preclinical model. So this drove a lot of excitement for the development of antibodies to block the CD40 or CD40 ligand pathway. pathway. And this is just another, to highlight that they saw long-term survival over a year with kind of dosing of these antibodies up front. And so this generated a lot of interest in the lay press. This is an islet study to show that at the same time as well. So this is late 90s, and it hit the New York Times, and so as well as many other media outlets, that this research that was going on to develop these new methods to kind of block rejection could have the potential to change the way that we treated patients. It was in CNN as well. This was Dr. Kirk at the time, back in the day, and this is kind of nice. This is an editorial that talked about he and Dr. Harlan, their studies in the non-human primate, and we know Dr. Kirk today is the editor of American Journal of Transplantation. But what happened, right? So these studies had clinical trials both in autoimmunity and in transplant, and unfortunately, they had to halt those trials because of untoward effects. And so there were two different reagents from different companies, Biogen and IDEC, that had anti-CD154, anti-CD40 ligand antibodies, and they used those in both autoimmunity and in transplant, and showed not only just a lack of efficacy in some circumstances, but both had thromboembolic events that were unanticipated and kind of stopped the trial and the development of this pathway. So a really promising avenue to prevent transplant rejection that led to long-term survival in preclinical models that had unintended consequences in the clinical trials. And so it really just halted their development some 15 plus years ago. And so later on, going back to kind of the drawing board and trying to figure this out, they found out that the reason maybe some of these clots developed was that CD40 ligand or CD154 can be shed in the blood, this molecule. It's found on platelets, and platelets also express the FC receptor, so an antibody that can bind to the CD154 that's soluble and to the FC receptor on platelets can then cross-link platelets and cause clot. And so this was important because the development of antibodies that go either after the receptor, CD40, or that can't bind the FC receptor were now kind of the intent to develop to be able to prevent this complication, right? So back to kind of belatacept and the development of fusion protein to block this. In the meantime, when this antibody against CD154 kind of stuck in its development, belatacept was developed, as you all probably know, by making mutations in the molecule of CTLA-4 Ig to have it have higher binding affinity and avidity to human CD80 and 86. And so after they mutated this and made the belatacept, at the time it was called LEA29Y because of the amino acid substitutions that were changed, it was found to be more potent both in vitro and in some non-human primate studies that we did, where belatacept doesn't cause tolerance but extends survival compared to abatacept. So it's kind of the rational development of a molecule to make it more potent, to bind more tightly and prevent activation of the T cells and rejection. And so that translated, when you combine it with conventional immunosuppression, to prolong survival and led to the basis for the benefit trial, which Alex talked about, which I won't go through, but this is the phase 2 trial. I'll just mention a couple of slides from the phase 3 trial, where you looked at a more intense and less intense regimen of belatacept compared to cyclosporin, which Alex explained was the standard of care mandated by the FDA at the time. And what I wanted to highlight is that in trials, when you start to think about use, it's a highly selected population, right? So more homogeneous, not very immunologically high risk, so the sense that these weren't retransplant candidates, low PRA, and what you saw was an incredible benefit from as far as the renal function went at 5 and then at 7 years, but you also saw some drawbacks. You had one of the other benefits was less cholesterol, less blood pressure agents, so better cardiovascular risk in the belatacept treated people versus patients that were treated with cyclosporin. But you saw kind of in this subset of population the development of PTLD in patients that had EBV naive that received belatacept. And so kind of a black box warning to use there that when you see EBV for the first time in the setting of belatacept treatment, you have a higher tendency to develop EBV and PTLD as well. And then rejection was much higher. So rejection in the belatacept groups compared to a very low rate of rejection in the cyclosporin group, almost abnormally low for that group, was much higher. So Despite that, when you looked at the 7-year outcomes, when you used a combined endpoint for graft survival, patient survival, and GFR, you saw a benefit from belatacept treatment. And so that benefit of GFR sustained over time compared to cyclosporin. So that led to its approval in 2011. So if I wanted to poll the audience here, if you were to say at my center, as far as you know, for kidney transplant, we never use belatacept, we rarely use it, we only use it in special circumstances, perhaps for people with low GFR, or we routinely use it. So good evidence that you have better GFR over time, some higher rates of rejection. How do we use it now? All right. So, as Alex suggested, about half of the people in the room that do use it in special circumstances, maybe for conversion, maybe for CNI intolerance, etc. And then there's a couple of people, probably from my center, that use it routinely for most of the patients. And in some patients, some people never use it, right? And so despite having a new reagent that has a lot of promise, there are a lot of problems associated with it. And I'll show you just briefly what we ran into. So we used kind of a TAC-based regimen, IL-2 receptor induction. We said, well, just swap it out, use it as it is per label. And as Alex kind of alluded to, it's a different population that we serve, so not as homogeneous as the clinical trial, more highly sensitized, higher immunologic risk, right? And so what we saw was a much higher rate of rejection, early biopsy-proven rejection, in the belatacept-treated per label patients than in our kind of historic TAC cohort. So this is not a controlled trial. This was just us using it after it was approved in a way that was per the label. And so that rejection occurred very early and was quite a surprise. And so we had to go back to the drawing board and kind of figure this out. And so just to highlight the example of what do you do with a new reagent. Fortunately, patient and graft survival were equivalent, and we saw the benefit of renal function despite all that rejection. And so there is something to be said about having rejection on belatacept versus tacrolimus. And the question is development of DSA, development of fibrosis, et cetera. And those are kind of unanswered questions that remain. And so you have this early risk of rejection that we all know about, and what to do with that. And what we decided to do is that for half of those patients, and we can't really determine which ones those would be, we have to cover them with additional immunosuppression. So everybody has to get a little bit more immunosuppression if you're developing a protocol. Ideally, you'd be able to identify which patients would be able to not have extra immunosuppression and which ones would. And so we covered those patients for that period of time with something that we knew worked, right, at the time and that was available. And this was to use tacrolimus for a short period of time afterwards. And we published that, so if you want to look at the details. But basically, it's a lower dose of tacrolimus for the first 9 months. And what we found is you needed that to overcome the difference in rejection rates. And so the freedom from rejection is the same in that group. You still see equal patient and graft survival, and you see a benefit with belatacept over time. So one way you can overcome some of the challenges with a new reagent in that setting. And as Alex highlighted, we saw the same difference in decreased DSA rates, which may drive late outcomes or do drive late outcomes in patients, and belatacept may have a role there, whether it's because of compliance or its unique mechanism of action. And so there are certainly other people who are using belatacept in many different ways, as we kind of talked about, the group at UCSF using it with thymoglobulin induction. There's a whole host of articles over the past kind of 5+ years where you can look at how they're using it. The question, as Josh brought up, is whether there's a role for it in liver again, even though the trial, although fraught with some problems, the potential to use it in patients maybe in a delayed fashion that have renal insufficiency there. And then in cardiothoracic transplant too, more and more people that are using it in both heart and lung transplant for its benefits to prevent DSA, but also for renal function. So there are a lot of other sponsored trials that are ongoing that we're awaiting some of the results from. They're trickling out to see how to best use belatacept as a new reagent. But despite that, because of the success that we see with, say, for example, thymoglobulin induction, tacrolimus, MMF plus or minus steroids, there's a reticence to kind of use a new reagent that has problems, not just immunologic problems with higher rates of rejection, and potentially sometimes figuring out how to use it in the setting of infection, but also practical problems with having to have an IV infusion in patients monthly for the rest of their lives. And so just from this portion, thinking about belatacept as a unique new agent that does provide better long-term renal function. The rejections can be fairly challenging, and you need additional strategies to mitigate that, particularly in higher risk patients. And so learning how to do that is a challenge, and doing that in the setting of clinical trials is also can potentially be challenging. So what are the next reagents that build on some of the things that we learned from belatacept? Well, just to highlight this kind of balance between positive signals and negative signals that drive T cell activation. The negative signal that we talked about that was based on the development of ABBA and belatacept, CTLA-4, is upregulated on all activated T cells. And so you see that as T cells get activated, there's the gas pedal that gets pressed to kind of get them to proliferate and fight off infections or potentially rejection. And there's also the brake pedal that holds back them from causing autoimmunity. And so it's this tight regulation between positive and negative signals. And ultimately, it's the summation of that that determines whether a T cell's going to be activated and do its job or not. So this concept of blocking the positive but not the negative has been around for a while. So belatacept blocks the signals that bind to both not only the positive but also the negative signals. Oh, I do have a pointer. So it's a fusion protein from CTLA-4, and they share binding capacity for the ligands on the antigen presenting cell. And so when you give belatacept, you're blocking positive signals and negative signals. So why not just block the positive and leave the brake on to restrain the T cell response? And like I mentioned, that's not a new concept. There was an anti-CD28 antibody that was developed in the past, but as you looked at it, what happens is if you bind this and activate the T cell by the antibody binding, you end up with cytokine storm. So this was an antibody that was developed in mice and in monkeys, and everything looked great, and they put it in a clinical trial in a phase 1, testing it in healthy patients, and unfortunately, those patients developed cytokine storm, and some of them ended up in the ICU, intubated, very sick. And so that kind of curtailed the development of that pathway for a period of time as kind of a recurring theme. Now all of a sudden, companies aren't interested. So back to the drawing board, we partnered with Bristol Myers Squibb, and they developed kind of a unique way to target this area, and this is lulizumab. It's a CD28 specific domain antibody, and it's monovalent, so it doesn't cross-link and activate the T cell, and doesn't cause this cytokine release syndrome, right? So we tested it in the mouse and said, is it better or is it the same as abatacept? And this is work from my colleague Mandy Ford at Emory, and showed that in a mouse model, this looked superior to CTLA-4 Ig, to abatacept, kind of the belatacept equivalent in mice. So encouraging. So we went ahead and tested that alone or in combination in a non-human primate kidney transplant model to see, does it have potential to be used for transplant in people? And what we saw was not something that causes tolerance, but something that's better than belatacept, which has, as a monotherapy, a median survival of about a month, versus in lulizumab, we saw long-term survival in some animals. And so promising data to suggest maybe it should be developed in transplant. And so it appeared safe and efficacious. It was used in a clinical trial in lupus, and although it didn't show efficacy in lupus, there was good safety signature, so it didn't look like it had any over immunosuppression there, and the potential to use it in transplant. And so we have a grant to look at a clinical trial of lulizumab, and Flavio has a similar trial, but we're doing a phase 2 trial that's going to look at lulizumab, kind of the newer version of belatacept that's more specific to inhibiting just the positive signal, not the negative signal, in kidney transplant recipients with thymo induction, right? And so hopefully in a few years we'll know, is this reagent something better that can have the benefits of belatacept but not have the rejection that's associated with that? And we'll look at the same things that were looked at in kind of the benefit trial. And this is kind of the proposed immunosuppression protocol where patients will get thymoglobulin induction, lulizumab or TAC with MMF and a steroid taper down to 5 milligrams. So what about other pathways? What about back to that CD40, CD154 pathway, which we talked about earlier, that was even more promising than belatacept, but had the blood clotting or the thromboembolic events that really stopped its development. And so the focus has been on developing anti-CD40s, as Josh kind of suggested, and there have been a couple of those. So go after the receptor that wasn't expressed and didn't cause the thromboembolic events. And this was one by Astellas, and this was a kidney transplant phase 2 trial that was performed looking at the use of anti-CD40 with and without a little bit of TAC. And so when they used it without tacrolimus, same type of result, higher rates of rejection. And when they used it kind of with tacrolimus, minimized, there were some adverse events compared to just the TAC alone comparator arm. And so that kind of, for that company and that particular antibody, stopped the development. And this is just to highlight some of those results there. So the other anti-CD40 that's out there and is promising is one by Novartis, this CFZ533, and that's been used in the kidney transplant recipients now and showed the same benefit in GFR, so comparable to tacrolimus. It's very small numbers. It's a small trial, the little data that we have that's been released. It did show potentially a lower rate of new onset diabetes, and there are larger trials now that are ongoing in kidney and then in liver transplant as well. And so there may be some potential here to use, again, a different costimulatory molecule and see what its efficacy is in organ transplant. And then the question is whether you start to combine some of these reagents as they come out. And then we tested another anti-CD154 antibody, and I'll tell you why this might be important in a couple of slides, that isn't able to bind to the FC receptor and activate the platelets and cause the clot. And it showed good efficacy in a kidney transplant model in primates. The other anti-CD154s that are out there, this is one by Biogen or UCB that was a pegylated version, so of a monover that didn't bind to the FC receptor again. And unfortunately, that didn't show efficacy in autoimmunity, so there's a much bigger kind of catchment, a lot more patients in autoimmunity than are in transplant. So many of these drugs are tried there first. And unfortunately, when they don't have success there, there's not a lot of impetus for the company to pursue trials in transplant. So that's some of the challenge of getting some of these new agents to market in transplant. The other one that's pretty encouraging is one by Viela Bio. This is not an antibody. Instead, there's new technology now where they develop proteins that they've screened that are able to interact and inhibit the ability of CD154 and CD40 to bind to each other. So just like an antibody would to interrupt those, but they're not antibody-based, and so they don't bind to FC receptors. They don't activate the immune system in other ways. And it's actually been used in people, and this came out earlier this year they used it not only in preclinical models, but also in patients with rheumatoid arthritis, and showed that it reduced disease activity and showed some really positive results there. And so there's a trial planned for kidney transplant in the near future. So why might targeting the CD40, CD154 pathway be really important? Well, you probably at least have seen different lay press about the recent successes in xenotransplantation. So the other big kind of elephant, to use another animal analogy, in the room, right, is that we don't have enough organs to go around. And so there's been a lot of effort over the last several decades at developing xenotransplantation. It really has never gotten there until the advent of kind of CRISPR-Cas with the ability to make genetically modified animals and make them more human-like to prevent the early antibody-mediated rejection that we would see. And there's some in the room that have worked on this in the past as well. And so it's really now in the last couple of years where you see articles in much of the lay press and some really exciting articles in the scientific literature that suggest this may be actually possible, and it's not just kind of fiction that comes back and forth with a teaser that this might be actually clinically applicable. And so this is just to hit home. This is David Cooper, one of the people that's been very prevalent in the literature, but I like the title of his review article. It said, "Bringing Home the Bacon, an update on kidney xenotransplantation." So using pig organs, in this case kidneys, into monkeys to look at the preclinical model. Where are we going? If you looked 20, 30 years ago, the survival times could be measured in days. And now we're talking about measuring them in months to years. And more recently, we have data to show that we have surviving animals now in this preclinical model out over 500 days. But what's really been clear through all of those studies in any organ type, kidney, heart, and islet, which have had some significant successes, is that when you use conventional immunosuppression like tacrolimus or other CNIs, it doesn't really work in these models. It's targeting that CD40, CD154 pathway that prolongs survival, at least in preclinical models. So the question is, to translate this, are we going to need a reagent that's going to be effective there? And that may be an additional reason for the development of these molecules. And what we found is that CD154 might be even more important for some reason than CD40. And this really has to go back to some of those concepts that Leo presented, where the T cell or some of those specific T cell subsets, follicular helper T cells and B cells, and the generation of antibody that drives kind of early rejection. But you can see where you start to think in preclinical models where you have survival now in a life-sustaining kidney or heart that's out, into the year mark. At what point is it ethically acceptable to go ahead and try this in patients who are on the wait list that may never get a transplant? And what reagents are we going to use there? Oops. Somebody just shine it in their eyes. So the last couple of slides here, other pathways that have been tried in transplant and are still kind of going, and some of them are not. JAK kinase inhibitors were tried, developed for rheumatoid arthritis. They're effective at preventing rejection and preserving renal function, but we saw increased rates of infection. Another protein kinase C inhibitor that was not effective in preventing rejection. Some of this has to do with the way the trials are developed, and some of it is inefficacy in the reagent and the pathway. Tocilizumab, we heard a little bit in heart transplant that's being used. It's really important in inhibiting B-cell responses and antibodies, so could it be used as an adjunct, seen in preclinical trials in lung transplant as well? There may be a benefit with the generation of regulatory T cells, which can prevent rejection. And then lastly, just to think about the sensitized patients or patients that develop acute antibody-mediated rejection. How do we kind of deal with that? So there are a lot of different reagents, a lot of research now that's ongoing. One I'll just highlight that has a recent New England Journal small clinical trial, IDIS, which is kind of a unique way to target antibody. There's inhibitors of the complement system, looking at signals that are important for B cells or depleting B cells, new depleting B cell antibodies. Proteasome inhibition, which targets plasma cells, and the combination of proteasome inhibition and co-stimulatory blockade. Dr. Anita Chong and her colleagues have shown that combination, along with Dr. Konecny at Duke, can be really potent at inhibiting, getting rid of antibody that's existing towards the donor. And this is just to show you what's going on with IDIS. So this is an enzyme that strep pyogenes makes, is kind of a defense mechanism that degrades IgG so it can't be opsonized and gotten rid of. And so people have taken advantage of that. And this is a study by Stan Jordan and a group in Sweden that looked at its use. And so that's kind of the concept of the way it works. If you take all of your immunoglobulin, this enzyme then cleaves it into FAB2 and FC, so now it's not functional. So even though it binds, it can't opsonize, it can't bind to FC receptors, it can't bind complement, et cetera. And this happens very quickly. So within 2 hours, you can take all of your IgG in your body and cleave it into these parts so that it's no longer pathogenic. And so they looked at it in highly sensitized patients, and I'll just go quickly this so we don't go over time. But this is the groups here in Sweden and the United States, and you can see that these are highly sensitized patients that typically would have early acute antibody-mediated rejection and had really good results, at least in the near term. The problem is that some of that antibody comes back. So some of these combination therapies to get rid of all your antibody that you had, that you could think about the potential infectious complications that might arise with that, but that you could reduce antibody-mediated rejection, and then how do you keep that antibody from coming back and causing antibody-mediated rejection within the first month or two after transplant. So just as a closing question, which of the following kind of best describes your opinion on the current use of on the use of co-stimulation blockade in kidney transplant recipients? I would never use it. They're not good enough. It makes sense, but I'm not really willing to use it given the high rate of rejection or other problems. I would use it now, but only in low immunologic risk patients or only in certain patient populations, like those that are at high risk of DGF or et cetera. Or I would use it in everybody, or some combination C and D. See if I've changed anybody's opinion. Okay. Well, all right, interesting. Good. I think most people are still in the C and D range, right? Which I think is where most people are targeted to low immunologic risk patients where maybe you don't have the rejection into those with marginal function. It'd be nice with these newer reagents if we get to the point where we can use it. Okay. Go back. We can go back to, or we can get reagents that we can use confidently without those side effects, but have the benefits that have been seen both preclinically in some of these models and in the clinical trials in belatacim. So I'll leave it at that. Thanks.
Thank you, Dr. Adams. For the purpose of time, we're going to skip questions. We're getting a lot of amazing questions, though, so I encourage you to approach the faculty afterwards to ask your questions. Up next, we have Dr. Kristen Rogers presenting a couple interesting cases in immunosuppression.
Thank you, Barrett. Thank you all. And being one of the moderators, I do feel very obligated to try to stay on time. So I've set myself a timer, and we are going to try to do this. I have 58 slides. I know I'm not going to get through them all, so we'll probably focus on just the first two cases. So let me go to our first case. I have no disclosures. So let's start with Mr. TR, 55-year-old guy who was called in for a deceased donor renal transplant. He has a history of HIV and CDC criteria for AIDS, as well as some control, and he's controlled on ARVs. He has end-stage renal disease related to foscarnet. He has renal anal HPV lesions treated with ablation, cardiac echo that shows some heart failure, and his medications are listed there for you. I want to highlight his antiretroviral regimen, which includes darunavir with boosted ritonavir, tenofovir, and lamivudine. First question for y'all. We have a lot of audience response. We'll have to go through them quickly. I just want you to hit your first thought and go for it. So what should you give TR for induction on call to the OR? Nothing. He has HIV and he will die from AIDS. No induction. Thymo, just steroids, or basiliximab? All right. Good. Excellent. A lot of people are feeling pretty confident with thymoglobulin. So let's talk about the data. So given the increase in number of HIV-positive transplants, we've seen a dramatic shift in how people are using induction in this patient population. And this nice review of data from the SRTR really describes how this has changed over time, looking at the early era in 2000 to 2003, where a number of centers really did not use much in the way of thymoglobulin or induction. You can see highlighting in the red a dramatic increase in the number of thymoglobulin over time. They also looked specifically in this study at the impact of various induction agents on infection, and they did not find any influence of induction on infection. They did find, however, a beneficial effect of induction with thymoglobulin on prevention of rejection. So with that information, we updated the 2019 guidelines to speak to the use of induction in this population. And it specifically states that induction therapy with either lymphocyte depletion or IL-2 receptor blockers should be used. And lymphocyte depleting induction is recommended for high immunologic risk candidates, which include your African American, your patients with DSAs, and those with prior transplants. So how would you address his antiretroviral regimen? I apologize, there's a typo on the bottom. I changed fosamparnavir to darunavir, so he is still on boosted darunavir coming into transplant. Would you continue his home regimen? Would you switch it to a combination of dolutegravir and Descovy? Would you discontinue it and add on a simple combined fixed dose product called Genvoya? Or would you say he doesn't need any ARVs? Let's enter your... All right, let's go to the answers. We are going to put him on Descovy. Excellent. In combination with Tivicay. So the first study is looking at this interaction, really showed some dramatic effects of the potency of the interaction, with a lot of patients having significant toxicities and elevated levels. These first two here just show dramatic decreases in the number of the amount of weekly tacro needed with use of nelfinavir. And this one here shows initiation of nelfinavir, toxicity at 120, level of 120, and the need for sporadic dosing of tacrolimus. One would think with this significant increase in level that the interaction would result in overexposure of tacro, but this is actually quite the opposite. When you look at a pharmacokinetic model of the once weekly or every other day dosing of TAC, what you actually see is a dramatic decrease in your area under the curve in the patients who receive the intermittent dosing compared to the normal BID dosing. So a 44% decrease in your AUC in the patients who are on PIs. And this may be part of the reason why these patients actually have higher rejection rates. So this was a study that was published this year looking at the experience at Mount Sinai, where they looked at the impact of various antiretroviral regimens on rejection and outcomes. And you can see these patients, as expected, did have somewhat of a higher rate of rejection, about 30% one-year rejection. But you could see the patients who had boosted HIV regimens with ritonavir had rejection rates of close to 60%. This in comparison to those who did not have boosted HIV regimens, closer to 20%. So an improved rejection rate using a non-boosted PI regimen. This did not impact patient or graft survival. And then also looking at a larger scale study, Dr. Sorensky looked at the SRTR database and also found similar results with a decreased graft survival with PIs and also increased hazard ratio for all-cause allograft loss in the first year with use of PIs. So let's think about our patient again. He's going to come back to clinic now. He was lost to follow-up for 6 months. He had a 1-week history of nausea, vomiting, headache, kidney injury. Immunosuppression is standard. We find out his local provider put him on Stribild, and his tacro level is now 60. We've got a little bit of a problem here. So what component of Stribild causes this issue? Let's go on to the answer. It is the carboxystat, exactly. So carboxystat or Stribild was FDA approved in 2012. And I was actually giving a talk on this topic in 2013, and I was looking to see, is there any data on this? And sure enough, in 2010, there was actually a nice PK study looking at the impact of ritonavir versus carboxystat on midazolam clearance. This kind of gives you an idea of how potent this interaction is, and I had always thought, I'm like, this is going to be trouble. I don't know who's going to do it or when it's going to get published. I probably should have published something about this then, but I didn't. But you can see here, ritonavir, and this is the dose of carboxystat in Stribild. So comparable to the inhibition that you see with ritonavir. The PI has very little information about the severity of this interaction. It just says therapeutic monitoring should be recommended. Probably not sufficient. And this was demonstrated in a case series published with a patient who was initiated on Stribild who ended up with a tacro level of 112. So illustrating that just monitoring is not sufficient. So how would you manage a patient that walks into your clinic with this level of TAC toxicity? Would you put them on dialysis, plasma exchange, gastric lavage, or would you give them some enzyme-inducing meds such as phenytoin? Let's answer your questions. Let's pull them up quickly. All right. Okay, we got a good mix. Excellent. So in the literature, there is actually a decent amount of data on using phenytoin for severe CNI toxicity. In this small case series, they looked at patients who had elevated levels over 30, giving them approximately 3 days of phenytoin. When we look at this case was actually taken from a colleague of mine, Samir Patel, who presented it at this meeting a few years ago. He published this experience, and this is exactly what they did. They gave phenytoin for 3 days, and you can see the dramatic decline in the TAC levels with use of phenytoin. So coming back to choice of ARVs, based on the recent guidelines, protease inhibitors, and those including carboxystat should be avoided. Regimens including these medications, avoiding these medications should be implemented prior to transplant unless there's no alternative option. Use of PIs or enhancers such as carboxystat, if they're necessary, there are significant reductions in your calcineurin inhibitors, typically down to once a week, that are necessary. and use of integrase inhibitors would be preferred if at all possible. Let's go quickly through this next case. We have 1 minute to stay on time. So not feeling well, here's his past medical history, here are his meds, tacrotoxic, renal failure. Oh, I forgot the most important point, diarrhea. 8 loose bowel movements per day. So what is the cause of his diarrhea? Or what is the cause of his elevated TAC level? Is it decreased renal clearance in the setting of AKI? Is it increased exposure due to alteration of intestinal function in the setting of diarrhea? Lab error because TAC should lower, or diarrhea should lower the TAC level? Or is it just CMV, which causes TAC levels to go up? All right, most everybody has this concept. Let's just quickly talk. Come on, let's go. We'll talk about the impact of diarrhea on TAC and how it happens. So it's basically because of the increase in GI transit time that we see with diarrhea. We think of TAC being metabolized through CYP3A4, which is primarily in your liver, but it's in your gut too. So when you have diarrhea, things move quickly. You're not getting the exposure. My timer's saying that I'm done, so let's breeze through this quickly. So the patient comes in, he gets admitted, he gets some IV fluids, his TAC level's coming down, his creatinine's resolved. Now what do? Time to go home. What's your follow-up plan? Are you going to resume his home dose of 6 BID, follow up with labs? Are you going to reevaluate because the impact of diarrhea persists after resolution? Hold 2 more doses, drop them down to 3 BID? Continue to hold TAC and check labs in 1 week? Or convert TAC to sirolimus to prevent further renal dysfunction? All right, let's pull up some answers. Good, about the vast majority of you got the right answer. So hold 2 more doses, resume at a lower dose. Even though the diarrhea is resolved, it may not actually be resolved on the true effect of the CYP3A4. So just looking quickly at the impact of diarrhea, there have been a few nice studies looking at this. This first one here looks at the increase in the Cmax that you see with diarrhea. This can lead to patients feeling much worse, headaches, tremors, etc. And you can see an increase in the area under the curve as well with diarrhea. So would you empirically decrease tacro doses in the setting of diarrhea? Somebody presents to the hospital, diarrhea. Are we going to cut their dose empirically in half, or are you going to watch and wait? Yes or no? Quick one? No. Good. Most people have the right answer there. And that's because the impact of diarrhea is quite variable. This is that same study, but it just shows you the dramatic difference in the troughs in patients who have diarrhea. So you can't say that everybody's going to have the same effect of diarrhea because, again, it probably comes back to the varying amounts of CYP3A5 in their gut and how that change in diarrhea impacts that. But you can see here also decrease in the tacro dose to account for the diarrhea. That decrease in dose is actually sustained for a while, and it sometimes is not resolved and the dose is not corrected back to their original dose for upwards of 2 weeks after resolution of diarrhea. So does the number of watery stools per day matter? Yes or no? Or is all diarrhea the same? Let's go to the next. Yes? No? What is the magic number of watery stools? How many watery stools do you have to be considered diarrhea and impact your TAC? 2, 4, 6, 8, 2, 4, 6, 10, 12? We're kind of in the middle, 4 to 6. That's actually often what I say to people. So this is important because there is actually data that shows how much diarrhea matters. The study here looks at 2 to 3 stools per day, or 1 per day within the prior 2 weeks. And that amount, it does not impact TAC levels. What about cyclosporin? Can you just switch to cyclosporin or assume your cyclosporin patients are going to have the same effect or no? I see the answer. No, correct. Same thing. Doesn't happen with cyclosporin. So this is just an illustration of tacro on the left, cyclo on the right. Your patients on tacro have this dramatic increase in their TAC levels. With diarrhea, small number of patients on cyclosporin, but there is not the same impact seen there. and then further looking at the impact of diarrhea on cyclosporin, looking at trends and levels, and TAC versus cyclosporin. And the theory behind this is thought to be because of the potential different effect of diarrhea on CYP3A4 versus P-glycoprotein. All right, 5 minutes over what I said I wanted to do. But this is the third case. Hopefully you'll have access to the cases. This one really focuses on genetic polymorphisms in CYP3A5 and how you would address a patient who can't get therapeutic TAC levels. But you'll have this hopefully in your access to slides, and Barrett will be talking much more about this afternoon. So at this time, I am going to hand it over to Dr. Roz Mannon. Where's Roz? Oh, there she is. I told you I'd try to stay on time, best I could. All right. So Roz is going to present what are the next steps, the future of transplant immunosuppression.
I don't know who they are, but they were like,
They have good PharmDs at their center.
I think they have all the, they do all the interactions. Do you have the, Thank you. Well, thanks for having me and getting us all back online. And this is like kind of a little bit of a sophisticated topic, so I'm happy to answer questions. And it's very nice the organizers are taking away time from some of the other presentations to talk about the future of immunosuppression. Now, I'm not talking about the drugs that you just heard about. I'm talking about how drugs get approved, what's going on in the field, and how maybe you can get involved. And I do have quite a number of disclosures, mostly all grant support. And I'm going to be sometimes alluding to off-label use, but most specifically, God, they cut my time to 15 minutes? Okay. So this is my outline. I'm just, oh no, thank you. See, I spoke and now it's back up. So really the goal here is to talk about the unmet needs in transplant. That's kind of what this conference and meeting is about. To talk about barriers to developing new drug therapies. I know we talked about the hypotheticals and preclinical models, but how do you get those into human beings? And then spend a little bit of time, you can start running the clock, guys, because I'll be up here, I can just talk all day. And then talk about interactions with the Food and Drug Administration through a private-public partnership that was created about 2 years ago called the Transplant Therapeutic Consortium. So when I was, about, almost 2 decades ago now, in 2002, I went to the NIH. I was super excited. We were going to study novel immunosuppressive therapies there. We had a transplant program with Alan Kirk, and I was the only nephrologist, so I really had a unique opportunity, and I had my laboratory, and it was a very bench to bedside. And there were all these drugs that we talked about here. That seemingly were very exciting and had new potential, but only about 6 years later, another point of view published in the American Journal of Transplant indicated that there was kind of a dead end, that the first decade seemed very disappointing in the new millennium. No new therapeutic agents have been approved. And they're created, and this is a famous slide by Dr. Flavio Vincenti that he loaned me that I adapted, that there was this, grim reality that many of these agents that were being tested during that decade failed to launch. And there were issues in terms of study design that I'll allude to shortly. And some of these agents, as you'll recognize, their names are actually in other they're in autoimmune disease. And again, that brings to mind that our patients are quite ill. And while kidney transplantation was really, not only do they do preservation techniques, but the kidney transplant patient was really the platform for many immunosuppressive therapies. And now no longer is that the case. That many of these therapies that are on this slide have gone and launched into autoimmune disease. And again, when you look at a patient with psoriasis and you look at a patient with liver failure, who do you think is sicker? And that's one of the problems. So this is the most recent new drug application approvals. You can see we had the Rapamune, the mTORs, took 10 years later to get another mTOR approved. The only sort of new agent was belatacept in 2011, and then the long-acting tacrolimus therapies, Astigraph, which preceded Envarsus, and it took Envarsus 3 years to get de novo approval on a label, meaning you can use it at the time right after transplantation. So again, though I'm pleased to see these long-acting agents and the promotion of adherence, and many of us can argue that this is a novel way of delivering the drug compared to the Astigraph delivery, they're really still CNIs. So what are the unmet needs? And I think they're summarized here and addressed at this conference, including improving long-term patient survival of all transplants, improving the long-term function of those. And I don't see our co-director in here, but that includes, composite tissue and also xenotransplantation. Increasing the number of donors and increasing the function of those organs that are non-ideal. Immunosuppressive therapies that minimize comorbidities and improve the quality of life of our patients. Avoiding viral diseases and cancers when possible. And then we have very specific therapeutic purposes now. We have antibody-mediated injury, which is not well addressed. We talked about delayed graft function, tolerance, and recurrent diseases, for example. So I think one of the biggest, hurdles we have is the misconception that our outcomes are really outstanding and cannot be improved upon. And for a person who made their career on late graft failure, for the last 20 years, to me, or maybe it's 25 now, this is really something that I was always fighting. I was fighting when I was writing my grants. Now it's not such a big fight, but now the fight is everybody else is studying it too. So I didn't win before, and I'm not winning now. So here is an example of our mindset, okay? So cancer's bad, that's in the red columns here, melanoma, colon, regional breast cancer, renal cell, and over here are the kidney patients that, this is their percent survival at 5 years. And if you put the group, deceased donor on the wait list, living donor transplant patients, transplanted patients, living, deceased, wait list, and failed transplant, and you look at the overall 5-year survival, these patients are not really doing a whole lot better than some of these regional cancers. Now, there was a reason I didn't go to oncology. I loved oncology. I did 6 months of my fellowship. I could be an onconephrologist probably. Well, not now because my skills are out of date. But I said to myself, oh, that's, a fatal disease. Well, I never realized that kidney failure is a fatal disease. And we think of liver and heart and lung. And so I challenge all the nephrologists to say that we can do better. And we can do better for the other organs as well. And these are our long-term graft survivals. Now, this is some older data because you got to wait, you can't get this data from this year, for 10 years from 2018. But I'd argue that these numbers are still relevant. And when you talk to a patient with a deceased donor transplant, you're talking about a half-life of 10 years. That's nothing to write home about. So, and then the other thing is I know we talked about diarrhea and the impact, but I think we don't take into account as much patient-reported outcomes. When I see a patient and I'm super busy and I see the creatinine's fine, there's no proteinuria, blood pressure's good, blood sugar's good, and then they say, I don't feel well, I'm tired, doctor, and I just take a deep breath and, and say, okay, are you sleeping well? But these are the things that interrupt life, and these are the things that interfere with immunosuppressive adherence. Diarrhea, headaches, tremors, difficulty thinking. And I mean, many of us who have very extensive practices have heard these complaints. I worry about the diabetes and hypertension, the control. And then another concern almost every patient has is the return to dialysis, which often equates to death. And a really amazing group of individuals led by Alison Tong across continents is called the Standardized Outcomes in Nephrology, and she did a specific attempt in kidney transplantation. And these were the patient-reported outcomes that she focused on and have given us sort of a platform to think about patient-reported outcome measures, which I'll show you in terms of drug approval. So this got me all fired up in my year prior to presidency at the AST. Oh my God, ASN. That was a Freudian slip. Strike it from the record. Nah, it's okay. I've made peace, and I actually do quite a bit for ASN. But that's a parenthetical statement being recorded. So during the year coming into presidency, and as a president, you have access to a lot of opportunities. And so I thought, this is the one last stand in terms of changing things. And so when we initially approached FDA, our transplant division of FDA, which was then with infectious diseases and ophthalmic products, don't ask why, because they're all related, we talked about the problems and the stagnation in drug development, and they said, well, we need a white paper, we need data. So I drafted Rita Alloway, some of you may have heard of her, Tim Schroeder, who was then ran a company called CTI. This is a major clinical research organization that initially focused in transplant and now is international. Flavia Vincendi from UCSF and myself, we were the executive editors, and we wrote this very long document about the AST's recommendations for a memo of understanding with FDA to improve transplant therapies. This was like 50 pages, and that's the website location. We never submitted to a journal because it was just too difficult. But the day before my presidency ended, it's it's brilliant how you do these things. We had to deliver this to them, and it had to be approved and read by everybody. And so the cover letter included really that this was a notion of having a memory of understanding with the FDA, that the society would interact directly with FDA, and that we would look at the background of the problems in drug development, a blueprint for how to move forward. And this document addressed many things, including research regulation, electronic health access to medical records, but the main thing was approaching drug development in a new way for transplantation, and thinking of some of the introductory material, the barriers that we have in the field, and also how to overcome it. Coincidentally, there was the FDA Transplant Division organized with AST and ASTS an open forum about clinical trials, and this led to an international society publication and a meeting right adjacent to it, looking at some of the lessons we had learned from the oncology field, and in particular, sort of looking at more rapid drug development approval, the disparities between oncology drug development, which has exploded, as you know, and importantly, the surrogate endpoints that were used in oncology, that was disease-free survival, and objective responses to tumors and this progression. So you know that many of some of these checkpoint inhibitors, for example, were rapidly approved just based on patients surviving a few more months. Now, with the argument that kidney failure and kidney transplantation survival is very similar to oncology, we had to build a case for reform. The next publication was, again, a group effort between, again, myself and Dr. Alloway, as well as Mark Stiegel from the ASTS, and Randy Morris, who is a cardiac surgeon, but a transplant investigator, primarily looking at novel therapeutics, who's now retired. And we developed this personal viewpoint by our multiple conversations, and we identified multiple barriers for the development of new therapies. We've already talked about our general misconceptions about it, but also overcoming the transplant community's barriers and being so risk averse. And that's a discussion point that you've had in your breakouts, as well as this organ discard rate. But also we highlighted that biopharmaceutical industry issues, the return of investment, and the whole notion that we have these dedicated medical science liaisons and dedicated professionals that are focused on transplant drugs, and some of them are here today, but yet their higher-ups don't see it that way. I mean, you make a ton of money on, on some of these sildenafil. I mean, you make more money on an antihypertensive than you're going to ever make in the lifetime. And so we have a small cohort of patients that we have to overcome, that this return of investment is important. And then, of course, the regulatory issues, which I thought we could really peg quite well, because it was a very, I can't overcome the Pfizers of the world disagreeing with me. You try to do that, but we thought we could make inroads with regulatory changes. And indeed, after many discussions and many conversations, and including the American Society of Transplant Surgery, the Transplant Therapeutic Consortium was finally launched in April 2017. This was done under the auspices of a group called Critical Path. Critical Path was created by the Food and Drug Administration to be an instantaneous private-public partnership with FDA. So we didn't need to sign an MOU with the FDA. Critical Path already has that in place. And it creates an opportunity for societies and experts within the field to also work with industry in an open space, in a pre-competitive space, with FDA, with payers, with regulators, with the goal of developing, through collaboration, new therapeutics. And the focus, and shown here is just on the website, some of the different critical path consortia. Some of them are really novel. They include muscular dystrophy. They're a very successful Alzheimer's disease group, and the polycystic kidney disease. And I think knowing that they had had renal disease allowed us some of the expertise. But again, the notion here is that they work with these groups, look at the standards of care, look at the outcome measures that are necessary, and assist through work in, again, the pre-competitive space, where nobody's losing here, no company is going to lose here. We can actually identify ways of working together. And so they have many resources there. They have regulatory experts that they house. It's a not-for-profit. They have individuals that, and they have biostatisticians, they have analytical mathematicians that work together, and they work directly to create regulatory endorsement of either novel methodologies or novel drugs. And I think it's been a terrific fit for us. They also have opportunity to work with EMA, the European agency, and also the PMDA as well. So it's not Roz Mannon running out and screaming and saying, please, let's do this together. This is now an elaborate group of people that are very, very strongly focused on getting new therapies approved for our patients. So this is the consortium model. There's a coordinating committee. I think I'm on that. There's an executive committee, which I'm not on, and then individuals from the FDA that directly interact with us. And we came up with 2 work groups. It took us like 6 months to figure out. I mean, the work coming into the consortium kind of identified these 2 work groups. One is focused on endpoints and biomarkers, and the other on drug safety profiling. So we have the hard, concrete things. Those are the strong people, and then the soft people, squishy people like me. I'm in this group because I'm squishy. But the idea here was to coordinate, and then this is all enhanced by having shared data from drug trials, shared data from, not registries like SRTR, but registries that are within your own institutions. So what's the current, state of affairs? Well, for me, most of my career, well, up until 10 years ago, most of my career, the standard of care when you did a randomized control trial for drug registration was mycophenolate, steroids, and cyclosporin. And I have to say that our center and my other center were on Prograf or tacrolimus, 10 years earlier. And so there wasn't, so it took the FDA a lot of work and a lot of convincing to say that the new comparator is what 85% of us in this room use. Similar issues in terms of getting rabbit ATG approved for de novo use. That drug up until, 2 years ago was only labeled for rejection. And how many centers do you know use rabbit ATG in kidney? Like a ton. So that was one issue that's been sort of fixed, and so they don't allow single-arm studies necessarily, so that's another story. But again, having an appropriate comparator arm, but the current endpoints for any new drug, rejection and graft survival in 1 year. And we have graft survivals now of, thank goodness, 99 or 98, 97%. And biopsy-proven rejection rates are the lowest they are. So when you're designing a trial, it's really hard to get a new therapy. You're struggling with a non-inferiority concept. You're struggling with massive patient populations, and also you can't look at there's a dissociation, I think, between early rejection and late graft survival. I know the 1990 paper that we quote from the New England Journal from Harry Herron, but that's not true anymore. There's a dissociation, and I think that dissociation has been shown by others, including Bruce Kaplan, Ulfmeyer Kriech, most recently about 5 years ago. So new branded therapies, when they currently on the state of affairs is that they have to be non-inferior for efficacy or safety compared to a generic. And that just makes it very difficult for companies to want to move forward. So Work Group 1 was really entrusted to define a drug development tool, a specific tool, and you can think of tool as any number of things. I'll show you one example of a potential tool, as a reasonably likely surrogate endpoint to support the approval of new immunosuppressive therapy. So this group is real, and it should apply to the vast majority of patients with de novo transplant, and it needed to predict the response of a therapeutic intervention in terms of what was coming out of outcome, and that it should be agnostic to the intervention. So, and in a line, why do we talk about surrogate endpoints? Well, there's this thing called Subpart H, which all the oncology manufacturers figured out well in advance of us, and this is the notion, this is a way of approving drugs in the FDA. And this became much more popular because of an act called the 21st Century Cures Act that was passed in July of 2015, which mandates that the Food and Drug Administration focus on this and utilize this as a potential way of approving drugs. And before that, there was no impetus by the FDA. But this Cures Act also includes some specific carve-outs in the law, specifically towards NIH and developing new therapies, and also for patient improvement of drugs. And so the guidance here that you could have a surrogate endpoint to predict a drug effect that's not that does not directly represent an improvement in how a patient feels, functions, but is reasonably likely to predict clinical benefit. And that's in quotations because there's often arguments about it, but this has been used in lots of other fields and really never used in transplantation. And so part of the TTC is to utilize this. Do we have biomarkers? You've talked about some of them. Some of us in the room remember the failed Silex immunoassay. Donor-specific antibody, gene expression profiles, which are rampant both in whole blood, PBMCs and biopsy, urine chemokines, pre-transplant ELISpot, cell-free DNA, donor-derived cell-free DNA, and I think, is it a lack of interest? No, I think we're all very interested, but getting complete validation on each of these and lack of consensus. There isn't a consensus because we had a big FDA meeting last year, and this paper has been submitted and is under review right now, is sort of how do you personalize medicine and what are these biomarkers, what's the evidence for them. And so if and when the paper is revised appropriately to the happiness of the reviewers, hopefully it'll outline, I was a co-author, it'll outline many of the biomarkers I touched upon in that slide. So the notion here for a surrogate is what we call a multi-parameter composite endpoint, and some of you may be aware that the Paris Transplant Group, which is a very large clinical group with very strong scientific underpinnings and clinical research, just published a paper like 2 weeks ago using what they call this multi-parameter composite endpoint, aka the iBox. And just the name iBox makes me want to go out and buy one, but you can't buy it, right? It's like, do I really want, my kid sends me an email, I want the CRV, I want the new CRV, you know, I want the hybrid CRV. I said, okay, well, let me get it, let me go and do some other work, I don't know, donate an ovary. Oh no, that's too late. But you know, like, everybody wants an iBox because it sounds like, you know, and maybe one day we will have it on our phone. You can actually sort of use the iBox, but what is the iBox? They gather tons and tons of data. It's probably close to 10,000 subjects. They looked at their own registry information in their own hospital of biopsy, creatinine, proteinuria, and donor-specific antibody at the time of biopsy. And the biopsy, by the way, was in the first year. Some are protocol surveillance, some are not. They're for cause. And then they did a validation with 4 other centers in Europe and 2 centers in the US. And that is the content of that paper. And the factors that are part of the iBox are basically histology markers of inflammation, I plus T-score and BAMF, which you'll hear about in a little bit, microvascular injury, interstitial fibrosis and tubular atrophy, and chronic glomerulopathy. So for the non-renal people, you don't want any of that, okay? You want like a 0 on your biopsy. But typically you can get those, and some of the baddies are really this transplant glomerulopathy. The presence of donor HLA, anti-donor HLA DSA, the presence of proteinuria, and poor graft function in the top of our heads, we already sort of know. But the notion is that you would do this online, that a patient would come to you, get this information, and you could give them an assessment of their risk of graft failure, and you would rank the risk of graft loss. And the notion by this group is not only to provide patients real-time prognostic information, but they could accurately use this for therapeutic interventions. And they shown data, it's not in this paper, maybe in the supplement, I didn't see it, but they show it at meetings where they treat patients and the iBox score post-biopsy changes, and they use it as a predictive tool to say there's therapeutic improvement. And so there was a lot of focus by the Transplant Consortium to use this specific tool. However, this is now becoming a company. There's some interaction with a non-federal entity. This was, you know, French data and some private groups in the U.S. But it's a great opportunity, and I know that they're moving forward with this, you know, matching the iBox with other tools that you'll hear about here in terms of biomarkers. So how would this consortium get there? Well, you have to gather the data, and this thing looks like a vacuum cleaner, but that's kind of the way it is. I'll show you in a minute the data sets, and the notion is that they would use data standards. This is a third party, right? This is not Roz saying, oh, I want to include proteinuria mg per deciliter. We independently, I worked with Rita on developing these data standards, and Dan Brennan is content experts, and then clean up this massive data set and have a massive integrated database. And this is somewhat funded by ourselves, AST, ASTS, TTS, and some other agencies in pharma, but the experts at CPATH actually receive funding from the FDA, so they competitively got several $1 million to do this. So there are people that recognize the relevance of the work we do, and though right now it's focused on kidney, that the dream is to do this for other organs. Kidney is the test case because we have so many subjects, but there are, so the idea is to develop this, what they call it a quantitative drug development platform, so that sponsors could use it. And again, they take this database, they have analytical databases, they use their computer, and they can kind of tell you. And there'll be a workshop about this, so if you're around in DC and you have nothing to do, come on down and watch everybody fight. It's kind of fun to watch professional people, old people fight and go, well, I don't know about that. But again, I'm kind of excited about it because you heard Alex talk about these drug studies. Many of these drug studies are going to be in this database. But again, the idea, I call it big data, big math. The guy was so boring, but very nice. And he's explaining how to do this integration. And he goes, am I boring everybody? And everybody was like too polite to say anything. And he said, yeah, I am. it's hard to understand it, but the idea is whether, this tool, the simulation would be whether you have de novo immunosuppression or you're treating a specific drug or you're looking at a high-risk patient population. And so that's right now the most urgent goal within the Transplant Consortium. These are the data sets. A lot of them are from old drug trials. I think we've been very excited to sort of integrate data from a lot of the Novartis studies have been, helpful because there's comparators in there. Not everybody is on the experimental therapy. There's the so-called standard of care, and they have a number of patients that are on standard triple therapy. And other kudos go to places like the Mayo Clinic and Mark Stiegel and Osama Gaber at Houston Methodist that provided their data, and their data is in the process of being transferred and cleaned and integrated in this database. So eventually, probably within about, 7 months, a year for some of these people in red, give up on them. But the green people, they're doing their jobs, and so we will have an integrated database of some sort within about 6 months, because these data guys, they love it. They eat it up with a spoon. I'm like, oh my God. So this is the timeline, and you can see it's a very tight timeline, and I'm involved in this in some unfortunate fashion where I'm not involved with the paper, but we're going to have a letter of intent to be submitted to the FDA. So the FDA is going to provide an initial recommendation that we're moving forward, that we're going to develop this drug development tool, and the capacity will include histology, HLA, DSA, proteinuria, and GFR, and start getting some feedback with the notion that, in another year and a half, we'll be able to actually submit the data and have the data qualification. So for the letter of intent, we don't need all that information cleaned up yet. We do have to have arguments to show the many things you've learned here today about the importance of those bad prognostic features associated with transplant. The patient-reported drug development tool has never really been utilized in transplantation. The notions of how patients feel, the fatigue, the diarrhea, the nausea. This has been used predominantly in oncology labeling, and so the whole separate work group too is focusing on, how do patients feel with certain therapies? Could we get some therapies relabeled because they could be substituted so they don't feel as bad? And so there was a work group 2 report on the importance of drug safety and tolerability in the developing of new therapy, kind of a position paper that we co-authored. And the editorial, I think, was finally put in press by the Food and Drug Administration, a commentary to sort of say, hey, this has value in the transplant field, because if anybody has issues with adherence, it's our group. So in summary, and I'm actually ending almost on time, transplant is a critical juncture in the development of new therapies. I think we finally are considering alternative pathways for drug approval and encouraging industry to do so. And this is a tripartite thing. It's the societies and the community coming together. It's the regulatory agency, now almost mandated, but they actually went along quite willingly, and Renate Albrecht, though she just retired, suddenly had sort of a change of face and a confidence she could do this. And so, and industry in particular, there's a company making this Intel IL-6 trial for chronic ABMR. They went to the agency and have a novel study design with an intermediate endpoint to look at, and then they can continue randomization. And will this go ahead with other organs is not clear. Continuing collaboration and consensus. And I think the one thing that's really missing right now is patient group involvement. HIV and oncology advance very quickly because their patients are very loud, and appropriately so. And the Alzheimer's group got quite a bit of traction because they're actually involved. These are my acknowledgments. Everybody, they're great people. Most of them do things on time, a lot don't. But if you have a PhD or an equivalent in pharmacology, biology, or your PharmD, and you've got 7 years of experience, get on their website or reach out to Inisha Doherty, who's our executive director of the organization, because they are taking applications. And with that, I'll end. And I don't know if there's time for questions. It has 3 minutes, so. Any questions?
There's nothing on the iPad.
Nothing?
Nothing.
Stunning.
Nothing on the iPad.
You don't want to know any personal details?
Except for a tacro diarrhea question.
Do you
but
guys have anything? Questions you have?
I don't have
Nope.
one
All right.
off the top of my head.
Yield to the next slide.
All right, I have the pleasure of introducing our next speaker, Jay Fishman. He will be talking about infection and transplantation and some clinical pearls.
So I'm here because you've gotten this mistaken notion that the immune system was created to reject grafts. And it probably was created when you got bit by a dinosaur and to protect you from having some part of your body fall off. So what I'm going to do is talk a little bit about why transplant has become so successful in the past 20 or so years. And it ain't all the drugs. So we have some conflicts here, none of which are related to this talk. And I'm going to have some questions here, but they're not going to be for you to answer because they are basically things that you know, but you need to incorporate into your thinking. For example, most of our patients are fairly complex. So you say, which of these patients are immunocompromised? The patient with ESRD, the organ transplant recipient, the insulin requiring diabetic, et cetera. And the obvious answer is all of these people are immunocompromised, and therefore, I think we're losing control here over the, okay. Immunocompromised patients with infection generally don't have fevers. Well, sometimes they do, sometimes they don't. But one of the nice things is you get to be a clinician again. You get to stand at the foot of the bed and, particularly if you're an infectious disease clinician, figure out what is troubling your patient, or in Roz's case, why her patient doesn't feel so well. Infections due to cytomegalovirus can be prevented. Sure, if you pay attention and you monitor or you give them the right drugs and you deal with the side effects. You've heard a lot about various immunosuppressive regimens, so you would assume that we have decent assays to measure immune competence or immune suppression, and the answer is we don't. We have terrible assays other than those directed at specific pathogens, so that we have no idea what we're doing, but we keep giving them different drug combinations, and then different people publish papers. So you will then go back to relying on your infectious disease colleagues. You should avoid immunosuppression if possible, and I'm not going to deal with this in detail now, but if you under-immunosuppress up front, or you use some of the drugs that Alex told you about recently, then you're going to have graft rejection, and then you're going to over-immunosuppress, and then you can call me. So I'll give you my phone number, because what's going to happen is you're going to have all the side effects of immunosuppression, which is basically infection. So it is this balance, and obviously I'm being glib, but the reality is you have to take this on seriously because you need the right amount of immunosuppression to prevent graft rejection. And if you give the right prophylaxis, or you can give less immunosuppression, then you have this balance mastered so that you don't have the toxicity of my drugs and you don't have the toxicity of the immunosuppressive drugs that we've given. So I'm going to try to give you, my job was supposed to give you some clinical pearls. I don't know that I have any to give, but I will give you a few ideas, which is basically we are much better, as you've heard, at doing immunosuppression. We see more atypical presentations as a result of our focus on cellular immune function. And so you've heard a little bit about some of the strategies to prevent humoral graft rejection. We have a persistence of chronic allograft dysfunction, which is a nice term for the we don't know why grafts fail long term. We call it rejection. We think it's a lot of other things. And we have a lot of interesting new therapies, including antiviral therapies, CAR T cells and the like, which are just coming to market now, which are very exciting in the field of both solid organ transplantation, stem cell transplantation, and infectious disease. Infections are common, but the presentations are often atypical. Or somebody presents with a little bit of a headache and doesn't want to come back to the hospital, reasonably so, they've spent too much time in the hospital. But infection exceeds rejection as a cause of hospitalization. Prophylaxis works, but only for a period of time, so that it moves the curve to the right a little bit, but resistance emerges, and I'm sure you've all dealt with bacteria that are resistant to various antimicrobial therapies, viruses that are resistant to antiviral therapies. So these therapies don't work forever. And so now we have become reliant on microbiologic assays, particularly molecular assays, to guide us. And just to show you the complexity, 63-year-old man with his second renal allograft for diabetes had suffered early humoral rejection. His creatinine is about 2.2. He's on rapamycin and mycophenolate mofetil and has this non-healing skin ulcer growing Staph aureus. You see his wrist there. He's had poor response to multiple courses of antibiotics provided by his local physician. and I'm just noting that his dialysis AV graft is in the same wrist as that. So the question is, what does he have? He has an ischemic stele from his AV graft. He has resistant Staph aureus infection. Turns out he doesn't. It's fusarium with something unusual. No, it's nocardia. And it turns out, yes, this is nocardia, but only found on biopsy. So if you learn nothing else from me this morning, is biopsy early and often. We need tissue. We need a specific diagnosis every time you see these patients. Do they have rapamycin, sirolimus-induced poor wound healing? Very likely. So it's a combination of things, and when we tied off his AV graft, switched him off rapamycin, and treated his nocardia, eureka, life got better. The same week we saw a similar presentation with somebody with a chronic skin lesion, and this turned out to be fungal infection. So you don't know by examining these patients exactly what is going on. So I put on this slide everything you need to know about transplant infectious disease. And this will be on the exam at the end. But it's actually fairly simple. Multiple simultaneous processes, so broad differential is essential. We often see infection and graft versus host disease in the BMT population. Well, it's infection and graft rejection in the solid organ population. And we really need to know something about the immune status of the host, but as I've already said, we don't have good assays for it. But immune reconstitution can look like rejection, can look like infection or the like. So when you reduce immunosuppression, there is a risk downstream. I've mentioned prophylaxis works, but only for a limited period of time. Drugs, you need to know the toxicities of the drugs, particularly the calcineurin inhibitors, and particularly the fact that they are, despite the fact that this place is loaded with nephrologists, they are pre-renal vasoconstrictors, so they cause the toxicity of every other drug that we give to these individuals. So as a result, the synergistic toxicity, you can shut down a transplanted kidney with single doses of amphotericin aminoglycoside and other drugs. I wouldn't overemphasize it, and to save a life, yes, you would sacrifice a kidney, but the reality is we generally don't need to do that, so that you need to know that the toxicity is there. Urgency for specific diagnosis, I've mentioned already. You need to review their prior microbiology. So if they are colonized with methicillin-resistant staph or vancomycin-resistant enterococcus, it doesn't disappear automatically. So when they come in, giving them ampicillin probably is not going to work. So reasonable review of prior records. Always consider CMV status. There's one lurking diagnosis in the background of a large number of our patients, whether we're treating them for rejection, whether we're treating them for leukopenia, whether we're treating them for something else. CMV, and I'm going to talk about this more in a couple of minutes. I've mentioned graft function, and then there are some specific diagnoses that you need to think of in your area or when you're dealing with other transplanted patients, such as BK and kidney, et cetera, and the list you can read as well as I can. But things that you always include in your differential, either because they might be causing what's going on with your patient or because you really want to look good on rounds. Okay, so in terms of general concepts, diminished signs of inflammation for sure, multiple simultaneous processes is common. Infection is advanced or disseminated at the time of presentation. That means if they show up with nocardia or mucor or something like that, you need to look at their central nervous system. You need to think that it may have spread somewhere. Antimicrobial resistance is not only common but increasing. All of our drugs have toxic side effects. All of our patients have anatomic and surgical alterations, and that's because they're transplant patients, but it also means something interesting, which is that our transplanted organs have no lymphatic supply. They don't sense pain because the nerves have been cut. So pyelonephritis in a transplanted kidney isn't sensed until it goes through the transplanted organ's wall and causes peritonitis. So that you can't expect the same kind of symptoms as you see in your general population, and immune deficits are cumulative, so that as we add drugs or sequentially use drugs, and I'm thinking particularly, for example, T-cell depletion and then give standard dual or triple therapy, these immune deficits are cumulative over time. And so we rely very strongly, because of the altered host response, on demonstration of anatomy, CT scans, MRIs, bone scans, and the like. Tissue histology, I've mentioned that before. Biopsy everything when you get a chance. Learn your nucleic acid testing and protein tests. Serologic tests are not useful in this population. They don't seroconvert in a timely fashion in general. So if they're positive, great, you should get them. But if they're not, they shouldn't necessarily be taken as the absence of disease. We need to work closely with our surgical colleagues. We meet with them in our center. We round with them every day. But we meet with them early and often to coordinate plans for dealing with infection, because otherwise our patients don't do well. Okay, fever as a sign of infection. Sure, if you've got fever, it is a good sign of infection, but about 5 to 10% will be due to graft rejection, and another few percent will be due to other things. The anti-metabolites and steroids prevent the release of tumor necrosis factor, so you don't see fever. And patients with significant infection, and we've seen multiple patients with wide open bowel perforations who have absolutely benign abdomens, even on exam carefully at the bedside. So you need to not expect fever, but follow it when you see it. One of my teachers had this semi-quantitative relationship, Bob Rubin, between epidemiologic exposures, what you see, including latent infections in donor and in the recipient, and this concept called the net state of immune suppression as a predictor of the risk of infection in these individuals. Epidemiologic exposures can be put into two buckets. The distant ones are the ones we often forget about. Tuberculosis, exposures to geographic and endemic fungi, molds in unusual areas, Southeast Asia, for example, Latin American parasitic infections and the like, all can come back to haunt you 30 years or more after the initial exposure. In addition, there are the more recent exposures, the nosocomial exposures, those that come with the donor organ and the like, which you need to think of in the early differential diagnosis. So the distant exposures we deal with largely by prophylaxis or by monitoring. The acute ones we may have to deal with in the early phase as early opportunistic infection. The net state of immune suppression is this conceptual framework we use to think about how much at risk an individual is for infection. And the driver for this is largely the immunosuppressive drugs that we use, including the sequence, as I've mentioned, and the total amount and duration of immunosuppression. In that setting, less is better. However, we do all kinds of things to these patients, and then we tend to ignore them. We leave catheters in too long. We ignore their incisions breaking down. We ignore the fact they have malnutrition, et cetera, et cetera. And all of these various factors put together are what creates the risk in an individual. And so when you think about your patient, we need to think about them as individuals and categorize all of these particular events. Now, I'm going to summarize all of immunosuppression in one slide. And that's easy to do because Leo Riella has made this really easy. And here it is. This is mostly his picture, except better. Right, Leo? Wait, yeah, okay. So what I've tried to do, and this will be on the exam also, is to give you a sense that you can think about these in terms of exactly what you've just heard in terms of side effects. The depletional antibodies that we use don't just go away. And so the effects of these last 6 months or so, when your T cells start coming back or your B cells start coming back, but they're not fully functional when they come back. So the notion is when somebody says, oh, he's got a normal white count, you need to say, but what therapy did they have? And were they then put on dual or triple therapy, calcineurin inhibitor-based therapy, to drive their immunosuppression? The co-stimulatory blockade molecules, which were touted by this side of the audience, are also not terribly good at stimulating infection. Isn't that great? which also should suggest to you they're not very good at immunosuppression either, but we'll let them come back and talk about that a little bit later. But one of the reasons we don't see as many infections is they are not as globally immunosuppressive as are the calcineurin inhibitors or the other agents you're going to see. So I mentioned that you can talk about immune modulation versus depletion, and you will be pretty easily able to understand a lot of infectious disease. What you do need to know is that when you deplete T cells, you are setting up the patient for viral infections, particularly the herpes viral infections, but in addition, many of the other viral infections, BK and the like, that we see routinely. The more immunosuppressive the depletion is, alemtuzumab, for example, the more different categories of cells you deplete, and you heard about the innate immune system from Leo earlier, the more likely you are to have a persistent immune deficit. So that if you use alemtuzumab and you deplete NK cells as well as lymphocytes, you are in fact going to pay a price in terms of risk infection. We've seen very few side effects of co-stimulatory blockade, but belatacept, we've seen interesting presentations of CNS lymphoma, for example. We've seen unusual presentations of CMV infection, which are difficult to treat, and so that we are just beginning to get a handle on the mechanisms of these related to infectious disease, and this is an important area for study going forward. I should mention that if you achieve tolerance induction, which we have both in patients and in animal models, we don't see infection. So that we only see what you see in the community amongst normal individuals. So tolerance induction still remains the holy grail of transplantation. I point out a couple of things about the calcineurin inhibitors, things that you tend to ignore. You all know that they promote hyperglycemia and diabetes. Oral disease, gingival hyperplasia, and the like are important in many of our patients because they have bad teeth. Hemolytic uremic syndrome, neurotoxicity, neoplasia, you know all of those. If you try to link immune suppression to prophylaxis, which you need to do, we should know that anybody on corticosteroids for a prolonged time is at risk for pneumocystis infection. Trimethoprim sulfa is far and away better than any other form of prophylaxis. The cell cycle inhibitors tend to give you neutropenia, so that in combination, for example, with valganciclovir or other drugs, you may have to modulate these to be able to tolerate some of your other prophylactic strategies. I've mentioned the calcineurin inhibitors. The problem with the mTOR inhibitors, rapamycin, sirolimus, poor wound healing is a significant issue. This interesting syndrome of pneumonitis that you see often follows community-acquired respiratory virus, pneumocystis, or other infections. So it is not necessarily a spontaneous event on its own. What does it look like? It looks like influenza. It looks like pneumocystis, interstitial, rapidly progressive pneumonitis that doesn't get better until you stop the mTOR inhibitors. Why does it occur? I have no idea. But you need to be aware of it, because if you don't stop the drug, your patient won't get off the ventilator. I stole another illustration. This is from Alex's, one of Alex's papers, and again, I've improved it to make it readable. But basically to remind me to mention that in terms of B cells do a lot of things other than produce antibodies, including antigen presentation and regulation of T cell responses. So when we deplete B cells, we're not just getting rid of the antibodies that are directed against the graft. We're doing a lot of things to the immune system overall. All of these have effects. Most of them are preventable with trimethoprim sulfa prophylaxis. But you do need to know that if you use eculizumab, for example, you need to give meningococcal vaccine A and B. If you don't, you will see some really unusual infections in your patients rather quickly. But the biggest problem with this group of drugs, including bortezomib and proteasome inhibitors, is the issue of encapsulated bacteria, the ones that don't normally cause problems, but our patients don't respond well to vaccination. So pneumococcus, H-flu, meningococcus, all easily preventable, vaccine-preventable diseases, but you will see them in this patient population in the ones undergoing plasmapheresis, in the ones undergoing anti-B cell therapies, and they're worth thinking about. If you put all these things together, we've created a timeline, which you can find in any of the papers now, of which infections you get when. And these timelines serve a number of functions. It tells you what you should think about when somebody comes into your office, if they're not on prophylaxis, for example, against specific infections. It also says to you that if you see infections at the wrong time, that you may have an epidemiologic problem, which means that either your patient has just gone out and done so well that he or she just started gardening or just started raising pigeons. It's one of those things in Boston. Or spelunking in caves. If any of your patients go spelunking in caves, leave them there. You know, so those kinds of things. What's the risk? And this is how you find aspergillus in your ORs, for example, or legionellosis in your air conditioning system. So it's worth thinking about. And I'm going to talk a little bit about that, just in brief, which is the first month following transplantation. The one thing we forget most often are not the infections that were already present necessarily in your recipient, but donor-derived infections. And you need to think about those infections because they tend to occur early after transplantation, in addition to the usual postoperative complications. And we have to give kudos to our surgeons. This is not only technically difficult surgery, but then what we do is we give them a variety of drugs, like sirolimus or steroids or other drugs, that prevent healing. And so if they're not technically good, you're going to get leaks. And it doesn't matter what kind of surgery you do, in addition to the fact that we've denervated these organs and taken out the lymphatics. So again, this coordination of care between specialties is absolutely critical. If you move to the period after that immediate postoperative period, we have the period of greatest risk for what we call opportunistic infections. And this is the period of time when you've accumulated enough immunosuppression to start seeing the pneumocystis, the toxoplasma, the listeria, the herpes viral infections. And it is indeed during this period of time that the reactivation of viruses drive most of what you see, even if you don't recognize it. And the reason is outlined here, which is that these viruses have pleiotropic effects, which were, again, by my preceptor, talked about direct and indirect effects. We all know about the direct effects. Influenza causes pneumonia, okay? BK virus causes nephritis, etc. Each of these viruses has a clinical syndrome. They also are all immunomodulatory. And we were always taught that, for example, the herpes virus is seen here can cause both immunosuppression, so they predispose to fungal infections and other viral infections, and graft rejection. And that doesn't make any real sense because one's immunosuppressive and one's immunostimulatory. Just before I get to some basic science, because Anita Chong accused us of not including any ID basic science in our lectures, it's worth remembering that the greatest risk factor, of course, is from the individual who's immunologically naive, who gets a seropositive organ, or who has a variety of genetic mutations, or in addition, that predispose to viral infections. So I mention that because these are important areas of research. Now, we have been studying in our group, and Preetha Sen has done beautiful work, on the pathways by RNA-seq that are altered by CMV in monocytes, both from clinical samples and in human cells infected with clinical strains of virus in vitro. And to take this rather complicated diagram down to its basics, what we actually see is a few things. At the same time, we are creating a pro-inflammatory state by infecting innate immune cells with CMV, pro-cytokines, cytokine release stimulating graft rejection. We are seeing downregulation of the receptors responsible for phagocytosis of fungal elements. So what you are seeing is an explanation of why you see these indirect effects, which include graft rejection, at the same time as you see a predisposition that is largely driven towards fungal infections being pneumocystis, and aspergillus, and the like. And in clinical trials, we've seen that over and over again. So now we're starting to unravel the basic mechanisms underlying CMV infection, and certainly we need to do that for other infections as well. And I point this out because this is an important interface between basic biology and infectious disease. If we go back to that timeline, sort of more than 6 or 12 months after transplantation, the majority of our patients are doing pretty well. In fact, the ones we see in the hospital are the exception by and large. And it's hard to remember that because we see these sick people over and over and over again. We see community-acquired infections, the community-acquired respiratory viral infections, in part because we have really no useful drugs for many of those infections. We see zoster and herpes simplex. So in patients that get those, we may extend prophylaxis in those individuals. We also have a group of patients we call the chronic ne'er-do-well. And this gentleman, I should preface this by saying, is still alive. He's had central nervous system aspergillosis. He had CMV twice. He had a Staph aureus empyema followed by a VRE empyema. He ruptured his appendix, but now he's fine. He's had a kidney transplant, and he's on his way in Boston. He's going up to Maine for a vacation, and he comes in with this, I assume there's no dermatologist in the audience, a ditzel on his arm. And to make a long story short, this is his cerebrospinal fluid, and this is nocardia asteroides. He's fine. He's really annoyed that we're going to interrupt his vacation to take care of his meningitis. So I point out that there are some people who don't seem to respond right, and he's on minimal immunosuppression, but don't seem to respond right to a variety of pathogens. And so this is an important area, the genetic defects in innate and adaptive immune systems that predispose to opportunistic infection. Just to give you another dermatologic manifestation, this is the first manifestation in this individual of Cryptococcus. I would call these zits, but again, I told you I'm not a dermatologist, so I'm not exactly sure what the right term is. Excrescences, I assume. So, why don't we just reduce immunosuppression in every patient we see who comes in with an infectious syndrome? Well, first of all, we use a lot more immunosuppression than they do in Europe. In Europe, if you said this, they'd laugh at you because they basically don't use as much immunosuppression, don't really have the room. But we get graft rejection. We get a variety of immune reconstitution syndromes and the like, so that we need to be very cautious. And as I've mentioned, we don't have assays, which is another important area for investigation, to tell us where we stand relative to risk of infection versus risk of graft rejection. So I would implore you that specific diagnosis remains the key when you see somebody with an infectious syndrome. Be aggressive. This is a patient, fever and cough, 2 years after cardiac transplant. He was seen by one of our eminent radiologists who said, pulmonary nodule with a halo, this is definitely aspergillus. We agreed. We started treating with antifungal infections. He went on to cavitate 5 days later. Well, the cavitation is probably okay because that's the natural history of nodular lesions, except in this particular case, he had nocardia, and we were treating him with the wrong drugs. So we need specific diagnosis, and it often means that we are more aggressive in terms of biopsies than we would like, and I think that would be the prime mechanism. We are investigating newer diagnostic tools. I mentioned high-throughput sequencing as one of them, which there are a lot of companies starting to do now and may be very interesting in the years to come. The summary is that infection in our patients is advanced at the time of diagnosis. Drug toxicity is common. We need to address that. The intensity of immune suppression is very important, but we don't have the right assays yet to measure it. And infection is linked to patient and graft survival. And I've mentioned the example of CMV promoting graft rejection, and prevention of infection is the key to excellent outcomes in whatever you go into. So let me stop there. And I am all that stands between you and lunch. And thank you very much.
Thanks, Dr. Fishman. I think we have time for one question. You get one. Can you comment on the role of the CMV cell-mediated assay? And then is there any investigation with other viruses such as EBV?
Yeah, so there are a variety, I mentioned, of pathogen-specific assays that have been developed to tell you how immune you are. The TB assay, of course, is one that we use for screening. The CMV assay is also very useful because you want to know whether somebody has pre-existing immunity to CMV, and therefore, in most settings now, can be used to stop prophylaxis. If, however, somebody has immunity and they are on 16 different immunosuppressive drugs, it actually doesn't matter whether they have pre-existing immunity. So we're assuming they're on some modest level of immunosuppression, and then there are good data to suggest that you may safely, with monitoring often, reduce immunosuppression. However, it doesn't apply to people who've actually had active CMV disease already, because many of those people will have recurrent disease for reasons we don't understand very well. So we don't understand the full nature of CMV immunity, but they are a useful guide to prophylaxis.
Fantastic, thank you. So with that, I'd like to thank all our speakers this morning. It is now time for lunch at the usual spot. Additionally, we had several requests for Kristen to finish her last case. If you are interested, please come to our breakout session later this afternoon. She will add it on.
everyone. Well, we're going to get started, so please get your seats. And just want to make sure we stay on time. Otherwise, I'm going to get fired. Actually, I was fired. Fantastic. So welcome again. I hope you guys have enjoyed the morning. This is one of the immunology boot camps. We have two. And what we decided to do in the immunology boot camp is to dive into some important concepts that unfortunately when we talk superficially about rejection, we are unable to touch. And we got excellent speakers to go over some of the content, including basics of T cells, basics of B cells, and then going through some of the current and investigational immunological assays in transplantation. We flipped the first talk with the second one just because Annette has to kind of run to another session after that. So we're going to start with basics of B cells, how they develop, where they go, and how they differentiate to become antibody-producing cells. And I'll invite Annette Jackson to take the stage. And then you're going to have, with the B cell maturation, some post-germinal center plasma cells are going to be generated. They're going to be protecting the patient against future infections. So they're going to have that baseline, antibody production in the serum, which, you can see with vaccines and so forth. And then you also have the capability of some of these memory B cells, which are those intermediate in the maturation process, that just, are there in case we have a recall, re-exposure with the antigen. controls in immune response. They can be important in the antigen presentation. They can be important in cytokine secretion. And not only they are important in triggering or potentiating the immune response, they can also be players in the regulatory phenomenon. But here I have a work that was published about last year, which was an excellent of hearts, in which they characterized the B cells that were infiltrating the heart in patients that have chronic rejection. And the big thing about those infiltrating hearts is that there was a hypothesis that a lot of these B cells infiltrating the heart, they were producing donor-specific antibodies, and they were contributing to some of that chronic injury. And what was found when they screened those antibodies that were invading the graft that was under rejection was that a lot of these B cells were actually not producing donor-specific antibodies, but were producing what we call polyreactive antibodies, which are almost like innate type antibodies that are produced just in general in the setting of inflammation. So they could be reactive to a number of different things, including reactivity here to self-antigens as well as apoptotic cells. So there's a lot of epiphenomenon of ongoing when we talk about the graft itself, and not necessarily the B cells that are infiltrating that are producing those antibodies, but they could also be contributing to that inflammatory milieu and causing persistent rejection. And then for sure, you have antibodies that produce donor-specific antibodies and B cells that produce polyreactive antibodies that increase inflammation. And then you have also what we call regulatory B cells. Regulatory B cells, what is really hard about it is that we don't have a perfect marker to identify regulatory B cell. For the T cell, there's one subset of the T cell that has a marker called FOXP3. So this has allowed a lot of research to go into this. But what we know about some of these regulatory cells is that a lot of them produce IL-10, which is an immune suppressive cytokine, and therefore they can play a role in stimulating FOXP3 cells, inhibiting Th1 and Th17 cells, inhibiting the maturation of dendritic cells, and so influencing from innate as well as the adaptive components of the immune system. And as we think about therapies to target B cells, we have to be cautious that, in theory, we don't want to be affecting some of these B regulatory cells because of its potential beneficial effect. And if you look at across most papers that have tried to characterize B cells, the kind of common while, I told you that the adaptive immune side of the immune system is antigen specific, and they require that antigen specific signal either through a T cell receptor or a B cell receptor. When they get to the stage of plasma cells, which are kind of the end stage of B cell development, they lose that antigen specificity. So a lot of it, it's almost independent of that. And that's why it becomes so hard to break those neutralizing plasma cells once you have an immune response. And it correlates to what Annette was showing in terms of like early antibody-mediated reduction and late. That if you get someone that's been non-compliant for like 10 to 12 months and they have a really strong antibody response, it gets to a point to, depending on what you use with the current medication that we have, it's really hard to break that niche of And finally, when we talk about antigen pathogenicity and what we're currently doing in the clinic, we're mainly measuring, if they have a specificity against a certain age allele, and we are measuring the titers. Some centers are also doing the complement activation that seems to correlate more with the level of the antibody rather than its capacity to activate complement. But there are other factors in the antibody itself, as well as in the target antigen that may affect its pathogenicity. So that goes from the affinity of the antibody, which is something we don't assess when we're kind of measuring these antibodies. It has to do with the epitope expression. So how much of this antigen is actually expressed? And we'll have another session of the immunology boot camp 2 where we go over, okay, how DR versus DP has a different expression in the endothelium, and how a same level of antibody from those two specific HLA antigens may trigger different types of responses in the tissue. So that expression is important because if you have antibodies but you don't have a lot of expression on the surface, you don't have a lot of antibodies. The second part is that some of these antibodies have post-translational changes. There's glycosylation, there's some sugar coating that happens on the antibody, and that can actually change the property of the antibody. It can become suddenly, instead of pathogenic, they can actually become more inhibitory, which is something interesting, and not much is known inside of transplantation. There is the Fc subtypes, as you've seen before, IgG1, 2, 3, and 4, and they play a role as well in combination with the other factors. And all these are things that, traditionally we're not measuring or we're not considering when we are discussing antibodies, but I think it's something that in the future we'll be, putting together as well as with the titers and the antigen specificity. So the main conclusions of this part is that B cells contribute to rejection primarily by differentiating into antibody-secreting cells, though there are also regulatory cells that are responsible for inhibiting the alloimmune response, and some of these B cells that can also potentiate the innate immune cells. Late detection of de novo donor-specific antibody is usually associated with a much stronger germinal center response and resistance to treatment, and we didn't change the epitope mismatch, not the outlet. The epitope mismatch significantly affects donor-specific antibody generation, while the HLA expression, DSA titer, and the Fc portion characteristics may impact its pathogenicity. We'll stop here. Answer any questions? Thank you. And that is an expert in known HLA.
Yes. We're gonna have to put in a talk next year, I think. So the importance, you're asking what is the
introduce our second speaker, Marisa Langry. She's going to talk about the basics of T cells. So she's a basic immunologist with lots of experience in transplant, really active lab, and hopefully you guys will be able to try first.
Thanks, Leo. So this is going to be quite basic, like the time process, since I've been able to mostly for the clinicians and for basic research and regarding other molecules that help retain them into the tissues. And people have looked at whether retinal memory cells can recirculate or not. And they use this trick where they induce paragliosis in mice. You can sew the skin of two mice. Their vasculature becomes very light, and so cells that can circulate from one mouse to the other. You can have T cells of different colors, usually one mouse red than the other. You can see the green cells are darker in the mouse, the red cells in the mouse. And so through these types of experiments, it's clear that tissue-resident memory cells do not recirculate and stay in the tissue. And this is kind of the distribution. If you look at lymph nodes, you only find the central memory cells. The spleen has central memory and effector memory cells, and the tissues don't have central memory cells. They have this resident tissue-resident memory cells instead of effector memory cells. So in conclusion, naive T cells are activated by cognate antigen with costimulatory signals, with cytokines, and then depending on the cytokine milieu, they're going to undergo different types of differentiation, and then they're going to activate innate cells, and B cells, and CD8 cells to carry out the rest of the effector phase of the immune response. And in memory, you have these different types of memory that can develop with particular markers that you can look for to see if cells are present or not. So that's what I have for just basics of T cells.
Our resident memory cell rejection
Yeah, either in the rejection process or in protection against rejection, right? One way to look at them is that they could kill recipient T cells that would go into the organ and then protect the organ against acute rejection. And I guess we didn't do the journal club paper that we were going to do yesterday for the basic science, but Donna Farber was analyzing exactly that, right? And how donor T cells after lung transplantation persist in the lung, and these are associated, their persistence is associated with a better outcome for mice when they feel that they can protect the organs. All right, let's move on because we still have one more, and then if you have questions, we can go to the second look at
So we will go to the last talk of our breakout session here at the boot camp. Robert Fairchild will talk about current and investigation of immunological assays, meat transplantation. And Peter will take you on.
So I'll take 20 minutes or so, and I'll go through some assays. These are assays that any of you can grab or whatever. And we have 5 extra minutes if I go fast enough.
preparing to file in, and there's obviously transitions from one place to another. I think we will at least get the momentum started by introducing our next speaker and our next group of topics. These topics are really focused upon career development and how you guys would like to navigate the next few years of your life within your professional life. And we have a number of excellent speakers who have navigated that and can give you some guidance. Our first is Dr. Verna from Columbia. She's our hepatologist, representative and a recent elected board member of the AST. Happy to have her talk about Career Development Award and application process and words of wisdom. Thank you.
Okay, let's see. Okay, so these are my disclosures, but I actually just want to disclose that I'm going to give this talk as somebody who's just coming off a Career Development Award, and so this is sort of my in-the-trenches view of what that process was like and what I think I've learned from it and want to pass on. But I also want to say there's many people here at this conference who have much more grantsmanship experience than I do, and to the extent that you are able to interact with them, this is a really good crowd to ask important questions of if you're thinking about writing grants in the next few years of your career. So I'm going to start by going over what I think are really the three essential elements of any career development award, which is mentorship, what to look for in a mentor, the importance of a good mentor, your actual research question, which I think is very personal, but I'm going to give you, what my advice would be on how to pick a question that might be successful, and then what your training plan is. I'm then going to talk about the types of funding that are available, including federal funding, but also other types of career development awards outside of federal funding, the actual application process itself, and then how to fit all of this into your job negotiation. We had a lot of questions this morning at the breakfast session about job negotiations, and if you know you're going to be on a pathway like this, that discussion is very different than people in different pathways. And then I'm going to end with some pearls from mentors of mine and also other people that have K awards in the transplant community. So what to look for in a mentor? Really the key to success in getting a career development award, in addition to being very persistent and having thick skin, is to identifying a mentor. And it's important because they will guide you through the process. Hopefully they have a track record of guiding other awardees through the process as well. They need to have their own significant federal funding. So even if people in your institution are very successful clinical trialists, nationally recognized, if they don't have their own federally funded grants, it's going to be very hard for them to be the only mentor on your NIHK award. So this is really important. And they also need to have time and energy devoted to you. They need to be available. I think these days it's increasingly important to have co-mentors. So there's one mentor who's going to have their own sort of specific expertise, but this is about you going on to be an independent investigator and learning skills not only from your mentor, but also from people outside that one relationship. And I think more and more we're seeing applications go in that have sort of either formal co-mentoring or very strong collaborators and advisory committee members that are going to teach you the different skills that you don't already have coming through your training. And then it's important to think about the role of your people, the leadership in your department and division, and lean on them in terms of advice about grantsmanship. So this is the 10 commandments for the mentor-mentee relationship. Believe it or not, this was written by one of my mentors, Robert Brown, who's a hepatologist at Columbia and Cornell. Back when he was a fellow in the 90s, he wrote this with his mentor at the time when he was embarking on his first round of grantsmanship. And this was actually published many, many years later when his mentor came across this in his old files, which I think is pretty funny. And so just, this is not something you have to read every word of, but I would really think about this. What are you looking for in a mentor? You want that person to be a role model, to be an advocate, to be enthusiastic, and to be available, but also somebody who's thinking about the long term with you, who wants to show you a path towards independence and is looking at the long view. You also have obligations as the mentee to stay engaged, to take initiative, to choose a role model, to shop around, to seek advice of people. Don't disappear for periods of time and think that people are going to pursue you. So the next essential element is the research question, and this is obviously a very personal decision. There's a huge number of types of research that one can do and apply for grants for, and so without being too specific, these are some, I think, sort of broad thoughts. You really have to have a delicate balance, I think, in many aspects of this, between having something that's very focused, but also something that can be flexible, so that if your initial question doesn't work out, or, my original K award that I wrote was about hepatitis C and transplant after transplantation when they got rapid fibrosis, and in the middle of this award period, we cured hepatitis C. So my reapplication for my K award had to be much more broad. And it was the same topic applied to different patient populations, so you have to be both focused but also flexible. You have to be realistic about what you can actually accomplish in your own institution and in the timeline, but also be somewhat aspirational in the sense that whatever the answer to this question is has to lead to something bigger, has to lead to more funding, possibly multi-center work afterwards. And you have to understand what specific resources are available at your institution, whether it's basic science or clinical partnerships. Do you need to have patients? Do you not need to have patients on site because you're looking at large databases? And you have to think about that when you're interviewing for your first job. And then the final aspect I think that's sort of key is what additional training are you seeking? We all have done a lot of training, years and years and years of training. But I think this is one of the last periods when you can really branch out and do something different. Be trained in a different department or division in your own institution. Be trained sometimes even outside your own institution. So think about what training you already have, whether you've had epi training, we've had a lot of clinical training, basic science training, how to build on that. What additional tools do you need to specifically answer the research question that you have? But then really, what other training would you be passionate about? What other new knowledge set you think would really springboard you into the next level in terms of competition for the next round of grantsmanship? So what about all the different funding sources? And as my father always told me, you can't score if you don't shoot. And I think that this is really true. So start to apply for grants early. The first grant you write, I don't think should be a NIH-K award, right? There's lots of grants between now and the NIH-K award. I mean, maybe some of you can go straight to that, but a lot of us can't. And we're going to talk about federal funding a few slides later, but just remember that there's lots and lots of sources of funding out there. And I think in transplant, it's incredible how many different types of medical foundations and societies actually we touch on. So just as an example, as a hepatologist, I can look not only at the AST and the ASTS in transplant, but the ASLD, which is our liver organization, the AGA, which is our GI society, endoscopy societies like, the ASGE was one of my first grants, believe it or not, and it was about liver transplantation. There's cancer societies. I mean, there's a very, very long list. And so in transplant, you have lots of things that you can look to in order to try to think creatively about funding. And the last thing I want to say there is also think about grants within your own institution. So particularly if your institution has a CTSA, oftentimes there's lots of pilot funding awards and things like that, but even without that, again, one of the first pilot awards I ever got was a little thing that the Department of Surgery decided to do, and it was like $8,000, but it allowed me to run the first set of assays that was the preliminary analysis for my K award. So think about also local things, and your mentors can sort of steer you towards those things as well. So in terms of federal funding, also, of course, we all think about the NIH institutes, but there's actually many other funding agencies that are federally funded that also have career development awards. So not all of these have career development awards, but it's important to know that 18% of the federal funds in 2017 that went for biomedical research were actually not from the standard NIH institutes. So the CDC, AHRQ, they all have career development awards as well. And there's lots of funding outside federal funding sources. So all the sort of small lines at the top may seem small, but when you add this up in terms of the total amount of money that was spent between voluntary health organizations, state and local governments, independent research institutes, foundations and our medical societies, it's actually millions and millions of dollars that is spent on biomedical research a year. And a lot of these smaller foundations actually like to give smaller either pilot or career development awards because they're not going to be able to afford the big R01 type funding. And so this is a really good source of funding for junior investigators as well. So how do you find these things? Speak to your colleagues, speak to your mentors. This is a good place for all of you guys to talk about this and at meetings like this for people that are all interested in applying for these types of grants. Other little tricks are things like look for acknowledgments in publications for people in your field that are doing the type of work that you want to do, also in presentations at national meetings. Think broadly about all of the different types of societies that you might tangentially be related to and inquire about whether your work might be of interest to them. And there's lots of online search engines. So one thing I learned when I was preparing for this talk was that 90% of US foundations don't actually even have a website. And a lot of them fund research. And so there's online search mechanisms I listed two here. I'm sure there's many other ones. Some of them you actually have to have a login that a lot of academic institutions have access to. But it gives you access to some of these funding sources that may not be readily apparent if you were just to Google Career Development Award. Not all of these awards are the same. So you have to understand what the mission of that foundation or that funding source is and what the exact mission of the award is. So oftentimes they have something sort of very specific in mind. It's helpful to look at the previously awarded applications to get a sense of what types of research they're interested in and the scope of that research. And don't be afraid to ask questions, not only of each other and of your mentors, but also of the administrators in the funding source. If you're not sure if you're eligible or if they're interested in your type of work, you can always call, and people are really helpful, I think, when you do that. And then finally, know the particulars. So read all the instructions before you start. Know the deadlines. Confirm that you're eligible. There's lots of different things that make people eligible and not eligible across all these foundation and other awards. Look at the duration of funding. Sometimes it's 1 year, sometimes it's 5 years, sometimes it's renewable, sometimes it's not. Look at the different amounts of money that are available so that what you're proposing seems realistic within the budget. And be knowledgeable that sometimes every year the exact amount of money or the specifications for the award will change, even for our sort of traditional societies like the AST and AASLD. And I'll just make a plug, obviously, for the AST Career Development Awards. So the AST is one of the organizations that sponsors these types of awards, both for fellows and also for early career physicians. The purpose of these grants is to foster the training of young investigators who have the potential to contribute to transplant science and immunology and treatment of transplant recipients. So that's basically everybody in this room. Note that the deadline is in December. So if this is something that you're interested in, I'm sure there's many people here, members of the AST, that could give you some guidance on how best to apply for these awards. So what about the NIH grants? So in general, the training and career development grants within the NIH are in the F, K, and T categories, and then obviously the loan repayment program. So I'm going to focus mostly on the K awards because I think that's sort of the individual career development awards, but just know that there's other fellowship and training awards that are out there that generally are more like awarded to your institution, but that's definitely something you should ask about at your local institution. So the different NIH K awards are in different categories. So the K01 is for basic scientists, usually not clinicians. So for the most part, that's not what we're doing here, but certainly sometimes it is. K08 is for the clinical investigators. So this is mostly bench science, but can be other types of investigation as well. The Physician Scientist Award, the K12, is actually an award that goes to your institution. So this is like a local K award that I think you should inquire at your institution if they have this. This is a nice, sometimes bridge to an external K, an NIH K. I did this in my own career. I got a K-12 in my own institution and then ended up with a K-23 afterwards, so it sort of can extend your period of funding. And then the K-23 is the Mentored Patient-Oriented Research Award. So these K programs are basically the model that the other career development programs are modeled off of. They predominantly provide salary support. There's very little money awarded for actual research costs, right? Like research supplies and coordinator time and things like that. It's sort of assumed that that's going to be mostly absorbed by your mentor, which is why they need to have a good track record of funding as well. There's a minimum requirement of effort that must be towards research when you're on these awards, and it's usually 75%, although some of them I think go as low as 50%. But that's an important thing to know when you're negotiating your job. They go for up to 5 years. They have specific salary levels associated with them in terms of it's 75% of the NIH salary cap, not of the salary of a transplant surgeon probably, so that's another important thing to know. And being a U.S. citizen or a permanent resident is required to be awarded these awards. There's a lot of information on the NIH website in terms of statistics and trends over time that is incredibly useful. And it's relatively transparent if you spend a little time going through all of the different pages. So this is just sort of a trend over time of the number of awards that have been given by year. So this is across all the NIH institutes. About 4,000 career development awards were awarded last year. But the number of awards varies a lot by the institute that you're applying to. So luckily for us, most of the institutes, that liver, kidney, heart, lung applies to do have a lot of K awards, but there are institutes that don't have this program at all. So you have to think about that when you're sort of strategizing about how you're going to apply. This is NIDDK itself, sort of looking at the number of awards over time. So there's more K awards overall than the F or T awards, although probably less money spent on each individual award there. And here's a breakdown of all of the different types of K awards, where you can see that really the K01 is the most in terms of number of awards overall that was funded. Looking a little bit deeper, and this is not for you to read each line, this is a whole spreadsheet that you can just download from the NIH website that shows you by type of K award, by funding institute, year over year. I think it goes back, at least this one did to, I think 2001, where you can actually see the number of K awards that were submitted, the number that were awarded, and the total amount of money that was spent on those awards. So this is just an example from last year for all the different institutes. You can get a sense of some institutes have a lot of awards and others have none. And this is all readily available right on the NIH website. So let's say you actually decide that you're going to apply for an NIH K award. Sort of what is that process like? And I'm not going to go through every detail of this, but I will just tell you it is a very large number of documents that are required. And every time you think you have drafted the last document that's required, a new document pops up on a form that you didn't realize. So this is sort of a broad overview of that, but just know that if you're going to do this, you have to get organized, you have to have a timeline, and you have to plan in advance. So this is sort of like the main front page checklist of all the documents that you would upload to. Each one of these documents has specific instructions associated with it. They all have different page limits, okay? They all have different specific things that are supposed to be stated. There's lots of weird things, like you have to add 2 sections together and make it under the same page limit. This is very confusing. So every time you change one thing and it goes over a page, you have to rejigger everything else you've written. And this is a very important part of the document, obviously, because this is your training plan along with your research plan that has to sort of fit scrunched into this 12-page document. And then there's other pages in this application where there's a bunch of other things that you need to write as well, in terms of project summary and abstract, bibliography gets uploaded separately, facilities and resources, bio sketches for yourself and all of your mentors. And another thing that's very important to remember is that you actually, in addition to your mentor letters, need outside referees. So I'll talk about that in the next couple slides. So how do you go about this? First is read the instructions. It is incredibly dense and frustrating, but there's things that you pick up along the way, and I would read the instructions at the beginning. Otherwise, if you have to go back and change things, you have to change them in documents all across the different documents that are required. All of these documents have to reflect the same plan and vision for you, including all of the mentor letters, all the collaborative letters, every introductory paragraph and every bio sketch. All has to be harmonized, so it looks like all of this was specifically written for your award. And it all has to be well written and proofread and sort of come together in the end. And so every time you change, an aim of your research, you have to go back and change lots of other things too. So just think about that ahead of time in terms of your timeline and prepare for setbacks. Ask awardees outside of your own department about if they'll read the document for you, people that don't sort of think about your science or your clinical interests all day, to make sure that it's readable for people outside your own expertise. Take advantage of your institutional resources. A lot of academic medical centers now have sort of very specific mentoring programs for people that want to go on to apply for Ks or graduate from a K to an R01. And it's important to take advantage of those resources. And think about using figures and tables to your advantage throughout all of these different documents. In addition, you have to be mindful that you have to get a number of things from other people and sort of be respectful of their timeline as well. So the letters that come from the mentors are incredibly important. They have to be really thoughtful and well-developed and make sure it really seems like they know you and that they understand that they're grooming you to be an independent investigator. Same really goes for the key collaborators that go along with that. You also need bio-sketches from all of them that have sort of individualized paragraphs at the beginning that talk about why it's important for them to be involved in the project that you've proposed. And also 3 to 5 additional letters of reference that come from outside the people involved in your research in this application. So it's great if those people can even be outside your institution, people that you might have met at meetings like this, people that know of your work but are not directly involved in it. And you have to ask them not only to write you a letter, but they have to go in and submit it independent of you. So this is not a process that you can be in complete control of, so you have to be patient and give people time to get all those things done, because usually those people are quite busy. So what happens after you submit the award? And again, this is a very complicated process that I'm not going to say I'm an expert on, but I'm going to tell you sort of my view of what happens next, is that the award is received and is reviewed, and each reviewer is tasked at giving specific aspects of the application as well as the overall application a score that is on this scale from 1 to 9, where 1 is the best and 9 is the poorest of all of the applications. And again, right on the NIH website, you can see that there's specific guidance given for the type of award that you have. So what does it mean to have an exceptional K award? What does it mean to have a medium K award? And they give you sort of real examples of what that would mean. And in addition, they specifically state all of the different ways, all the different aspects of the K awards that are specifically graded, which you can see here in the yellow box under the K. So it's the candidate. So your experience, your record of publication, maybe even other grantsmanship, your career development plan and goals, what are your short and long-term goals, how are you going to get there, your research plan, which has to be tight and doable and not overly ambitious for the K award budget and time frame, your mentors, so not only their relationship with you, but their own success in mentoring other people and their own success in grantsmanship, and then also the institutional commitment to you and the environment. So usually there's a letter from your program director or your division chief that specifically states that they're committed to you having all of this protected time to do this research and also to providing the environment you need in order to be successful. So all of those areas are actually separately scored by the reviewers, and then there's an overall preliminary impact score which determines whether your grant is going to be reviewed in person at the study section. And then among the ones that are actually discussed at study section, there's an overall impact score and a percentile ranking, and then this is basically sent to you as a summary of the discussion. And so now you get a score. And so what happens next, right? Because it's not like, when you get your boards back and it says pass, fail. This is just a score, and there's more process and weighting that occurs. And so which awards are actually awarded depends on lots of things. It's not just the strength of your application, although that's very important. So it's the scientific merit in your score and percentile, but also the specific considerations of that program or institute and the availability of funds. So in a year where, somebody in our government proposes slashing the NIH budget, maybe we're actually going to have less funds available. And for people that have scores that are on the margin, it can make a big difference in terms of whether you're going to get funded or not. And all of these decisions take time. The one thing that I'll say is that it's very useful when you receive your scores and your comments to call your point of contact within your institute and discuss what it means. Usually they can give you some insight into where you are in terms of how likely you are to get funded, should you reapply, are you golden, your application was perfect. What were the elements of the discussion that happened in the room that are actually articulated in these documents that are sent to you, and it's incredibly helpful. So here are just a few resources of websites that are available to sort of guide you through this process. Again, this is all just Googleable. You know, there's no rocket science here, but there are a lot of instructions for all of these different aspects that are very helpful. So how does this fit into your actual job? Because this sounds like a job in and of itself, right? And most of us don't show up at our first job with an NIHK award. Some lucky people, or maybe smart people, do, but most people don't. So what do you have to look for in the interview trail? So a track record of success in mentoring other people, a mentor that might be a good fit for you, a department or division that is committed to having people in a research track that are going to be protected, and that might even have a completely different track from some of the other clinical or educator pathways. It's never too soon to start applying for things, even pilot awards. I think even if you get a small pilot award in fellowship, it's a nice way to demonstrate that you're committed to doing this and that you know how to write and you know how to transmit your thoughts in that way. And know what the expectations and benchmarks are going to be for you once you get there. So this is actually a paper that was written about academic GI centers that's in a GI journal, but I think it sort of broadly applies. This was a survey that went out to GI division chiefs at academic centers that just sort of asked, how many of you have research tracks? Right? So it's not everybody. These are academic centers, and only about 60 to 75% of people even have a track where people are sort of purposefully protected for research. When you go in and you're negotiating your first job and maybe you don't already have all this funding, how much time should you ask for, right? So they actually asked these division chiefs that. And I think, interestingly, about half of them said that if the person is on the research track but don't already have extramural funding, that about half of them would give them 50, 60, or 70% protected time up front. But the question is, for how long? So how much time do you have until you get funded before you have to go into a different clinical track? And most people here said 3 years. I would say 2 to 3 years is minimum, especially if you're going to a new institution to sort of get all your mentorship together. And then LICOP, the Liver Intestine Community of Practice within the AST, actually we just completed an early career survey. So this again is specific to hepatologists, although I think there's a lot of overlap here. Where we surveyed everybody that passed the transplant hepatology boards between 2014 and 2018. And we had about a 50% response rate, which I think is pretty impressive. So 122 individuals replied in 9 UNOS regions. And we divided, just for the purposes of this, people into people that were in university hospitals, but that had predominantly clinical jobs, so less than 50% research, no grant funding. People that were in non-university hospitals in clinical jobs, and then people that were specifically hired for research. So they had at least 50% protected time or had significant funding. Just so you know, this whole analysis is going to be presented at the liver meeting in the fall, just as a little plug, not only as a poster, but actually we're going to present it at the program directors meeting. So if you want to hear more about that, we hope to have a good discussion around it. And this is just briefly the results of that. So for the most part, everybody was in their 30s. In terms of year from training, it was somewhere between 2 and 5. It's interesting, in the research track in particular, about 60% of people that responded stayed at the institution where they trained as fellows. And I think this is sort of common because you need some momentum going into a research career where you're going to be applying for grants, but it certainly is not required. And most of them were in relatively large programs. So the mean number of transplants per year in the programs that researchers went to was 120 for liver transplantation. And then what about the other parts of their jobs that they negotiated? So how many of them participate in research? Obviously 100%. What percent protected time was the median? It was 50%. So, you know, it's not quite the 75% NIH requirement, but it's pretty good. But the IQR was from 20 to 75%. Half days of protected time, the median was 4. 23 out of the 35, or 66%, received startup funds when they were hired for research purposes. 66% had salary supports from research funding, and they had less educational administrative responsibilities than their clinical counterparts. So just to close very briefly, other words of advice. So this is the advice that was given to me when I sort of surveyed the people at my institution that I think are the most experienced mentors of K awardees, and just asked them, if you had one sentence to say to this crowd, what would they say? And this is what they said. They said mentor, 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 incredibly important. Time, time, time. I actually think mentor and time is like 90% of the way there. No one gets all of the grants that they apply for funded. So be persistent, reapply. Almost no one gets their first grant funded. And even the most successful people get denied their funding all the time. You'll be making more than you did as a fellow, so try not to focus on salary. I think we all have to take that as, we have to be realistic about that. The perfect job is in the eye of the beholder. And if you want to do research, you have to be hired to do research. This is pearls from people that I know in transplantation that have K23s. So study what you have a lot of, ask questions that matter both ways, whether the answer is positive or negative. Understand why you're doing this work, seek mentorship outside your division, enjoy what you're doing. And even though some people may tell you you have to focus on only one disease, maybe you can focus on an actual methodology or process instead and have that what you become synonymous with, and then can apply it across other disease processes. And just to close, this is my take. What would I do? The same. I followed my passion. I like to collaborate in a network. It's really important. I applied to many, many grants over the years, many of which I didn't get, and reapplied when I felt that I could make the grant even better. What I wish I could do differently is focus more, write more, learn to say no to things if you can, even when you're young, that you think are outside of your real mission, and really understand your benchmarks at your own institution pretty much right when you arrive. So good luck to everybody. This is a very exciting time in your career, and if you're thinking about doing research and grant writing, this is a good time to start. Not everybody writes grants for the rest of their lives, but it's really an incredible learning experience, and good luck with your jobs.
I will have to say that is inspiring, and that very interestingly, program directors were willing to give time, and were willing to give years of time for people who are interested even in the absence of funding. I think that LICOP survey was incredibly informative, and that is as well a very informative talk. Thank you very much, Betsy. So our next, so any questions? I didn't see any questions pop through on the iPads. Either it's non-functional offline, or there's not any questions. Any quick questions for Dr. Verna?
For the K-12, is it individual initiated or institute initiated?
K-12 funding, is it to the institute and then to the individual, or is it to the individual then to the institute?
Also, you're competing only against people in your local institution. Does that make sense? Did everybody hear that? Yeah.
So you write the application for K-12, not the institute?
The institution has received the funding from the NIH, and then it is the review committee for your application. And usually it's basically the same documents. Yeah.
Okay. All right, well, thank you very much. So we'll move on to our second speaker of the afternoon. This is back and better than ever. Dr. Nicole Turgeon is going back to the stage here. She's, again, the surgical director of the newly formed program at UT Austin, and the past chair of the UNOS Kidney Committee, and will give us some ideas about how to get involved, what UNOS infrastructure is like, how individuals can get involved in UNOS. Thanks.
All right, so we're going to shift gears a little bit, and I thought it would be important to start really talking about what UNOS is and what the components are, to have a really good understanding of how you may want to get involved in the future. But in general, also when you hear about policy development and there's a regional meeting and there's a new policy out there, what all that entails. So we're going to start with some definitions, And I think NOTA, the National Organ Transplant Act, is the first one that we all need to understand very clearly. That is a federal law that was passed in 1984, and it was meant to prohibit the sale or purchase of organs. Very specific in that regard. And so it did have two major establishments. One was the OPTN, which is the Organ Procurement and Transplant Network, and the second is the SRTR, which many of us are very familiar with, the Scientific Registry of Transplant Recipients. It also established the OPOs, the Organ Procurement Organizations, and as I mentioned, that was really to prohibit the sale and purchase of organs. So the next step was the OPTN final rule. So this is an actual federal regulation which builds upon NOTA. And it sets up many different components that are important for us to understand as to how the OPTN works and what it means. So it actually established the structure and function of the OPTN and how the operations are supposed to happen. It also directs the OPTN to establish a board of directors. And it specifies actually who are the people who are supposed to be on those board of directors. So there are some significant limitations. Every once in a while I'll hear, well, why aren't such and such on the board of directors? It's because of this. It's a federal regulation that establishes who needs to be on that board. And there's an executive committee which appoints an executive director as well as establishes other committees that are necessary within the structure of the OPTN. And then there is a particular process to have OPTN membership as centers. And there are also processes for if you are a member in not good standing. There are appeals and all kinds of processes that are a part of this as well. So these are not just things that the OPTN or UNOS thought up. This comes from the final rule. So what is the final rule? We've heard a lot about it in the last year or so, especially with the liver allocation and geography distribution conversations. And so the OPTN is directed to develop policies that are compliant or consistent with this final rule. And these are the elements of the final rule. They're based on sound medical judgment, to seek to achieve the best use of donated organs, avoid wasting of organs, and promote the efficient placement. This is something that's come up over and over again in our talks about geography. Set candidates' priority based on objective and measurable criteria. Do not base access on a candidate's residence or place of listing, which is probably the one that's been given the most emphasis in a lot of these geography conversations. Distribute organs over as broad a geographic area as feasible, again within that same category. And then orders candidates from the most to the least medically urgent. So I guess one of the challenges that we've had in a lot of these geography discussions is we seem to be focusing on a couple, and then we may be actually prioritizing those, but there is no priority in the final rule as to which one is most important. Again, the top one I think is what's most important, sound medical judgment. How can we develop policies which take into account all of these important elements of the final rule so that we're compliant with them, but how do we use sound medical judgment to do that? And so again, the final rule is to give us direction on policy development, and we really have to provide an opportunity for our members, which are the community, to provide comments on all of those proposed policies that we are developing within the UNOS committees. And once those policies are developed or adopted, those have to be out for the available public to see them at any time. So they're up on the websites. They give lots of different communications to centers about the policies and how they'll be enacted. It's interesting, there are very few changes to the final rule, and these two are the most recent examples. The VCA, vascular composite allografts, is now included in the definition of an organ, and so that was an important change. And the second one was the use of HIV-positive donor organs, and many of you have heard about the HOPE Act. So that was an important change as well. But you can see, this was since when, 1994 or whatever, 2000, and these are the two changes that we've had since then, and they're fairly recent. So it's not a common practice for us to go and change the final rule. And because it is a federal regulation, and NOTA is a law, it takes a lot of effort to do that. So there must be compelling reasons why we want to change the final rule. It's not just a willy-nilly thing that we have a better idea and we want to go ahead and do that. It has to be compelling and something that's really changed the field and we feel is necessary so that we can move forward with what our goals are as a community. And so these are the bylaws for the OPTN. It outlines, as I mentioned, the membership requirements and the process for approval of a transplant center or an OPO, and also how you can appeal membership decisions. For example, if your program was meant to be have outcome issues, you can appeal that if you didn't agree with that. It establishes, again, the board of directors and the process by which we go and do policy development as well as bylaw development. There is a contract for the OPTN. Many people may not know that. And every 5 years, this contract is up, and it's an open call where others can see if they want to go for the OPTN contract. And it is renewed and runs with the fiscal year. And there are modifications that can be made within this contract period as it's renewed every year by HRSA and others in government. And so that brings us to what's the difference between UNOS, because we talk about UNOS a lot, and OPTN. So UNOS is actually the private nonprofit organization that manages the OPTN under contract with the federal government. That's an important distinction. So UNOS does all of that work. They also do other work. So some of the research work they're doing and the initiatives like the COIN project or organ acceptance projects that are now about to go under pilot, those are UNOS projects that are separate from the OPTN contract, but they must maintain what their commitments are to this OPTN contract. So does everybody understand that? Because that is a little bit of a nuance, which confused me for years until I started really being involved in UNOS. And so they're often used interchangeably. You'll see UNOS, OPTN, because many of the initiatives are kind of consistent with each other and are the same. But every once in a while, you might see something that is a UNOS-only product, and that's what that means. So how do we develop policy? And these are things that you can start thinking about. What are the ways that I want to be involved in policy development? Do I even have any interest in that? Some people don't. You know, they want to do basic science or some clinical science, get K awards. Other people are really interested in how we can improve our current policies and move our field forward in that regard. So from start to finish, I think you need to understand what happens in UNOS and who's involved, and then make decisions for yourself. Is this something that I really want to pursue? So there are several standing and ad hoc committees, and the structure of this was considered to change a couple years ago, but for now, these are the current committees. There are about 21 of them, and I'm not going to go through all of them all, but you can see it really represents our constituency, all the way from the pediatric group to ethics and data support, DTAC, as Marion was outlining yesterday in her talk, membership and professional standards, which is some of the things we don't like to talk about so much, but when we have outcomes issues or just discrepancies that we need to address in a committee. Minority affairs, all very important topics that are all composed of people from individual regions mostly, except for some of the ad hoc committees. So there's regional representation on all of these committees. And then there are patient representatives as well. And oftentimes, like for example, in the kidney committee, we have coordinators because we feel that that's very important to have a coordinator perspective. And other members that are essential to policy development and we need at the table when we're having some of these discussions. And each committee has that sort of grouping. The other thing we really try to do is, besides having the regional diversity, have ethnic diversity, have gender diversity, and really represent all of our patients and our staff in our various institutions. To give you another level of understanding is how the boards and the committee structure works, who reports to who. Because I think a lot of people are like, UNOS is this big body and they just do stuff. And the reality is it's very much composed of us. And there are some people, like the executive director, that are functioning for UNOS, and there are liaisons who work with the committees that are UNOS employees. But we're the people in the committees who are coming up with a lot of these ideas and working through the policy development and using our sound medical judgment to get to the next step in policy development. So there are some organizational structures that need to happen in order for all of these changes in policy developments to be made. And so at the bottom, you can see the standing ad hoc committees that I was just referring to. Then they report up to what's called the Policy Oversight Committee. And so that committee is actually, and I'm vice chairing that now, so I have a little bit more insight into that. That committee is composed of all the vice chairs of the individual committees that are in the standing committees. So they kind of report up in this Policy Oversight Committee. There's a chair and a vice chair of that committee who then report up to the executive committee. And what the Policy Oversight Committee does at this moment is kind of see if these policies are in alignment with the final rule, make sure we don't have any big constituencies that we haven't addressed or talked to about these policies. Are all the stakeholders aware and participating in the policy development? And then more importantly, the directions changed a little bit with the Policy Oversight Committee. Are we aligning our strategies and goals across the different organs? Are we all doing different things that don't actually make sense? Can we come to a place where we're all working on geography together at the same time? In aligning what we do and learning from each other rather than having one person do something and then 6 years later another group do something else. So that's really kind of what the direction of the Policy Oversight Committee is, really giving direction to the committees in the future. And then the Policy Oversight Committee will reviews policies, recommends it to the Executive Committee, and then that will then go up to the Board of Directors. Now there's also a nominating committee and a corporate affairs committee, which is more technical and we don't have a lot of involvement in as committee members. And then there's also finance and IT advisory. But just so you can see where we fit in our policy development and in our committee structures. So a lot of people ask, well, how do we develop policy? Those policies that you come up with are just ridiculous. There's so many more important issues that we need to address. I have a good idea. I always bring up ideas. No one ever listens to me. These are the things we hear over and over again. And so the reality is there are 1,000 million trillion ideas. But what ideas are going to then translate into policies that we can actually make changes or improvements to what we do today? And the reality is it's hard. So a really good example, I think, right now, and we've discussed many times in the Kidney Committee, is discards. How do you wrap your head around all of the different things that go into organ utilization, organ discards? It involves OPOs, it involves, transplant centers, it involves patients. There's so many aspects to it. And there are so many stakeholders doing projects on it. So there's the COIN project, then there's a task force, in ASTS. And so we as a committee every 6 months have talked about how do we incorporate that idea, what is our idea actually, because we didn't really have a policy development idea, into a policy that's meaningful that will affect change in the environment where we're still making a lot of adjustments and learning and doing a lot of research. So that's an example of a more complex one. Another one that came up was we don't want to use KDPI. That's not as good as KDRI. We should be using KDRI. Okay, that's great, and it's probably very true, but is that impactful, right? Is that going to make a big difference down the line in what we do every day? And that's going to spend a lot of time for us to do research, go out to public comment, get people's input, make IT changes, when we could be really working on maybe discard rate or geography or whatever else it is. So just because you have an idea, and it may be a very good one, doesn't mean that that idea will then go on to policy development or in the policy of your committee. What does happen, though, is all of those ideas get put in a bank, and then we revisit those, and then things rise up and things rise down, just based on what the climate is and what's happening in the community or your organ-specific area. So you have an idea, it then goes to problem analysis, and that is some basic research that we can do to say, is this really a problem, or is it really a good idea? Sometimes some of the projects die right there. We learn that, guess what? It was a perception, not a real problem. And then we move along. Other ones go right next to the project approval, where it goes to the Policy Oversight Committee. They say, yep, great idea, you got all the right people, the stakeholders are identified. Then it goes on to more evidence gathering, so a more detailed overview and research, and work with SRTR to get some of the data that you need. Then from there, you'll go out to public comment. Now, some policies require going to public comment more than once. For example, geography. It went out for a concept overview, and then it went out for a true public comment policy proposal, and then it may go out again, I don't know. But sometimes you need to get more input from the community, and you learn things as you go out for public comment that you might not have thought of when you were in your committee. So you'll go out for public comment, you will review that as a committee, then you'll go back and say, are we going to support this as a kidney committee or any other committee and move forward and bring it to the board, or does it need to go out again? And so once it gets to the board, then the board has to vote. And you as the chair will, if you get to that part in the policy group, will have to present that to the board, which can be a bit scary. It's a bit like the United Nations. It's a big U table, and they're all got microphones around, and they're firing questions at you. So it's a bit of an intense situation. But once that gets to the board and they approve it and vote yes, it gets implemented, and then there's a lot of IT involvement in many of these projects, not all of them. So it can often take 6 months to a year from when it's approved at the board to when it actually is implemented. And every single project or policy has a post-implementation review where you're looking at specific data to make sure that you didn't miss anything, or there isn't anything really bad trending, that you need to change course quickly and make adjustments. So all things that are kind of in our minds as we're implementing these projects. It's not like you just implement it and then say, okay, we're done. You have to keep evaluating. And so where do all of these ideas come from? Many places. Most of them come within the committee. But sometimes the board of directors or the president at the time will give us ideas. Sometimes we'll get them from what we're hearing in the community or at our regional meetings. Some of the professional societies will bring things to our attention. Or we've heard about some new technology or something exciting that we really want to pursue. And most recently, we've had some government mandates that have asked us to do things. So that's really where our energies have been focused. When you get a government mandate, like we recently did for geography, it was such an overwhelming project. As I was mentioning when I was giving the talk yesterday, we had to drop all of our other projects to just do this particular project. So it can be very time consuming. There are 5 strategic goals currently, and these strategic goals are set by the board. And the first one is to increase the number of transplants. The second is to provide equity and access to transplants. The third is to improve the waitlist of patient, living donor, and transplant recipient outcomes. And the fourth, to promote living donor and transplant recipient safety. And lastly, to promote the efficient management of the OPTN. So we are asked to put all of our projects into these 5 categories, and the board and the executive committee look at the distribution within those categories and try to make sure that we're not over taxing one area more than the other. The emphasis, though, I will tell you, in the last 3 to 5 years has been to increase the number of transplants, and so you can see that's why the majority of the projects at this particular time were in that category. So just to speak a little bit about the problem and identifying if your idea is a problem or it needs to be addressed, you really need to stay focused on what the problem is and not the solution. It's important, though, and I say this as a caveat, to think, is there a solution that we can get to? Because if you can't, then there's really no point, even if there is a problem, of moving in that direction. It doesn't mean that you should have the exact solution or what you're going to do in mind, but know that there is a possible solution for what you're trying to achieve. And, things to think about. Is the committee's perception or the community's perception accurate? I can share with you that there was a perception largely about pediatric access to kidney transplantation under CAS. Turns out that some of the perception is actually not accurate because we got data to support that. But even so, we need to get the data to kind of say, hey, this is actually what we have, and now it's not really about access, it's about what we think as a community is the right thing to do, which in the end is to give our pediatric patients more access to transplantation and move them up on the priority in the sequences. So that's what we ended up doing, as I mentioned yesterday. Who's impacted by the problem, how severe is the problem, and what is the root cause? And so our efforts are really focused on consensus building, not only within the committees themselves, but out in the community. And that has been a little bit challenging currently, and I think, you know, geography is a difficult topic. It's kind of moving people's cheese. So when you do that, people are going to get a little bit more, I think, fired up and defensive and really want to take care of their patients in their areas. But it shouldn't be at the expense of other patients in other areas. So things to think about in consensus building. We really work with SRTR very closely. HRSA has insight and input into what we do, and they actually are at our committee meetings. The professional societies weigh in, so we ask for their input in formal statements, both the ASTS, AST, AOPO, for the organ procurement organizations, NATCO, and others. We also sometimes reach out to community experts that we know are specifically interested in our area to get their input, and board members also give us a lot of insight. And then we talked a little bit already about public comment. Just to be aware that there are 30 days for public comment to review the changes. And then, as I was mentioning, the committee decides whether or not we think it's the right thing to move forward with going to the board and asking for their vote on the proposal. Sometimes there are things that are very expensive, and so that can be extra data collection with the SRTR, IT cost of implementing a particular policy, more member burden for doing the things that are proposed in the policy. So these are all things that are considered by the board specifically, and you know, the committee as well, but people who are experts and know what these costs and burdens are. So the board does approve policy, large programming for IT, guidance documents, white papers, and data collection. The board doesn't need to approve manuscripts that come out of committees sometimes from some of the research, instructional events, and small system enhancements. But there is input that's still had in all of these activities from the committee level in general. And so when as I was mentioning, the policy is approved by the board, there is a policy notice that goes out to all of the transplant centers in the community through the website, so that people can prepare for the policy and do all the things they need to do at a programmatic level to be ready. So just so people are aware, there are 2 cycles of public comment. Not everybody may be aware of that. The first board meeting is in June of the year, and then they're going to have one in December for this fall cycle, or they call it summer cycle now, that just happened. So we'll see what policies are going to go forward for board proposal coming up in December. And I wanted to talk a little bit about the member compliance with policy. So this is another thing that confuses people a little bit. The Membership Professional and Standards Committee, as I mentioned earlier, as a committee, they review the membership applications and make recommendations to the board, and they monitor compliance and performance. So they also conduct a due process activities with members. Members can sometimes appear in front of them if there is an issue at their particular center. So these are things to be aware of when you hear of like MPSC. For me, for a long time, that floated in my brain. What does that mean? What do they do? This is actually what they do. It's a really difficult job and very time intensive, but this is a committee that you can serve on if you're interested in these types of activities as well. And just to be aware, this is how the review process works. Oftentimes there's an inquiry or somebody is concerned in the community, then that member is allowed to respond. There's a review by the MPSC. There's an informal discussion with the MPSC, and then a more formal one where they will appear at the meeting in a hearing, depending on if they need to go that far. And then if they need to go in front of the board, they will. It just really depends on what the inquiry is about and how egregious or not egregious it is. And there are adverse actions that can take place. There's probation and membership not in good standing. So these things are items to be aware of, and they do come out of the MPSC meeting. So I just wanted you to be aware of those as well. And lastly, the board of directors structure, because there's often a lot of questions about who are these people on the board. And there are actually 42 board members. They're all elected by vote by the OPTN members, and approximately 50% of them must be transplant surgeons or physicians. 25% must be transplant candidates, recipients, organ donors, or families. And then the others that are represented are major stakeholders like the OPOs, coordinators, HLA professionals, pediatric specialists, non-transplant professionals. And then the immediate past OPTN president is automatically a member. And then each of the 11 region elects a counselor. So if you've ever been to a regional meeting, you'll see your counselor sitting at the front of the room and sort of running the meeting, making sure everything flows and doing the proper voting techniques and all of that. They are at the board meetings as well and vote on behalf of the regions. And then the members that are there are members elected to 1, 2, or 3-year terms depending on what their post is. So with that, I'll entertain any questions and really just encourage you, if this is something you're interested in, to apply for some of these positions once you're on faculty for your institution. You can represent your institution, but also for your region. These come up yearly. The UNOS OPTN website will send out a call saying Region 3 or Region 7 or whatever has these posts available. I encourage you to, as you would for a grant, apply 1, 2, 3, 4, and 5 times. You just never know. They really are interested in having a lot of what they call young blood in the pipeline with new ideas. So don't be discouraged if you don't get on a committee the first time, but really, if you're interested, keep trying. You will get on a committee. It may not be one that you're super excited about at first, but once you show interest, do a good job, you'll certainly be called upon to be in other committees. So with that, that's all I got.
Any quick questions from the audience? I will just give a little roadmap. I think that every institution has representation at the regional meetings, which means there's twice a year that people usually attend in-person meetings to hear what's happening in their region. And while representatives from your hospital will always be there, maybe your surgeon-in-chief or maybe your administrator, that doesn't mean that you can't go if you make a personal effort to go. It might be on your own dime initially, but to go and attend and learn from those meetings. And then, know what the issues are. If you become interested in those policies and those differences, lung allocation, kidney, heart, all changed. Liver, you've heard about. Geography has affected everybody. The combination organ transplant, the SLK policy, SPK policies, all of those things have happened in the last 5 years essentially. And so I think, or somewhere along those lines. So if those concepts of how you improve access, improve your patient care, that sort of thing interest you, the first thing is to attend those meetings, find an interest, find a passion. So with that in mind, the last speaker from this section will be speaking regarding clinical research and how to best approach big data, is how I phrased it, and I appreciate your willingness to talk, Dr. Gill, on how you can become successful like Dr. Gill.
So I thought I'd wait. This is about big data, so I thought I'd pitch them Peter Gabriel. Can't hear that yet. A little big time. Get us going after that snoozy UNOS talk. Can't hear that too well. Okay, there you go. All right. So we're going to talk about big data, and it's exciting, but there's limitations, and so I hope to inspire you. That's the objective. So really, this is big data. This is a playing surface, and I use the playing surface or how you get into the game, and I'm going to hopefully convince you that this is the best game in town. I certainly have really enjoyed what I've done in big data, and hopefully you'll get inspired. I have no disclosures relevant to this. So first question for you guys is, do you remember the exact moment when you knew what you wanted to do with the rest of your life? Has that happened to you guys yet? It's not now, I can tell. Well, for me, a single image changed everything for me. I'll let your mind run crazy what that might have been for me. It's actually this graphic. So this is a... I know you're a little disappointed. It's not what you thought, right? Okay. If you think about everything that is going on in this graphic, if you really understand it, I cannot believe that you will not be excited. So let's think about what's happening here. So this is from a seminal publication from Bob Wolf. How many people know this graph intimately or think they know it? Holy. How many people have seen this graph before? Okay, everybody's seen it. How many people are confused by this graph? Quite a few. Okay, good, good. So here's what's happening. On the blue line is people on the waiting list. Like 100,000 of them, like a boatload of people. They're sitting there, they're ticking, okay? And it's a time-dependent model. They're all in this model, they're sitting there, and then their risk time, as they're sitting on their waiting list, is being ascribed to that blue line, right? They're sitting in that blue line. Once they hit the transplant, they automatically shift. So my SAS program shifts them to transplant status. And then their risk status jumps into the orange line, okay? So in this graph, in real time, it's a time-dependent model. You're seeing people move from one state to the other. And then as time moves on in these people, what you're comparing, which is the relative risk in that orange line, is the risk for people who look just like the people who got transplanted. So adjusted for everything else, the model's doing all of this, compared to the people who look just like them who remained waiting. And then you move it along as a function of time post-transplant, right? And you can see how there's a perioperative risk. I don't need to point my hand. There's a perioperative risk. And then the risk equalizes, and we can actually quantify that. Look how precise that is. That's freaking awesome. And then it goes down, and people have a long-term survival benefit compared to transplantation. And this graphic was pivotal in demonstrating that kidney transplantation was life-saving, right? So there is a ton going on in this graphic. The math behind it is inspiring. The model is so elegant, right? So the interpretation is, when you look at this, you can tell, and you can do this for people with different health characteristics, and you can get a different break point, a different trajectory to that line, and you can do it with different kinds of kidneys. So ergo, you can say to a person, look, you want to get, your patient is on dialysis, they want to get to the greener pasture of a transplant, right? But there's a fence they have to get over. So you can tell them exactly how high the fence is, right? But for our purposes, this was what definitively proved that, as best we can, because we're not going to do an RCT of kidney transplantation, that kidney transplantation is life-saving, okay? So if you understand, how many people understand the graph now? Okay, more hands. Whew. Okay, cool. You can see why I'm amped about this. It's pretty cool. Anyways, so if you think about this, there is really actually no other disease state, or very few, where I said no, but there's some, but anyways. I said there's very few other diseases where we have data for the entire population from the date of disease onset. And here I'm defining disease as the date of transplant, right? That's really remarkable, right? In many diseases in big databases, you don't know how long people have had cancer for. They just kind of enter or whatever. So here we actually have time zero. And we follow them through linkage analysis, right until they die. Unless they emigrate out of the United States, you will know what happens to that person in terms of whether they return to dialysis or they die. You'll be able to capture them all. So kidney transplantation is by design, from some of the stuff that Nicole told you, really a tightly regulated system. And because of that, we've got beautiful data, right? So when you think about that, we've got data for all aspects of a patient's journey through transplantation. And I'm going to focus on kidneys, but some of this is very similar for livers. Obviously, we don't have dialysis or the equivalent in liver patients or heart patients, but you could with VADs, right? That would be cool to get that. So we get it right from their onset of end-stage renal disease while they're on the waiting list. We can get data about organ donation, how it's allocated, the use or non-use. I don't like the word discard. I think we should call it non-use. It's not good for our donor families, even though it appears on my slide. Maybe we'll get rid of that next year. We have intimate data about the transplant procedure itself. If you go into the registry, there's tons of variables that tell you everything about what happened. You know the medications, at least initially, and the only reason we don't have them for the entire duration of the transplant is a data burden. There's medical and surgical procedures that we know that happen to our patients after that you can get from billing codes, and you can obviously get long-term outcomes, right? So it's an amazing amount of data for you to analyze, and it really tells us about the health of the system in an unprecedented manner compared to any other country in the world, in fact. So transplant's unique, but also the US system is unparalleled. Importantly, big just got bigger, right? So you guys have heard in this talk that now where the world is moving is not just in standard sort of registry demographic type data, but now we're including laboratory data, we're including molecular markers in this. And the French guys, I keep hearing how the French guys are kicking the crap out of us with getting all this great data into these big data systems and their genetics. Michael Mengel's all amped up about it. It's so the thing is it's an exciting time where we will have this artificial intelligence. We've gone away from hypothesis-based medicine now. We can go into pattern recognition-based medicine, right? So it is an exciting time from a big data perspective. So I put this up in terms of tolerance, right? In case any of you guys are thinking of doing tolerance research, right? So why do you want to do tolerance register, right? It's things like, maybe I want to get into that game. And I'm going to say that big data is so much better than that. If you think about your average guy who's doing tolerance research, my God, we should know, we should celebrate our goals, but we don't even know when we score. We don't even know what a goal looks like, right? So why do you want to get into this field? This is pathetic. You don't want to do that. You want to do big data. All right. So where's Rob Fairchild? He's not here. So here's some of the things I'm going to talk about. So the data system in the US and how to obtain data, I'll tell you a little thumbnail of that. Strengths and limitations of using the data and what you should consider if you're thinking about a career using big data. So first, a little bit about the system, and this comes up. So you've already heard about the OPTN, right? So you guys know what that is from Nicole's talk. OPTN is managed by a private nonprofit, which is UNOS, right? You heard that from Nicole as well. Data submission is importantly mandatory in the United States. It's voluntary in Canada and Australia and other countries. It's mandatory in the United States, right? So that's good from a data guy's perspective. You've got data, right? So that's important. And importantly, there's two entities that have government contracts, and they're meant to really be arm's length from the system, right? They're sort of the people that are sort of doing the analyses on how the system is performing. And there's two of them, the SRTR and USRES, and they bring in other data sources, they validate sources, they link data sources, but more importantly, they make standard analysis of files available for free to you and me if we want to use them. Free, right? Not $8,000 like Betsy had to spend on those markers that she was doing. You get them for free. So obtaining the data, you have to have an analysis plan, right? So you can't just say, oh, I'm going to do something. You gotta spell it out. It's got to be scientifically valid. But to be honest, they're mostly concerned about data security and those sorts of things. They're not going to sit there and say, oh, this is a dumb idea. They're not going to tell you that. They're just going to look at it from their requirements. The basic files are free. Research is intended for publication, that you have to send it to them to be reviewed, and mostly they're checking that you've put in the appropriate disclaimers and again that there's no privacy. You can't report less than 10 outcomes in any one population. Those are the kinds of things they're looking for. They're not looking otherwise to critique your data. You're responsible for the security of the data, so you can't just pass it around to people on the street. Now, when we think about registry data versus RCTs, importantly, both of these are valuable, right? But you have to sort of think of them in terms of big ticket. If you think about a registry, it's hypothesis generating. I told you guys in the living donor talk that we can't prove causality for anything in observational data, right? RCTs obviously can test hypotheses that are generated in observational studies. But importantly, we can determine real-world effectiveness of things that may have already been tested or demonstrated in a nicely, tightly controlled environment, right? Like, Beppe Ramuzzi, everything works in Italy, right? But does it work in the United States? So you can determine real-world effectiveness versus efficacy, and that's an important difference. And importantly, registry analyses can be fast. They can be efficient, whereas obviously RCTs, I'm trying to do one right now, I think it might kill me. It's slow and painful. So in terms of some big things that you should understand is this bias, right? So when you think about registries and RCTs, there's often hidden selection biases within registries. And their differences with RCTs is that you don't have hidden selected biases, but you have a generalizability problem. Who's in the trial and are the results? So that may be bias in terms of a different type of selection bias. It's not a hidden one, it's an obvious one. There's limited loss to follow-up in a registry, as I told you, but there's loss to follow-up. As you know, for some of our drugs, 60% of the patients will discontinue therapy during the RCT, right? It becomes very difficult. Capture all patients, and then RCTs may have limited external validity. So let me give you an example of what I mean by a hidden selection bias, right? So on the one hand, you may say, well, we've got every single patient, Dr. Gill, in the US registry, and so how can there be these hidden selection biases? Well, it's because we do and don't do things in certain patients, right? So if you want to examine an association, let's say, between donor age and the risk of DGF, you're going to account for confounding variables that you have in the data set, like cold ischemic time, like whether the kidney was pumped or not, whatever. But there's also a hidden bias that you have to understand, and that is you can only count the beans that actually got done, right? So there's an upfront selection that you might not be aware of when you start your analysis from the time of transplantation, right? So that's a hidden selection bias that you have to be aware of when you do these types of analysis. So clinical input is essential in designing these trials, right? You can't just have a statistician go off and run them. You have to be there working with your statistician to make sure that you're asking clinically relevant questions. Importantly, right, big data gets a bit of a bad name in part because some of the non-research applications, right? These are things that it wasn't necessarily intended to do. And some of them are for regulatory oversight and safety reasons, right? People have big issues, right? And it's not that the analyses are limited, it's just that the data input that went into them are limited. And so people have issues with some of the parameters or yardsticks by which their performance is measured. But they are essential for ensuring public trust and transparency in the system, right? You guys should be highly impressed by the fact that everything we do, more than any other branch of medicine, is dependent upon the transparency and trust of the public in the transplant system. Nothing happens without that. So it's essential for that. As you've heard, it's essential for informing health policy, organ allocation, minimizing disparities, inequities, and access to transplantation. And importantly, as you've already seen, we can very quickly assess the impact of policy change by looking at the entire system, right? When you change CAS, you can see that quick uptake in transplantation of that bolus effect of highly sensitized patients getting transplanted. So it's very powerful for those types of things. Now, what are some of the types of studies that you can do with big data? There's epidemiological research, outcomes research, and health service research. I'm just going to give you a couple snippets here at how powerful some of this stuff is. So when we think about epidemiological studies, we study the occurrence and distribution of disease and health-related conditions. These tend to be descriptive studies that define incidence and prevalence of disease, but importantly, you can look at if we're getting better in the system over time, right? So secular trends are very, very important. And you can do analytical studies to identify risk factors and novel risk factors. Some of those things that you can really harness is you can follow two mate kidneys and you look and see what happened to one versus the other, and you can get identify non-traditional risk factors for graft outcome, for example. And I'm a kidney guy, so I apologize to those non-kidney people. But this is an example of that, right? This was a very, very powerful, very simple study which really described how important this entity of new onset diabetes that up until then we just heard about from some drug companies. And this is using claims data, right, to identify people who weren't diabetic before transplant, who now were after a transplant. And this was really important data in terms of informing a change in how we think about immunosuppression because of this complication. Now, in terms of outcomes research, here we're studying the outcomes that I tend to focus on things that are relevant for patients. Graft survival, I gotta talk about it, graft survival and quality of life. So the types of studies that you can do, we've already seen a survival benefit analysis, but we can also look at the determinants of allograft survival. Sorry, I guess I can't wander from this thing. And this is a really classic study, right? This is from Bruce Kaplan, which just shows you that when grafts fail, You may look at that graph and go, duh, when graphs fail, people do badly, right? But what this said to the transplant community is we're still responsible for the outcome of our patients after the transplant fails. That's what was important about this study, right? So the messaging of these graphs is also very, very important. We recently did this. I'm just going to show you this as a cool application, right? So this is the pivotal 5-year study that Steve Whittle did of rapid steroid elimination in low-risk kidney transplant patients, right? And he reported data out to 5 years. So this is what he showed you. And so what was really cool is Darren Stewart and myself, we could go back and track every single one of these people that were in this trial, and we can find them actually in the UNOS registry, and we can update these graphs out to 15 years. So you can take studies that have limited, and I think this is perhaps something that's exciting for us to reinvigorate interest in clinical trials, because we can harness the power of the registry to get more out of them, okay? So that's an interesting example I just showed you then. What about health services research? So here we're studying how we deliver care and the impact of our quality of our care. We can look at things like access to care. We can look at interventions. We can do cost-effective analysis and qualities. And we can look at geographic variation and things. So this is about how we do things and can we do things better and whether we can afford things, okay? This is the type of things. And so this is a study that my fellow Matt Kaditz did, and he's just finished his thing. So you can do these types of things at a fellow. This was the highest impact publication from a clinical perspective in HAT, and a fellow did it. I helped him a little bit, but he did it. And so what you're looking at here is a cost-effective analysis. This is of treating people with hepatitis C, accepting a hepatitis C. We all know the science of this, but this is the math of it, of whether it's effective for a payer, right? And so basically you're looking at QALYs along here, and you're looking at cumulative cost in Canadian dollars here, but it's the same in American dollars. And basically what this shows you is if you treat somebody with hepatitis C and you're comparing that to remaining on the wait list and getting a non-hepatitis C kidney within a year, it costs a little bit more, but it's well within the pay threshold. It's only 5,000 odd bucks. But if you, but it's dominant, i.e. it's cheaper, and it gives you more QALYs compared to staying on the waiting list and waiting for a non-hep C kidney for 2, 3, 4, or 5 years, right? Very simple graphics, but very powerful stuff that we can get from micro-costing data that's available in the database. So kind of cool. Anyways, enough of that. So how can you get into the game? I told you I was going to come back to the game theme in this. You need to invest, right? These are complex data sets. They take a long time to work with, and you have to use them and get familiar with them. But it's not impossible. If I can do it, you can do it. You need hands-on experience, so you need essential training. So you do need to know how to program. You need to have basics in epidemiology, biostatistics, and so forth. But that's not an arduous thing. You can do those either as full-time studies or as part-time studies in parallel. But you can get lots of hands-on experience in working with the data while you're doing the training. So you really, it's a steep learning curve, but you do get to a different place after a couple of years in terms of your expertise. And so I'm going to leave you with this. This is Michael Jordan. I've missed more than 9,000 shots in my career. I've lost almost 300 games 26 times. I've been trusted to take the game-winning shot and missed it. I've failed over and over and over again in my life. You can probably add a few more overs for me. And that is why I succeed. And so there's supposed to be one more slide on here. There's supposed to think that what big data does, it gives you the opportunity to take a lot of shots. Okay, that's it for me. Oh, there it is. Yeah. See, I thought I'd failed in making my own slides. All right, we're done. I will just note for the other speakers that I've made up time and we're back on time. All right, thanks. No questions? Okay, good.
Well, I think really importantly, within the conversations that we had this morning for career development discussions, one was, John, I want to keep you up here, actually, is the importance to say, yeah, you're applying for a job. You're going to be, maybe you're a neophyte in terms of training. You've done your clinical work and you're going out to get a clinical job. But the opportunities still are there within a clinical position to gain some of these skills. When you talk about formal training, formal training, mentorship, statistics, what do you think the formula is for somebody in their first position who wants to take this step? Like, what's the...
I honestly think that, so the question is, well, why do you do this, right? For me, it keeps me interested, right? It really, throughout 20 years, how am I not going to get bored, right? So being in the game is a lot of fun, right? But I think what really, everything starts with a great question, right? So if you, like tons of people have got big data, they got it sitting on their thing and they ask, in my opinion, dumb questions. And the reason you ask good questions is because you have to be in the field in meetings like this, interacting, know what the clinically relevant issues are, the relevant health services questions are, and you have to read a lot, right? And so what I think makes this really exciting is when you come to something and you say, hey, I've been thinking about this, and you talk about it with, I'll often do this. I'll come talk to Alex and say, what do you think about this? Or I'll see Jesse Scholl and say, what do you think about this, right? And we'll kick it around and people say, yeah, I tried to do that. There's this. So the community is small enough, right, where you can do a preliminary analysis, show it to people in this kind of thing and say, what do you think about this? Should we run with this thing? Does it have legs? Is it something that's interesting? But I think what really the secret to success, honestly, is to start with small things that are feasible, because you need to get your confidence in times of doing these analyses, but then really pick carefully good questions. It's the same basics of any research project, right? You don't want to do a Me Too analysis and just show that, okay, that still applies or whatever, right? But some of these analyses, you know, that happened 20 years ago, these paradigms that we believe, they need to be updated, right? Some of these things need to be updated. So there's some things that, you know, need to be like the brilliant new idea. They need to be demonstrated in the current environment. You just need to know what those are. So there's tons of questions that you can answer this, but I would say it always starts with a good question. Okay.
Okay, so we are 15 minutes away from our next session, so please take a break. At 4:15, the breakout sessions will start. Refer to your program guide for where to go, and those will last until 5:45 or 5:30 or so, and then you'll break and regroup for some fun outside. Thank you.